你们重新弄一下。我好像听不见我讲的。这个抖音平台上得去吗？好嘛，这个抖音也是他的。
可以听到，抖音可以听到。
可以吗
？Excuse me. We cannot see. Now we can see you. Do you hear me?
You can see me now?
You hear me?
Can you hear us?
Can you hear me?
Can you hear us? Sorry.
Some noise in your voice.
Hello?
Would you make it more clear?
Hello?
Hello?
Hello? Hello? Can you hear us?
Noise.
I can hear you now. Would you ask Professor Joe to explain what is he doing for the audience?
Okay.
让你解释一下在干嘛？
你讲。
啊
？Dr. Zhu is now dissecting the gallbladder from the gallbladder bed.
Yes.
I use an I-type of the hybrid knife. In my procedure, I always inject the saline into the gallbladder bed.
So for all audience and attendee, now he is dissecting the whole bladder from its bed using hybrid knife. He injecting when needed, then cutting with the knife and coagulate when he is seeing any blood vessels, whatever prophylactically or therapeutic after bleeding.
And this is the gallbladder wall.
Would you explain to us how you will identify the cystic duct, the common bile duct, to avoid injury to the common bile duct?
So actually, when I finish the dissection of the gallbladder from the liver to the gallbladder to angle, I will introduce you what is the gallbladder duct, what is the CBD, what is the gallbladder artery.
Now the structure we are seeing is the common bile duct at 6 o'clock.
No, not yet.
Not yet. So are we still dissecting?
Yeah. Not yet. You先跟他讲呀，你跟他讲。
还讲电视吗？
不是讲电视，姐，这个现在在做的什么东西？他都问是不是当中文了？
الناس اللي لسه
还没到呢。
你讲，你要跟他讲，你要跟他讲。
القصر العيني اندوسكوبي هيباتولوجي اند جاسترونترولوجي كونجرس. نرحب بكل الاودينس. هو احنا بننقل البث دلوقتي من زونغشان هوسبيتال فودان يونيفرسيتي في شنغهاي. اللي شغال بروفيسور بينج هونج جو، ده من اقوى الناس في الانترفنشن اندوسكوبي على مستوى العالم، في مستشفى من اكبر المستشفيات. هو بيعمل حاجه اسمها اندوسكوبيك كوليسيستكتومي، بدل اللاباروسكوبيك بقى كله بالاندوسكوب. هو استخدم جاستروسكوب، دخل في الاستومك وبص على الانترم. في عندنا الانتير وول بتاع الانترم، بدا يعمل فيه ديستكشن، يعني يفتح الانترم، يعمل كومبليت ديستكشن للجاستريك وول. بيستخدم الاكسسوارز بتاعه الاندوسكوبي، استخدم الهايبرد، عمل بيها انتجن عشان يعمل كومبليت ديسكشن للانتير وول بتاع الاستومك. بعد كده استخدم حاجه اسمها الاي تي نايف، وعمل الفتحه بتاعته اللي هي في الانتير وول عشان يدخل جوه البروتينيه. هو دلوقتي تاني كان بننظف صوره المنظار. هو داخل بالمنظار جاستروسكوب عليه ديستال اتاتشمنت اللي هو الكاب، وهيدخل جوه الاستومك وهنشوف.
我在做什么，知道吧？
Again, Professor Joe, would you explain the, would you make it slowly to show for the audience the entry you enter from us? Now
This
this is the entry
is the entrance
from the
of
wall of the stomach to the peritoneum. You can see the peritoneal fat at 5 o'clock. Now we are inside the peritoneum. We are searching for the gallbladder. Actually, he dissected or starting to dissect the gallbladder from its bed from the liver. Now we are seeing the gallbladder above and the liver below, and he started dissection. He will complete the dissection of the gallbladder from its bed using the hybrid knife and the insulated tip knife or IT knife. Now he is injecting with the knife, then to separate, to make space, to make cushion, and then going from left to right by dissecting the fat and the fat. Now he is injecting again and dissecting.
There's adhesion here, fibrosis.
دلوقتي يا جماعه هي نفس القصه لحد ما الجول بلادر تتفصل من البيت بتاعتها. اهم حاجه نبقى احنا كوشس جدا وهو بيدسكت الجول بلادر يشوف البلاد فيسلز، عشان هنا البليدنج هوريبل. خلي بالنا هو شغال باندوسكوب ماسك برضو بمنظار واحد زي بايد واحده زي المنظار بتاعنا غير اللابروسكوب. فلما يشوف اي بلاد فيسل زي كده يبدا يبوينت عليه ويعمل له كواجليشن عشان ما يحصلش بليدنج. طبعا التكنيك اللي احنا شايفينه ده يعني ده اول مره يتعرض لايف كده، والتكنيك ده ما بيتعملش الا في الصين، وبروفيسور جو هو اللي عمل التكنيك ده. لحد ما كنا هناك انا وزمايلي في الصين كان هو عمل حوالي 40 حاله، الكلام ده في 2017 اخر 2017 اول 2018. احنا بنتكلم في تكنيك مختلف تماما وجديد. الحمد لله يعني زي ما عودناكم بنقدم حاجات جديده دايما، ده اول مره يتذاع حاجه زي كده.
So doctor is dissecting gradually from the fundus of the gallbladder to the neck of the gallbladder. Now we are reaching the middle part of the gallbladder.
هو لو انا زي ما سمعت حضرتك يا دكتور حسين، هو الايدنتيفيكيشن مهم جدا ان هو يشوف السيستيك داكت ويشوف الكومن بيل داكت عشان ما يعملش الانجن. هو من شويه اعتقد وصل للسيستيك ارتري، يعني هو كله شايفه بعينيه دلوقتي. لا بيكوترايز يا دكتور حسين، وما عندوش يعني فرصه ان هو يعمل لايجيشن. هو ممكن يحط كليبنج مثلا، لكن هو في الاخر بيكوترايز افضل.
这里太靠近胆囊壁了，一个地方。
هو برضو عشان الناس اللي سمعانا، هو الدكتور حسين عكاشة كان بيسأل سؤال مهم جدا بالنسبة للسيستيك ارتري. احنا هنعمل له ايه؟ احنا ما عندناش هنا فرصة ان هو يربط السوتشرنج، مش هيستخدمه هنا. هو التولز اللي احنا بنستخدمها في السيرابيوتيك اندوسكوبي هو يستخدمها سواء بالنايف اللي هو شغال بيها، ان هو يقدر يديسكت حوالين الفيسل ويجي من جنب الفيسل ويعمل له كواجليشن. بديفرنت مودز اوف كواجيليشن طبعا، لان السيستيك ارتري هيبقى ارتري كبير، سواء يستخدم النايف او ممكن يستخدم الكواجيليشن جراسبر او الهوت بايوبسي فورسبس. ممكن برضو يحط كليبنج عشان يقلل البليدنج قبل ما يبدا الكواجيليشن بتاعه. يعني بروكسيمال للارتري اللي هو يعمل له كواجيليت هو بيحط كليبنج يقلل الانسيدنس اوف بليدنج، وبعد كده يبدا يعمل كواجيليشن ليه. هو لحد دلوقتي دكتور زو لسه بيعمل ديستكشن، لازم يسيبريت كويس قوي المراره من البيت زي ما الجراح بيعمل في اللاباروسكوب او الاوبن بالظبط.
Thus now we could see minor bleeding and the hybrid IT knife could well manage it.
الجميل في التكنيك ده ان احنا مفيش سكار، مفيش درينز بعد ما بنخرج. الصعب ان هي ايد واحده في الاخر،
يعني في اللاباروسكوبيك
منظار واحد داخل.
اللاباروسكوبيك بيبقى داخل من اكتر من بانكشر، فبيبقى قادر ان هو يعني يدخل اكتر من تول في نفس الوقت. هنا التكنيكال ديفيكالتي في القصه دي ان هو ما عندوش غير ثيرابيوتيك شانل واحده، ما بيقدرش يستخدم غير تول واحده في المره، فده اللي بيخليه طبعا ان الموضوع
Because of the fat in the abdominal cavity, we should retract the scope to clean it rapidly and
عشان بيبقى في بعض
frequently.
طبعا بنعمل كواجيليشن جوه الكافيتي مغلقه اللي هي البروتونيوم. تاني هو في الاسوفجاس دلوقتي عشان برضو الناس اللي لسه دخل الاستومك وهو داخل
他在这解说是吧？
对，他一直在解说，
دي الفتحه
不停的。
منها دخل جوه البروتونيه.
排气在排吗？
在排。
هو الخروج ده
在
بس
排的是吧？
هو يبقى كلير للناس تبقى واضحه. يعني زي ما الدكتور نجيب كان بيقول احنا لو الجراح شغال باللابروسكوب بيستخدم ايديه الاثنين، يعني ايد من كل ناحيه، ويقدر يمسك باكسسوري هنا واكسسوري هنا، يقدر يعمل ديستكشن كويس بالالات بتاعتهم في اللابروسكوب. لكن هنا هي ايد واحده واله واحده، فتكنيكالي فيري ديفيكالت طبعا. يعني برضو يعني ما نشجعش قوي الناس ان هم اول ما يشوفوا البتاع ده يروحوا يجيبوا المنظار ويلا يروحوا يشيلوا مرارات، فالناس ما تسخنش قوي. الموضوع a little bit difficult وتكنيكالي لازم يكون حد اشتغل في الانترفنشن اندوسكوبي كويس قوي. طيب he is still
这个地方
now
啊，
Professor Joe.
Yeah.
We didn't reach cystic duct till now.
你到胆囊骨吗
No, no, no, no, no, no.
？Not yet.
Not yet.
Not yet. Okay. So where we are dissecting now, still in the gallbladder pit.
This is the neck of the gallbladder.
Yeah. هو لسه يا جماعه بيعمل dissection في البيت بتاع الجول بلادر.
The neck of the gallbladder. So we have finished the fundus.
Okay, so we are
Close to the duct.
we are reaching to the neck of gallbladder to do complete separation of the
Yeah.
gallbladder.
We are very close to the cystic duct now.
We are approaching the cystic duct now.
Yeah.
اللي على الشمال ده يا جماعه الليفر، يعني اللي على الشمال الليفر، واحنا في اخر جزء في الديستكشن اللي هو النك زي ما احنا شايفين، كله بالانسترومنت اللي هي داخله من البورت بتاع الاكسسوري شانل في المنظار. الجول بلادر فوقنا دلوقتي وهو برضو بيكمل الديستكشن بتاعه. لو الكلام واضح يا جماعه يعني قولوا لنا كويس جميل مبسوطين. لو في اسئله او استفسارات عن حاجه معينه ابعتوا لنا الاسئله في الشات جروب and Q&A في المسجز في الQ&A او الشات جروب.
还是什么？
没有听这句，没听见。
啊？
Sorry, what was your Q&A?
Now we are asking,
没有说。
we are still waiting the questions.
Okay.
Egyptian gastroenterologists that they are seeing that's a very easy technique because Professor Joe is doing it by himself.
说分起来好像很容易的样子。
那个人讲，我们完成了将近30例的。
We have finished almost 30 cases of endoscopic transgastric cholecystectomy by Dr. Zhou himself.
هو في سؤال جاي لنا يعني بيسأل any problem from the scope as it enter the peritoneum without sterilization. التقنية دي زي ما احنا شايفين لا دي تقنية غير المناظير مش اللي هي disinfectant او لا دي بتبقى complete sterilization. المنظار بيبقى متعقم وبيدخل البروتينيه متعقم. حتى احنا هنلاحظ ان الدكتور جو متعقم تعقيم جراحين تماما. اليونت او البروسيسور بتبقى متعقمه ومعزوله برضو، يعني هو ما بيشتغلش بالاندوسكوبي العادي، لا بيبقى كومبليت ستيرلايزيشن مش ديس افكتنت زي الدايجنوستيك او ثيرابيوتيك اندوسكوبي حتى بتاعه الايس دي او البوي.
轻一点，轻一点。
Yes.
So you asked a question about the sterilization of the scope entering the abdominal cavity. We use the standard sterilization, and in our experience of more than almost 30 cases, there's no severe abdominal inflammation due to the scope itself. And before we open the we perforate the gastric wall, we also constantly and intensively wash the gastric cavity to remove the potentially inflammatory elements.
اوكي يعني هي قالت يا جماعه ان هي الستيرلايزيشن بالظبط كامل، بالاضافه كمان ان هم بينظفوا الجاستريك كافيتي اول ما بيدخلوا تماما، بتتنظف عشان لو فيها اي ريزيدوال فود او فلويد.
那胆哪里去？
那
那胆哪里去？
怎么办？说不说？
那胆哪里去？这个地方是活火，看到吧？
看到了，怎么办？说不说？不说。
再去。刚才吵死啊！
طبعا يا جماعه الناس اللي يعني اللي حاضره معانا او كده، احنا برضو بنانونس ان يعني ان كل الفعاليات بتاعت المؤتمر منقوله لايف ستريمينج على البيج بتاعتنا اللي هي EHGC على الفيسبوك، وكذلك الشانل بتاعتنا على اليوتيوب اللي هي برضو نقدر ندور عليها كذلك باسم EHGC. هي اسمها يعني على اليوتيوب قصر العيني EHGC. برضو كمان يا جماعه كل الناس اللي اللي عاملين ريجستريشن بالنسبه لبكره وبعده هيتبعت لهم على الايميل بتاعهم اللينكات بتاعه الستريمينج، بالناس اللي هي مش هتقدر ان هي تشرفنا هنا في الاوتيل وتقدر وتحب ان هي تحضر الجلسات كلها. كل الجلسات هتبقى منقوله لايف ترانسميشن، يعني حتى الباراليل سيشنز هيبقوا برضو منقولين كلايف ترانسميشن. برضو هيتبعت لكم اللينكات كلها على الايميلات، وان شاء الله برضو نحط اللينكات برضو على كل السوشيال ميديا اللي هي سواء جروب التليجرام بتاعنا، وده يعني اهم وسيله يعني عشان ده بياخد عدد كبير وكلنا بناخد بالنا منه، وكذلك القناه بتاعت اليوتيوب والصفحه بتاعت الفيسبوك. طبعا برضو بفكر حضرتك ان احنا هنبتدي بكره الساعه 9 الصبح. عندنا 3 early post graduate courses، بلانتيشن، كورس بتاع الترا ساوند، وكورس بتاع تولز اند اكويبمنت. الثلاث كورسات يعني لطاف جدا جدا لكل المهتمين، وهيكونوا برضو للناس اللي مش هيقدروا ان هم يشرفونا ان هم يحضروا هنا يعني ان بيرسون في الفندق، ان هم يقدروا يحضروها لايف على السوشيال ميديا. شكرا.
Hi, Professor Joe.
Yes.
I'm seeing clip now. What you are clipping?
So there's small perforation in the gallbladder. Close.
Sorry?
好的，一个小的穿孔在胆囊壁上。
There's a small perforation on the gallbladder wall because in this patient we can see the severe adhesion in the surrounding tissues of the gallbladder. So just now there was a small perforation. So we are clipping the perforation.
So this perforation occurred from our knife during the section?
Yes, it was accidentally perforated by the knife.
So this important to close the perforation, right? So
yeah.
Contamination of the
No, actually it's close to the bile duct. 接近胆囊管。
we are approaching the cystic duct, and the working space became narrower and narrower.
We are now approaching the cystic duct.
I mean, maybe here is a artery.
Here may be the cystic artery.
Now we are dissecting around the cystic artery, right?
We think so. We are approaching, but there's not a clear. I mean, there's a not clear definition between the gallbladder neck and the cystic duct. So we are still not sure whether it is now, but we think we are approaching, and the cystic artery is nearby.
Right.
There is a question from the floor about what can you do if you are unable to complete it endoscopically during the procedure. If anything occurs, can you transfer it to a surgical or open cholecystectomy? Or you can...
Sure, as you can see, I think as you can see in the image that we are preparing according to a standard open surgery.
So till now there was no reversion to the surgery till now in our center.
In our experience of almost 30 cases, there's still no conversion to laparoscopic surgery or open surgery. But we are all preparing the standard pre-procedure preparation according to open surgery. So if any circumstances happen, we can convert to laparoscopic surgery or open surgery without hesitation.
يعني إجابة السؤال يا جماعة لازم يبقى في باك اب سيرجن يبقى موجود معانا ونبقى احنا شغالين. مش الكلام ما ينفعش يتعمل في اندوسكوبي يونت ما فيش فيها باك اب سيرجري وات ايفر هي يعني كومبليتد ولا مش كومبليتد، هتبقى لاباروسكوبيك ولا اوبن. فلازم نبقى جاهزين، حتى يعني لو حد فكر يعمل كده يقول للجراح وهو بقى يبقى ايه
是胆囊活腹，到了胆囊活腹的部分。
护肤不会说
啊？
护肤怎么说？
活腹啊，好像这人胆囊活腹比较大，这人胆囊比较大的。啊。
دكتور شربيني can I ask a question?
اتفضل.
Sometimes there is an accessory bile channel between the liver bed and the gallbladder, and injury of this accessory cystic duct can produce post-operative collection. Did he find this complication in his experience during this technique?
Professor Joe.
他说在胆囊和胆囊床之间有些
毛细胆管，
嗯，
毛细胆管。
会不会伤到？
Here we have a question. If you
这
find
是外科的问题，外科也会碰到这个问题。
how do you deal with this?
外科也会。
Actually, Dr. just said, actually, this is a question in the field of surgery of gallbladder removal. Not only we will face this problem, when we do laparoscopic or open cholecystectomy, this problem still occurs.
Would you repeat the answer about the question
Huh?
of cystic duct? We are asking Professor Joe how we will deal with the accessory duct if he found how we can deal with it.
Our answer is that damaging the accessories of the cystic duct is not a problem that only we endoscopists will face when we do transgastric
你
endoscopy
讲慢一点，你给他讲慢一点。
cholecystectomy. When we do laparoscopic or open surgery, this problem will still occur. So this is not only our question; it is a question of all gallbladder removal surgeries.
避免胆状管的损伤是一直要注意的。
So it is very important and never can be overemphasized that the common bile duct should not be injured.
胆囊三角一定要解剖清楚。
The hepatic triangle should be dissected very clearly.
就是对内镜医生来讲，可能更加要小心认识清楚。
It is especially important for endoscopists to recognize the vital structures of the hepatic triangle.
这里快要接近胆囊管。
胆囊管还是胆总管？
胆囊管。
السؤال نعمل اندوسكوبيك كوليسيستكتومي ما نعملش لاباروسكوبيك كوليسيستكتومي. السؤال ده انا سالته وانا في الصيف 2017 في بعض المعتقدات مبدئيا اللي عندهم ان هم ما بيحبوش سكارز لان هم بيعتقدوا الصينيين ان ده حاجه زي تشويه للجسم يعني. ده ممكن بيعملوا اكتر من كده كمان ان هم بيفتحوا الجول بلادر ويشيلوا الستونز منها عشان برضو من ضمن بعض الفصائل او المعتقدات ان هو مش عايز يشيل بارت من جسمه يعني ما يشيلش جزء من جسمه. لكن الحاجات التانية اللي ممكن تكون ميديكال ان مفيش سكارز يعني لو حد مش حابب يبقى فيه سكارز سواء ميل او فيميل لاسباب يعني هي بالنسبه للجنرال كونديشن هي ديفنتلي هو كانها سيرجري لان هي بيتعمل فيها انسيجن من جوه بيتعمل فيها كليبنج بيتعمل فيها كواجليشن نفس الحاجات وان كانت تظل اقل انفيزيف او ليس انفيزيف من اللاباروسكوبيك سيرجري لكن هو الانسفليشن فيه اوبننج بيتعمل في الوول من جوه الاوبننج اللي بيتعمل ده بيتقفل بكليبس غير السكارز اللي بره لكن تظل موضوع الانفكشن وارد تظل موضوع الكواجليشن مهم البلياري بريتونايتس لازم يحصل بعد ما بيخلص يعمل كومبليت لافاج لكن في الاخر اقل الحاجات انفيزيف في اللاباروسكوبيك كوليسيستكتومي بيبقى اتليست البيشنت عنده 3 انسيجن ايفن لو دول سمول ويبقى فيه درينز كمان هي ما فيش الدرينز تمام خالص يعني في القصه. دكتور نجيب برضو بيقول على الهوسبيتال ستاي ديفنتلي اقل يعني في الاندوسكوبيك كوليسيستومي.
说吗？ 是的，是的。
Still dissecting around gallbladder or this is the cystic duct?
We think this is the cystic duct.
We are dissecting around cystic duct now. I can see some injury to the cystic duct. A small injury to I saw pile.
Yes, just now. Yeah. Just now during coagulation.
Yeah. هي التكنيكاليتي او الديفيكالتيز في القصص دي زي ما كنا بنقول اللي انت بتستخدم وان هاند برضه في الاخر. كذا حاجه بقى.
Yes, one hand.
من اول الاوبننج بتاع الاستومك، ان احنا ازاي نعمل الاوبننج كويس، ندخل جوه البريتونيوم. برضه المنظار يعني مش بسهوله ان انت لما بتدخل من الانترم للبريتونيوم هتلاقي الجول بلادر في الوش، ساعات بتضطر تشتغل بلوب. يعني زي ما لما يبقى حد مثلا بيعمل ديسكشن في الكولون في سيكم مثلا او في الاسندنج كولون، ممكن يبقى مضطر يقف بلوب عشان يقدر يعمل ديسكشن. ساعات ان هو هنا عشان يوصل للجول بلادر او يوصل للبيت بتاعتها يضطر ياخد لوب شويه جوه البريتونيوم. التكنيكاليتي بقى او الافضل لو هو قدر يقلل اللوب ده قدر الامكان ويخلي المنظار قصير عشان التكنيك يبقى اسهل. يعني هو برضه لسه بيدسكت حوالين السيستيك داكت دلوقتي. لازم طبعا يبقى في ايدنتيفيكيشن طول الوقت في الاناتومي زي اي تكنيك انترفنشن. الاورينتيشن بيبقى مهم جدا يعني. شفنا من شويه بايل هو جه عليه البايل البسيط ده انجري صغيره حصلت للسيستيك داكت وهو هيمانج الانجري ده.
胆囊比较大。气在排吗？
在排。
دكتور علي اتفضل معانا. اتفضل يا دكتور علي. تاني هو بيخرج يمسح العدسه بتاعته. تمام. يدخل تاني جوه الاستومك اهو. طبعا الدخول في المرات المتتاليه بيبقى صعب، زي الاي ار سي بي مثلا يخرج ويدخل بيبقى صعب عشان يتنفخ. هنا البريتونيوم هو اللي اتنفخ، فالسي او 2 او الحاجات السي او 2 اللي نافخ البريتونيوم بيخلي الاستومك كولابسد، فهو لازم يعمل ايدنتيفيكيشن كويس للفتحه اللي فتحها في الاستومك ويدخل تاني على البريتونيوم. هو كل شويه بيبقى عايز الفيلد بتاعه يبقى كلير، فبيمسح العدسه سيمبلي ويدخل تاني عشان ما يحصلش انجري واحنا مش شايفين يعني. اعتقد ان هو اباوت ان هو يفينش خلاص الديسكشن. هو يعني
现在解剖干12长韧带，干12长韧带。
We are dissecting the haptic duodenal ligand now.
Ligament.
What are you dissecting now?
干12长韧带。
Haptic duodenal ligand. Ligation.
Is it normal to see that many blood vessels at this bit? This normal? Or it differs from patient to other, cause maybe of inflammation, recurrent cystitis, or this normal? to see this many blood vessels. Professor Joe.
Yeah.
There is a question about the incidence of the peritonitis after this procedure.
Sorry?
Or the
We didn't follow your question clearly. Sorry, we didn't follow your question well just now.
The question is, what about the incidence of the peritonitis or biliary peritonitis or peritonitis in general after this procedure? In your experience?
什么炎的发生啊？没有啊。There is no case of peritonitis in our case now, till now.
No.
No.
You are asking about
In our 30 cases, no incidence of the abdominal
infection. Because after the procedure, we wash the abdominal cavity very we wash the abdominal cavity with normal saline, a large amount of normal saline.
So you mean that he is doing thorough wash after finishing the cholecystectomy to avoid the peritonitis?
Yeah, yeah, yeah, to avoid the leakage of the bile to cause inflammation.
Okay. Also, I think he has to ensure accurately that there is no biliary leak to avoid delayed peritonitis. Another question about the duration of this procedure. The medium time of this
Duration? Medium time 中位数2.5个小时。
2到3小时。
The
看胆囊的情况的。
the median of the procedure was 2 to 3 hours in our center, and it depends on the condition of the gallbladder, the size, and the inflammatory status, whether there's severe fibrosis around it. And the shortest time was 1.5 hours. Right.
Yeah, right.
70 minutes.
Yeah, the shortest procedure happened last month. It takes only 70 minutes.
Yeah, right.
今天这个病人可能有些难度。
This case is a bit difficult, so it may take a longer time.
Another question about how many till now for this technique. Do you hear me?
Sorry, how?
Yeah, how many cases?
30.
30.
30.
30. 30. 30.
胆囊有点大，
感觉有点大，有点扭。
胆囊有点大嘛？啊？
嗯。
啊？
嗯。So this gallbladder was about 12 centimeters in length on ultrasound examinations. So it's very.
Now we finished this section.
No,
not yet.
来，加次。
This
看一下。
also in the gallbladder or in the cystic duct?
Gallbladder.
This small hole.
This is the damage, the small perforation we saw just now.
I can see bile coming out from this small hole. This gallbladder?
Yeah.
Yeah.
胆囊还是胆总管还是胆囊管？
胆囊。
This is the gallbladder. During the dissection just now, we thought it was the cystic duct. Actually, we find the gallbladder was very big, so this will still be the gallbladder. So this perforation was caused just now accidentally during coagulation. So we are also now clipping it with a metal clip.
يعني هو برضو accidentally كده هو بيعمل dissection. الجول بلادر اتعورت اول مره واتعورت تاني مره. هنا شفنا من الهول الصغير ده في بايل خارج منها فهو قفلها بالكليبس العادي الهيموكليبس او الاندوكليبس العادي.
What about after these many dissections? There wouldn't be any kind of collection or remains of the procedure that needs to be drained. I mean, after this procedure, there is no need to insert a drain or something like that for any remaining collection after such procedure.
You mean the procedure will cause even more severe adhesion? Did I catch it?
Yeah, we mean after this dissection, there wouldn't be any kind of collection in the gallbladder bed or peritoneum or something like that.
他说这个做完会不会粘连更严重？
什么地方粘连？
就是胆囊床。他说你这么包一遍，胆囊会不会胆囊床这个地方跟周围粘连更严重？
不影响。
为啥呀？
这个跟外科手术一样的，外科手术也要分离的嘛。
Okay, Dr. Joe just said that this will not cause even more severe adhesion and does not influence the anatomical structure of the local anatomy. This is the same procedure. So when we do laparoscopic or open surgery, we will also do this dissection. This is the same procedure.
Okay, thank you.
So
Same procedure, different access.
Yeah. So what's the commonest complication you find? What's the commonest complication you have?
The most common complication?
The most
the
injury to CPD. Injury to CPD.
Yes.
胆囊管损伤。
How will you manage it?
The most common complication of this procedure.
他说最严重的并发症就是 damage to CBD 啊。
Yes.
The most common complication is damage to the common bile duct.
Injury. And how can he deal with this injury of the common bile duct?
How to manage? 怎么处理？
这个是吧？不要老问这个问题。
他说最常见的呀，我们说最常见的是这个呀。
现在好。
We found that pre-operative ERBD could, to a large extent, prevent the damage to the CBD, and
这是避免胆囊管的损伤是外科手术跟同样的面临的问题，不是经济手术。腹腔镜切除、开腹切除一样。
你们说术前 ERBD 可以减少？
这是不是胆囊？这可能是胆囊管。这可能是胆囊管。
这哪根血管嘛？
这可能是胆囊管，或者血管。今天这个胆囊很大。
就感觉在跳。
大吗？
这是胆囊动脉吗？是吗？
哎，他妈的胆囊太大了，啊啊，看到吧？不很大，啊，哎，我们那个青岛的医生呢？是不是这个胆囊很大？今天，干嘛？
For a brief explanation of the previous question, the most severe complication of this procedure is damage to the common bile duct, but not most common in our case. We found that pre-procedure ERBD could largely prevent the damage to the to the common bile duct. And in our center, actually, there is no very severe complication after the procedure till now. Some patients will suffer from abdominal pain because of local inflammation.
今天这个人胆囊非常大。
So this patient has a very huge gallbladder.
So the work is very hard. 因为胆囊很大。啊？
胆囊动脉哪去？
这胆囊。
برضه يا جماعه نبقى عارفين طبعا كل شويه هو بيخرج جوه البريتونيوم ويشفط السي او 2 اللي هو عامل له. ده مهم جدا. البروسيجر دي بيستخدم سي او 2 ما بيستخدمش الريجولار اير، وزي ما قلنا ان المنظار بيبقى متعقم.
النهار哪里？
بالظبط. كل شويه بيسك عشان
النهار当在这里了。
يبقى محتاج
啊，胆囊活。
زي لو حد جرب.
你说他们假如其他房间有手术的话，可以等到其他房间去。
قوي.
我觉得可能还有一段时间。
يستخدموا حاجه اسمها
没有吧？
كده.
你跟他交流。
كتير اكتر، فهو لذلك بيخرج كذا مره ينظف العدسه بتاعته عشان الفيو يبقى كلير. برضه هو كل ده بقى بيعمل ديسكشن من الناحيه الثانيه. شايفين اللون الازرق ده بيتحقن مترين بلو زي ما بيتعمل في الاي ام ار البلدي اللي بيتعمل دلوقتي. هو بيحقن بالنايف وبيعمل ديسكشن. هو بيديسكت اراوند الجول بلادر كلها دلوقتي. والانجري اللي حصل في الجول بلادر ده بالنسبه له ما يسببش مشكله، لان هو حط الكليب قفل الجول بلادر تاني وهيشيلها ان بلوك على بعضها، يعني يشيلها كلها توتال. وفي الاخر بتعمل ووش كويس قوي البريتونيوم بسلاين، وبيصك كل السلاين اللي هو عمله عشان يقلل الانسيدنس بتاع البلياري بريتونيتس بعد كده.
Just now I heard a question about CO2, right? Actually, in our center, we adopted carbon dioxide for all endoscopic difficult endoscopic procedures since the year of 2012. And the use of carbon dioxide will largely reduce the incidence of gas-related adverse events. And in this patient, we also prepared paracentesis just after we went into the abdominal cavity. And the paracentesis is continuing now. So the peak is very constant and very about 15.
So if there are any other procedures in other rooms,
as this procedure may take a longer time than we expected, if you have other operation rooms to have live demo, you can convert to other operation rooms and come back to us later. 感觉好像没有。
这是胆囊管吗？这下面是什么？啊？
About the overuse.
这是胆囊管啊
Over
兄弟啊
insufficient insufficient of the peritoneum. You see that it will. If there is any complication from the excess use of CO2 because the long procedure.
这是胆囊。 是的呢。
There's still gas-related complications after adopting CO2 insufflation, but the incidence is reduced rapidly after we introduce CO2 compared to using air.
برضو يا جماعه
نعم.
السي او 2 احنا الموضوع ده ما بيتعملش في اندوسكوبي يونت عاديه، لازم بيبقى فيه جهاز تخدير. الجهاز التخدير ده ملحق في المونيتور بتاعته حاجه اسمها كابنوجرام. الكابنوجرام ده بيتوصل ببورت كده، بتوصل بسنسور على الاندوتراكيال تيوب، بتقدر تقول لنا السي او 2 ده الساتوريشن بتاعه او هو بوصل للليفل بتاعه قد ايه على المونيتور، وده يقول لنا هو قد ايه في البلد. لان المشاكل بتاعه السي او 2 لو الارقام يعني تخطت ليفلز معينه ممكن يبقى فيه ديلايد ريكفري او العيان ما بيفوقش بعدها وبيحصل مشكله من السي او 2، فده يقلل او في الريكفري. فلو ده حصل نتيجه الاوفر بيبقى الاندوسكوبست او اللي بيشتغل التكنيك ده ايفن حتى دي بتتعمل او بنلاحظها او بنستخدمها في اي انترفنشن استخدمنا فيه سي او 2 وبيبقى فيه الكابنوجرام بيوقف شويه الابزوربشن بتاع مره اكتر من الغير العادي. فبالتالي هو لو وقف البروسيجر 5 دقائق 10 دقائق الليفل بتاع السي او 2 ده على الكابنوجرام والمونيتور بيقل، ما بياخدش 5 دقائق 10 دقائق بالكتير قوي، ده لو الليفلز تخطت ارقام عاليه يعني. اعتقد دلوقتي خلاص ان احنا اباوت ان هو يخلص الكومبليت ديسكشن. انتوا زي ما سمعتوا قال الافريج تايم بتاعها من 2 ل 3، احنا ما كملناش ساعه، وهو عمل حاله قبل كده في 1.5 ساعة. ادي الفتحه الثانيه هيدخل مسح العدسه. هو بصراحه كذا تكنيك في بعض يعني الجاستريك رول ده القلب اللي يجي لك ان انت تفتح ده تجيب ليفر مالك وسبرين على اليمين تعمل ديستكشن.
是的呢，这个下面呢还是
因为我感觉它是这样卷起来的，扭了。
يخلص البول بلادر بتاعته ان هو زي الفتحه دي هنشوفها بالتكنيك اللي هو عشان يقفل الكومبليت كات اللي هو عمله في الوول.
下面有根粗的血管呀，这是胆囊动脉吧？不会。
لما اتسأل قبل كده على الكليبسات دي ما فيش فيها مشكله، ان حتى بعد شويه لو هي وقعت هتفضل في البروتينيه ما فيش مشكله خالص.
胆囊动脉有可能是吧？我感觉好像胆囊颈部很扭的，转了个圈圈，这样。
بص هنلاقي حاجات كاتس في الاخر بسيطه لان هو من كل الاتجاهات يعني.
ايه؟
掏出来。IT
啊
IT 的，
换一个。
لو في حد برضه يا جماعه عنده اي اسئله او على الشات جروب هو دلوقتي الكليبس ده عند السمول انجري اللي اتعمل من الكواجيليشن، لان هي الحاله دي بصراحه واضح ان هي بلادي قوي، فيها بلاد فيسلز كتير وفيها شويه فايبروز كتير، ده اللي مخليه الديسكشن كتير قوي حوالين جول بلادر. ده ممكن يكون ريكارنت كوليستايتس حصلت ودي مخليها المنظر كده.
这个胆囊很大，今天。
感觉扭起来了。
I'd like to ask a question. Could this maneuver be done in cases of mucocele or at the time of acute cholecystitis?
有血管。
Could it be easy as in the quiescent phase or the chronic phase, or it will be more dangerous?
什么东西？
هو
他说
دلوقتي
的慢性的是不是更危险？
اسمها IT knife.
他还会再说一遍的。
او النايف دي من اولمبس هنلاقيها انسوليتد تب. هو بيزق النايف يحطها في بلايند سبيس عشان ما يعملش انجري في الفورورد قدامه، يعني حته قدام هو مش شايفها فبيزقها وبيبدا يعمل كاتنج وكواجليشن بالسايد بتاع زي ما احنا شايفين. هو حطها فوق وبينزلها لتحت. التب بتاعتها انسوليت فمش هتكوي مش هتحرق مش هتعمل انجري، وينزل لتحت يعمل الديسكشن. هو دخلها هنا بلايند مش شايفين التب، يعمل التب وبيبدا لتحت ولفوق يعمل بيها ديسكشن كانه from up to down or from side to side. دي اخر قط بيعمل بيها كده عشان يقدر يفصل الجزء الباقي، لان ممكن الجزء الباقي ده وهو بيعمل يكون في حاجه ما وراءه وهو مش شايفها يعمل ليها انجري، سواء structure او سواء blood vessel. Professor Joe.
Yeah.
We have a question about, can you do cholecystectomy in presence of acute cholecystitis or mucocele, or you have to wait for some time?
不能做急性的吧？
什么？
能做急性胆囊炎发作吗？不能吧？
这个看你现在是在积累经验的阶段，跟他讲。
We are accumulating accumulating experience now. Till now, we haven't done any case in acute inflammatory cases.
In the future, I hope we can perform such procedures for the actual cholecystitis.
We can.
但是，是胆囊管的位置应该是啊。他刚才分了一些大的那个。
那两根大血管是什么？
Would you repeat the answer, please, about in case?
Yeah, here maybe a duct.
Acute cholecystitis. You will go for
这是胆囊。
or to wait some time.
这是胆囊。啊？差不多好了吗？好了没有？
这个血管有点粗啊。
差不多好了没？这应该是胆囊管的地方，掏出来。掏出来。
شايفينه دلوقتي يا جماعه عشان الناس اللي لسه جايه تحضر، احنا الحمد لله لاول مره في المؤتمر بتاعنا نعرض حاله لايف من الصين مباشره لاندوسكوبيك كوليسيستكتومي. مراره بتتشال بالمنظار بتاع المعده مش لابروسكوب، بتتشال. فكره النوتس ناتشورال اورفيس ترانسليومينال سيرجري ان احنا بتتشال الحاجه بدون اي سكار.
这个就是胆囊管。
不让我说话。
يعني
Here is a
cystic duct.
cystic duct. هنشوف.
الناس كلها راحت اتعلمت في المستشفى في زونغشان هوسبيتال في تبع فودان يونيفرستي في شنغهاي. الاوروبيين كلهم اتعلموا هناك. معانا بروفيسور على الهوا دلوقتي، هو بدا يعمل اول مره بنعرض الهوا هنا. ما يعني الحاجات اللي هو زمان اتعملت لحد دلوقتي 30. هو التكنيك
蛮粗的这个地方。
تبقى مجهزه بكل الحاجات بتاع الادفانسد انترفنشن. المنظار بيبقى متعقم كومبليت ستيرلايزيشن، او البروسيسور بتبقى متعقمه، هو كمان بيبقى كومبليتلي ستيرلايزد. هو بيدخل سكوب ثيرابيوتيك جاسترو شورت كولونوسكوبي لو الموضوع بالنسبه له طويل او اضطر انه يستخدم لوب عشان يوصل للجول. سيمبلي بيدخل على الانترم او الديستال بادي اوف ذا ستومك. الانترم بيدخل، احنا عارفين ان في حاجه اسمها انتير وول وبوستير وول، ليسر كيرف وجريتر كيرف. على الانتير وول بيستخدم النايف. النايف في الاول بيبدا يعمل ديسكشن، يبدا يقطع لاير باي لاير، يقطع الميكوزا، الماسكولاريس ميكوزا، السب ميكوزا، يوصل على المصل يعمل كومبليت ديسكشن لحد ما يوصل للسيروزا. يقطع السيروزا يبقى عمل سمول هول او انتري في الانتير وول اوف ذا انترم. يغير الاكسسوري بتاعته من النايف اللي هي زي هايبريد نايف، او النايفز اللي ليها تب تعمل بيها الكاتنج والكواجليشن، يستخدم حاجه اسمها انسوليتد تب نايف او اي تي نايف. الاي تي يدخلها جوه البور ده عشان يبدا يوسع البور اللي هو فتحه او الهول اللي فتحها في الانتير وول بتاع الانترم عشان تسمح بدخول المنظار، يعني يوسع على قد المنظار اللي هو الجاستروسكوب بتاعه. لما بوصل يفتح الفتحه ويوسعها يعدي بالمنظار تسمح بدخول المنظار جوه البريتونيال كافيتي، يبدا يعمل ايدنتيفيكيشن، يشوف الليفر، يدور على الجول بلادر، يعمل ايدنتيفيكيشن ليها كويس، يبدا يعمل ديسكشن. الديسكشن ريبيتدلي هو بالنايف الهايبريد نايف دي بيعمل انجكشن يسيبريت الجول بلادر من البيد، يخلق لنفسه سبيس زي ما احنا بنعمله في الاي اس دي، زي ما بتعمل في البويم، ان هو بيعمل سبيس عشان يعمل ديسكشن كويس بنفس الاكسسوري اللي بيستخدمها، وما يعملش انجري لا للجول بلادر ولا للليفر. طبعا هو الاهم ان هو ما يعملش انجر ليفر. السوبرفيشال انجري الحاجات اللي هي زي ممكن تحصل مع اللابروسكوب، جاست ان هو تاتش الليفر سيلز دي ما فيش فيها مشاكل. وبعد كده بيبدا يعمل كومبليت ديسكشن، بيبدا من الفندس بتاع الجول بلادر يعمل الديسكشن، يكرر العمليه، يلاقي بلاد فيسلز في سكته، ممكن البلاد فيسل اللي في سكته بيعمله كواجليشن، سواء لو البلاد فيسل ده شايفه صغير بالاكسسوري النايف اللي بيستخدمها، او يبدا يمسكه بالكواجليشن جراسبر او بالهوت فورسبس. لو حصل ليه انجري بيمسك هوت بايوبسي وبرده او وبيقفله. هو هنا احنا خلصنا الديسكشن بتاع الفندس، واصل للجول بلادر نيك، وهو شغال حصل انجري توايس بلادر، ده مش مشكله بالنسبه له، شويه بايل طلعوا، بيغسل البروتينيوم بسلاين سترايل سلاين عادي، وحط كليبس هيمو كليبس او اندو كليبس عادي جدا على السمول هول او السمول انجري اللي حصل في الجول بلادر، وبيكمل البروسيجر بتاعته لحد ما يخلص الديستكشن، يوصل كليب السيستيك كواجليشن، وبعد ايدنتيفيكيشن للسيستيك داكت بيديسكت الكومن بايل داكت تماما، يعمل كليبنج للسيستيك داكت ويخرج بالجول.
对，
finish that
这等到吗？已经转起来了，
转起来了，好像兜了个圈子。
对。对，是的，它那个胆囊颈不就是折起来的？
到这里了，倒出来。这是胆囊。
嗯。对。
这是胆囊。
对，它已经有点转了。
اللي كان على الشمال ده هو البيد اللي اتعمل له
肝脏和这个胆囊之间都是是一点那个地方。
ده ديستكشن بيعمل。
对，肝脏下面。
它从这儿进去。
这是胆囊床。
对。
او الريسكشن بيد.
这胆囊床吗？
كل ده اتعمل. شايفين الكليبسات دي؟
这不腹腔镜下面。
حصل في الجول بلاد. لسه في حاجات.
上面这个地方，这些丝是吧？
هستخدم النايف او التب بتاع النايف. الحته الصغيره دي كل ده بيحاول يشوف لسه الجول بلادر ماسكه في ايه، بحيث ان هو يفصلها تماما من الليفر. دي الجول بلادر اللي تحت، عند الساعة مثلا من 3 ل 6 كده دلوقتي، والليفر فوق.
这儿还连着是吧？
على الحاجات اللي لسه ما اتعملهاش.
是不是啊？诶，
这是胆囊床。
刚才那个地方好像前面还连着。
اقفل الكاميرا
对吧？
دي.
这还能再分吗，郝老师？
那是大门那个，这个
不是这里。
这是，打开就侧面。
So we are checking from the other side of the gallbladder bed to see how much tissue are still connected to the bed.
ايوه. هو بتقول ان احنا الناحيه الثانيه من الجول بلادر هو سلكها من ناحيه تماما، قلبها كده وبيشوف الناحيه الثانيه يعمل لها ديسكشن. طبعا الازرق ده يا جماعه هو حقن، هو بيستخدم بيستخدم سلاين وبيبقى كلرد بانديجو كارمين، يبدا يعمل بيه الديسكشن بتاعه، يعني يعمل بيه انجكشن عشان يسيبريت بعضها. وبرضه للعلم بالشيء، هو بروفيسور بينج هانج جو هو في الاصل، بس هو يعني الاتيتيود بتاع الجراحين او النزعه الجراحيه اللي جواه هي اللي خلته يقدم على عمليات زي دي، يعني او ان هو يستخدم الاندوسكوب في ان هو يعمل بيها بروسيجر زي دي.
哦，两边要会湿了，感觉。就是胆囊管了。这不能再切了吗？怎么往里去了呀？那是啥？那是啥？
胆囊管，胆囊管。
是胆囊管是吧？
وشايفين برضو يا جماعه خلاص، يعني هي لسه في حته صغيره. ايوه دي هو بيحاول.
胆囊管。啊。
你看刚才那下面那。
胆囊管。
对对对，左右都分开了。
Yes, yes, yes, yes, yes, yes.
So we have finally reached the cystic duct.
Yeah.
After dissecting from both the left and the right side, we can see clearly that this is finally the cystic duct.
We are.
Artery.
The final cut. This is the cystic duct that we are seeing now.
Yes, I think so.
Yeah.
这是叫血管呀，对吧？
هو بيشفيها يعني من الاخر، يعني هو بفكره الريسكشن او الديسكشن، هو السيستيك دكت في النص احنا شايفينها، وهو بيديسكت عشان في الاخر يكلبت الاستراكشر اللي هو كده. حواليها لسه حته في اليمين وحته وراه وحته شمالها اهو، هيدخل على الشمال ويبدا يعمل ديسكشن. واحنا هو بعمل ديسكشن النايف بتاعته. بعد الديسكشن ده كله كويس عشان يبدا يتعمل لها كليبنج. ساعات بيستخدم المنظار والديستال اتاتشمنت اللي هو بيحط يعني بيبش عشان يستخدم. طبعا ما بتبقاش يعني قويه رسوميه يعني زي ما احنا بنقول. هو طبعا
这是胆囊动脉吗？
知道。
胆囊管呢？
刚刚还觉得是来着，然后怎么就没了呢？
胆囊管呢？啊？ Yes， 快了。现在在解剖胆囊三角。要保持视野干净。
We are going to dissect the haptic triangle. So we cleaned the scope to keep our
to talk about clear vision.
这是最关键的步骤。
This is the most vital step. So everybody is holding their breath.
这是我们的第一次公开演示这个手术。
This is the first live demo to international colleagues.
Especially for Kasr University.
Especially for Kasr University.
I arranged this procedure especially for Mother Naga. Where is the Shammer? Shammer online?
Is Dr. Shammer online? 没声音了又。
Yes, we are online. 时间过的。现在要展览馆在哪里？啊，兄弟。
我感觉还要静一静哦。诶，左边是刚才那根动脉。
报出来。报提高。像一个血管啊，好，2块钱了。
Now this cystic
2块钱了。
you dissected.
No, here is a vessel.
So vessel here, so we are going to coagulate it with a coagulation grasper.
这是血管，看到吧？
嗯。
哎，黄了吧？切黄了吗？哎。
هو
切黄了吗？
دخل coagulation forceps أو coagulation grasper وبيكواجليت.
Yeah. 再说说。
خلي بالنا لأن هما الاتنين ماشيين مع بعض. وهحط يعني حصل انجري جول بلادر بيحط كليب. هو حصل كويس دلوقتي جول بلادر وحط كليب عليه. لا عادي يعني هو بعد كليبنج وعمل ديسكت بيقطع فوق الكليبنج ويخرج فيها على بعضها.
左边还能开应该。
لا.
展览馆呢？兄弟。
الحته قد دخول المنظار زي الغرفه بتاع اللابوراتوري.
先把左边这边开了呗。
这是胆囊上的。
对，那个脚上。
coagulation يعني هو ماسك الكواجليشن جراسبر دلوقتي بيعمل كواجليشن وبعدين كاتنج يعني بيعمل ديستكشن دلوقتي بحاجه مختلفه مش بالهايبريد نايف ولا بالانسوليتد نايف. لا ده هو بيعمله بالكواجليشن جراسبر او الكواجراسبر لان هي الحته دي ممكن يبقى فيها بلاد فيسلز فهو بادئ يعملها بده وهو بيلف حواليها ولا لسه ان في منطقه لسه ما حصلهاش ديستكشن فوق اللي احنا شفناها جول بلادر على الشمال.
胆总管5毫米粗。
نلاحظ ان هو كل شويه لو بصينا على ايديه ان هو بيحاول ياثر
على
ده
对
procedure اسهل.
ده
البيد اللي هو ريسكتد
这是跟12成认得了
شفنا حته في الليفر كده ملطوشه كده
啊，
عاديه كواجليشن مفيش فيها
是
مشاكل
吧？
وده هو
إيه؟
ضغط كل السكشن بيد الجول بلادر تحت
呃
اهي
这边胆囊环会不会位置很高吗？
النيك بتاعتها
这是胆囊环的位置啊，这是胆囊啊。 会不会在这里面？
嗯，
来， 嗯，
هو حد بيسأل لو احنا اتعمل انجل بيج بيت
这是胆囊，这是胆囊，看到没有？
المفروض يعني عمل العروض يعني او
这是胆囊。
دي
从刚才拧的那个地方下去走吧。
ان هو ايدنتيفيكيشن مهم جدا لكن الفيسل شايفينها كلها دي
连在这里。
كواجليت
当然，
يعني هو اول ما بيشوفها بيعمل كواجليشن
这是胆囊。 好，出来。
لو هي الفيسل كبير فما يحصلش البليدر ممكن يحط عليه كليب يقلل البليدنج شويه وبعد كده يبدا يكواجليت. فهي دايما في اي حد بيشتغل ريسكشن ان هو الاهم ان هو ما يشتغلش عمياني او ان هو يبقى شايف الحاجه قبل ما يعورها. يعني هنا مثلا هو شغال
那从刚才那个动脉那边往下分不行吗？
هو عمل بوينتنج عليه استخدم كواجليشن وكنترول بليدنج في ساعتها. الحاجات
对，然后洗嘛，就没了。
يتحكم فيه. الكبير لازم يكون هو يتوقع. من شويه لو واخدين بالنا نستخدم الاي تي نايف الانسوليتد تيب لان هو مش شايف بيهايند التيب بتاع النايف فدي يقدر يقطع بلايند ورا ويافويد الانجري لفاسكولار ستراكشرز او لاي ستراكشر. لكن هتظل طبعا ان ممكن البليد يعني وما يقدرش يكنترول بالاندوسكوب فتضطر الحاله تتقلب لابرسكوب او ايفن اف اوبن كلش.
但我觉得这边看不清啊，这边。
ونتجنب ده ولو حصل قلنا بيبقى فيه باك اب
那个把它挑到上面。
الطوارئ.
我刚才讲的就这个地方有管。那，我怀疑这个是。
不知道哪里跟哪里连着，我都有点看晕了。
你跟他讲，现在我们因为现在这个空间有限，胆囊三角解剖，传统的腹腔镜有限。现在我们内镜下的死，跟内镜下的死跟腹腔镜有些不一样。
As the working space is very narrow in the hepatic cyst, the view from our endoscopic view is actually not the same as the laparoscopic view. However, one advantage of our this is the gallbladder. Yeah, and one advantage of our endoscopic procedure is that after injecting normal saline, the connective tissue became transparent, and then the structures are also very clear, although the vision is limited.
是的呢。
كل ده برضو بيشوف ايه الحته ويرجع يوصل تاني للسيستم.
就刚刚我们断那个血管的地方。
实际上还有好多，这个手术还有好多困难没解决到现在。
يدخل تاني يدور تاني على السكت الضغط او ده الكليب اللي شايفينه اللي هو السمول انجري اللي حصلت للجول بلادر اللي هو قفلها على طول بالكليب. يوصل للسيستيك داكت وبيشوف اي منطقه لسه ما حصلش فيها ديسكشن عشان يقدر يفصل الجول.
就别说是这种管钢管，然后看
كل الجزء اللي شايفينه تحت ده ديسكتد تماما.
这是刚刚断那根血管的地方。
We have a question, Professor Joe.
I'm sorry. I don't want to answer any questions now. For me, this is a difficult time for me.
Question about the limitation of this procedure.
去看一下那个人的胆气窦倒影。
Did you hear me?
扭吗？应该扭死了，我觉得。看不懂。让人家更看，没事，他已经说了，我也不想说了。不是。
今天这个胆囊环今天在哪里？
感觉那里
啊？
那
兄弟，
是扭的啊。长，而且我觉得胆囊颈那边打了个折。
啊？
是打了个折吗？
对。
看了一眼他的那个磁共振的 MRCP， 确实是胆囊颈非常长。
胆囊颈啊？
胆囊颈很长，那边好像确实有点扭的。
هو خلاص هي السؤال ما جاوبوش يا جماعه، بس احنا هنقول طبعا ان احنا لو عندنا previous surgeries دي هتخلي التكنيكاليتي اصعب طبعا. لو في فايبروزس او في عمليات اتعملت قبل كده كل دي بتخلي الامور مش اظرف حاجه. طبعا الكوست مكلف يعني.
感觉有进展了。
الاوبننج والكلوجر اوف يعني انتري اللي اتعمل دي كلها كوست ممكن تكون مكلفه. لو في كوموربيد كونديشن زي اي سيرجري ممكن الكوموربيد كونديشن دي قد تكون عائق برضه للحاجات دي. يبقى احنا بنتكلم على حاجات ريجاردنج الكوست، بنتكلم على حاجات ريجاردنج التكنيكاليتي او حاجات في البيشنت نفسه. وخلاص احنا زي ما قلنا هو قلب الجول بلادر تاني حطها فوق ولقى ان لسه في حته عايزه تبقى ديسكتد بيحاول يدسكت.
Actually, this case is not good. Not a good case for lymphedema.这是比较安全的。
感觉是。
We have also question here from the floor. Do you hear me?
Yes, yes.
About the difficulty you face in presence of low insertion cystic duct. How would you deal with this situation? About the.
So as the procedure is facing a difficult time, and this is the most important part and most dangerous part. So Dr. Zhou, I think he is focusing quite a lot on the procedure itself.
Thank you.
这下面是不是？这是胆囊可能，对吧？
هيديسكت لحد عندها تكنيكالي طبعا هتبقى اصعب شويه، بس هو هيديسكت لحد عندها ان هو يبقى قريب كده من الوول بتاع الديودينا. الاورينتيشن مهم جدا، يعني شايفين برضو الجول بلادر فوق والبلين بتاع الديسكشن لازم.
这是到哪了，郝老师？到胆管管了吗？
برضو عشان السيبريشن فروم سايد تو سايد دلوقتي. حته برضو تحت اهي. الحته دي برضو المنطقه دي واضح قوي اللي هي على الشمال دلوقتي. هو بيدخل في الحته الصغيره دي بيحاول يحقن عشان يسيبريت ويبدا يعمل ديسكشن.
是不是到了？
ده الفيسل البلاد فيسلز اللي كنا بنسال عليها. لو هو شاف ان هو بالنسبه له يقدر يكنترول لانه بدا يبليد. لو شاف ان هو ارتيريال
应该可以这个。
لو شاف ان هو يقدر يكنترول النايف بتاعته بيجي باي سايد، يعني بتخش عليه بالتب. الفيسل الكبير طالما هو شايف جاي منين لفين بيدخل عليه من التب بالتب بتاع النايف، وبيجي من السايد يجي باي سايد كده ويعمل ليه.
兄弟啊！嗯，这个不想有管道啊？
猜一下。
不想有管道，是吧？像翻的。
حاسس ان الفيو مش كويس قوي، فهو لازم ياخد كل شويه كده ينظف عشان يشوف الحته الاخيره دي. السكشن الاخير ده واضح ان فيها فايبروزس، هنلاقي فيها بلاد فيسلز كتير، وهنلاقي ان الديسكشن ممكن يبقى صعب شويه، فلازم يبقى فيري كوشس، ولازم يبقى شايف كويس. بيمسح العدسه وبيدخل تاني من البورت اللي اتعمل لحد ما يوصل للسايت اللي فيه الديسكشن.
抱歉出去，抱歉出去擦一擦。
这样。
忘了。
Professor Joe。
是在上面吧，左上。
Question, please.
这里这里，右上。
Do you hear me?
右边右边。
你讲，在哪里？
这里。
Any suggestions?
Dr. Joe.
No.
We have question.
让问吗？
等明年我去开罗，我们一起交流。这是一个。
Dr. Zhou said when he comes to Korea next year, you can communicate in person.
干嘛？
胆囊管又解剖了一段啊。
这是应该这应该是胆囊管的地方。
那胆囊管呢？
这应该是。
但会不会那它一个上下的两部分呢？会到哪里去了？啊？
感觉很深了，真的。
这是胆囊管。
也。
这是。
اللي شايفين
这应该是胆囊管。
Yeah, we are checking. This is the cystic duct. Yep, 还是这样。
Yes.
Would you show us the system, please?
This is the cystic duct.
Yes, right. Also, we have question.
Yeah.
Can we use this technique to provide access to the peritoneal cavity to remove benign well-demarcated tumors in the retroperitoneal or benign GI tumor that have extra serosal extension?
Sorry, the signal was not good just now. Could you repeat the question?
Yes. Can we use the same technique to provide access to the peritoneal cavity to remove retroperitoneal benign tumors or GI tumor with extra serosal extension?
Extraluminal growth? Yeah, sure. Sure. That's a field of node surgery, right? To remove peritoneal benign tumors or tumors originated from the GI tract but with extraluminal growth. And also we have a recent publication about this technique.
Okay, thank you. بيتعمل ديسكشن دلوقتي للسيستيك دكت خلاص شفناها دي. هو ماشي بارل ليها يعني من ماشي بارل كده على البوردر بتاعها ومخليه تحت.
And also with gastric access, there are also reports about liver biopsy, liver cyst removal, ovary cyst removal, and other surgeries performed by Chinese endoscopists.
Yeah, for liver biopsy.
我感觉好深好深了呀！给它展示一下。
这是胆囊管。
在胆总管看一下，这边好端了吧？
还有先断下来。这是汇合的地方。
Yes, I think this is where the cystic duct goes into the common bile duct. And the CBD is even deeper inside.
好，过来一点。二脚过来一点。
二脚。
这边有个黄疸的是吧？
有过的。
说明他这个
他发过2次，第1次没有黄疸，第2次有。
这个人他的胆囊管有石头的。
就是第1次。哦。
呀，那是个血管吧？分哪里了？有点晕了都。
Mr. Joe. Mr. Joe. I hope next week you in Egypt, in Cairo, to do this procedure in Kasr Al-Ainy. Next year.
这是胆囊管啊。
对，这边胆囊颈，这边胆囊管。
哪里深？这呀？
够了，感觉。
啊？什么？但是它这个是往上走的，那我们可以
双手了，感觉。
啊？哪里分？
你看这个黄的地方。
这里啊。
就是视野3点钟。
对。
到这了。
黄红之间这个。
你说我们今天还有外科医生在这里做咨询。
Yeah, we have a standby surgeon who is providing our evidence that this is the cystic duct and the gallbladder neck on the left side.
Actually, he is 他是我们的进修医生，这个外科医生。
And he is a visiting scholar at our center, and he originally is a surgeon, GI surgeon.
So in China, most general surgeons are even more interested in the endoscopy. They want to one hand to handle the laparoscope, and one hand want to handle the endoscope.
Sorry, I didn't hear you.
Our visiting scholar, who is a standby surgeon this afternoon, is a visiting scholar in our center, and he is actually a surgeon. And in China, more and more surgeons are interested in endoscopy, and they want to master both laparoscopy and endoscopy. And we are also seeking opportunity to combine the two techniques together.
这么长，
好长。
怎么这么长？
Yeah, this patient has a long and twisted cystic duct.
然后不行就是围绕着肉管道，然后再看看。
我想这里断掉。
啊，远点断没有？
来，夹子断掉再看。OK， 来，
شايفينه ده يا جماعه الجول بلادر نيك، يعني جول بلادر فوق ودي النيك اللي هو قاعد يعمل لها ديسكشن كل ده.
对吧？把它断掉，再看，对，等下来去那确认。
我觉得差不多了，可以了。
今天分得很长。
对。
这么长？来。
讲吗？我们要夹上然后断掉。
对。
Now comes the exciting part. We are going to keep the cystic duct and cut it.
Professor Professor Joe.
Yes. Yeah.
About
这是打囊。
the advantage of use double channel scope to introduce two instruments, one for grasping and another for cutting or coagulation. Would it help?
Sometimes it's difficult to handle the double channel scope.
Yeah, and as the double channel scope is also a soft scope, it is also different from laparoscopic when you can do grasp and coagulation using another scope, another hand.
很粗这个啊。
So now we will clip the system. Now we are clipping the cystic duct, right?
Yeah, cystic duct.
Yeah. يبقى هو
往下一点吗？
بتاع النك
往右一点吗？还要不要？
واصل للcystic duct.
Yeah.
clipping دلوقتي. الهيمو كليب هو فاير الكليب دلوقتي بحيث ان هو يقفل وبعد كده هيقطع جنبه على طول. هيقفل
不再夹一个了吗？
تاني كليب تاني وبعد كده يعمل اهو تاني. هو احنا شفنا جول ونازل النك بعد كده هتقول شفناه
就是连在，但是我觉得是搭上去的还是连上去的？
If this clip applied to the system duct is a special type of clips or the usual clips?
The usual clip. Usual clip.
We congratulate you. The anatomy is very clear and the bleeding is much less than the open procedure.
هو دلوقتي المفروض هيحط كليب تاني، بس هو لما حط الكليب الاولاني طبعا حطه في السيستك ناحيه الجول بلادر، يعني هو بيحاول قدر الامكان يبعد عن الكومن بايل داكت. هو دلوقتي عمل ديسكشن كويس جدا للسيستك داكت وحط الكليب اكتر ناحيه السيستك داكت. في نفس الوقت ان هو مش عايز يسيب سيستك داكت طويله، فهيبدا بعد كده يقطع ويحط الكليب. بعمل بس ديستكشن عشان الابلكيشن بتاع الكليب الثاني ما يبقاش صعب، او لو حطه ما يلاقيش بعد كده صعوبه في الديستكشن. هو شايف ان لسه في جزء محتاج يتعمل له ديستكشن، هيعمل له ديستكشن. نفس فكره اللابروسكوب او الجراح، ان هو الايدنتيفيكيشن كويس.
这个时候没有，还挺有优势哈。
وكده فصلها دلوقتي.
Hello, Professor Zhu, do you hear me? This is Shaima from Egypt.
Oh, Shama.
Hello.
Shama 来了。
We miss you so much.
Shama, Shama.
Yes, hello.
Hello, Anma, I have no time to miss you.
Really an amazing work. We are happy to watch it here.
然后吗？盐吗？有没有混回来？
妈的，多大的蛋呢？
好的。
兄弟啊，
兄弟，多大？
今天这个选的不好。
没事，但是还算是顺利。
别讨论，因为他们钟主任在嘛，5点他们讨论掉，不一定等我。我这个下不来，不要等。上面员们你们上面先讨论掉。这赶紧等哪管了？还挺。哪里是我们家的？
这条刚才看到过。
I think we have here some part we have to dissect it. هو دلوقتي يا جماعه لسه هو بيسلك اهو، لقى ان لسه في حته ما اتقطعتش، فاستخدم الانسوليتد تيب نايف.
就是这个白的吧。
يبقى هو هيدخل التيب زي ما اتفقنا كده بلايند ويجي باي سايد. يبقى الكاتنج بتاعه هيبقى باي سايد. حشرها فوق عشان يشد بيها ويقطع بالسايد. استخدم موضوع ان هو مش شايف ما وراء التيب دي ويقطع بالجنب. ويقدر حتى بيها كمان يقدر يعني يستخدم التاب الانسوليتد دي ان هو يشد بيها، غير النايف الثانيه لو جاي يشد هتتزحلق.
ده ده 哪去了？
بس اهو هيدخل من فوق اكتر.
这是哪里啊？
دخل
不是不是不是不是不是这里不是这里。
这是个什么管道？
不知道不是这里，但是
啊？
不知道，但不是这里，刚才切的不是这里。
我当然不知道。
嗯，
这是个什么管道？
不能断吧？不知道是什么。
我刚才讲有一个东西，啊，我是说一个横在那里说的。
里面有个东西，但是打不开。
那刚才切的地方不是？
是肯定是，但这是啥不知道。
وحشتنا يا بيه. اتفضل حضرتك، هم كده ممكن يسمعوك يا بيه. لا صوت حضرتك افتح المايك يا دكتور مازن. المايك بتاع حضرتك مقفول.
Dear Professor Zhu.
كده سامعين حضرتك، اتفضل.
Thank you very much for your effort and support for us in Cairo. We want to see you again.
Yeah, thank you very much.
Very nice work.
Professor Zhu, this is
So
Naga review.
when I finish my work in Cairo, I hope I can visit Sharm el-Sheikh again next year.
Yeah, we hope to see you in Sharm el-Sheikh and Aswan also.
Professor Joe, do you hear Professor Naga?
Yeah, I can hear from Naga.
Yeah.
Hello.
You to come here to do this procedure in Egypt, Cairo.
是这个管道，知道吧？我前面啊，刚才在胆囊管呢，
但是
在胆囊啊。
但是当时胆囊是把这放到天花板上进去看到的，对吧？
那个接着夹了。这是胆囊管的长的。
嗯，对
兄弟
对。
啊？
是。
这没等这出来，这是胆囊管的长的，看到吗？这是管道吧？
是的，是的。
啊？
是的。This is the stump of the cystic duct. 是的，是的，是的。
但是，
这个要泡一下吧。倪老师。
等一会儿。
I think now surgeon in Egypt must do endoscopy.
胆囊是不是下来了？胆囊被这个什么东西？啊？
这是我胆囊上面走的，出了胆囊效果。
来，还不到了，还不到了。
So you will clip the stump of the cystic duct?
这是个什么？刚才我一直讲的这个一来，它是这个妈的浆膜扭起来了。
你看下管子，
看到没有？
真的吗？
看到没有？
也有可能。
他妈的吊在那里，像个浆膜吊在那里，妈的绕了一圈，我当到像个管道一样的，看到没有？看到没有？就它，看到吗？
嗯。
看你。 那当然。
嗯。
So it's safe to dissect the tissue just close to the gallbladder. 这个。
看不出边来了。
没地方，没地方分，全部搭在一起知道吧？缺一个手拎一下，
对，
太大了，这
趴
胆囊
着。
趴在那里。要我学习就叫他们上面看看胆囊切除也可以呀。对呀，他们会议室也在放的嘛，好像。
那天有个病例讨论的，有个
病例的是吧？
嗯。
那他们讲了再说。这里没东西吧？
签到，力哥，签到。
让大家看这个也行。这没东西，这没东西，这已经没东西。
Professor Zhu, is the gallbladder still attached?
王老师，看看他们那个记者是不是宣传会的人是不是走掉了？
So Professor Zhu, you are dissecting the gallbladder from the peritoneum.
说啥？
咋了？啊？啊？
Some parts of the gallbladder is still connected to the abdominal cavity, so we are dissecting the remaining parts.
It's connected to where?
To the abdominal cavity.
The abdominal cavity.
So the majority has been dissected, but some parts are still remaining. 就那个痰端。
Still few attachment.
啊？不要干嘛？
痰端的后面那儿好像还连着一点啊。
不要干嘛？
但是那边是啥？啥东西啊？
这里有没有结构的东西？知道吧？啊？啊？啊？这个是个什么结构？这里面，张姐啊？
不知道。
啊？
知道。哎，血管。
哎，你不要笑。
啊。
就这个，看到吧？看到没有？
这不像人呢，还是他们。
هو احنا يعني كنا متخيلين ان احنا we are almost done. هي اتقطعت من cystic duct stem، فدلوقتي احنا بنعمل dissection من peritoneal fat. هو هنا بيستخدم hybrid knife، فقادر يحقن ويقطع ويعمل coagulation in the same time. I think يعني he will finish soon إن شاء الله.
为什么？
是啥？
怎么在哪？啊？在那病里面去了。
哎，编在哪儿？
啊？在下面。
哦，对，编在这里。
啊？这里怎么？对啊，这里也。
那中间已经有个洞了。
这是什么？这是什么地方？
这是刚刚染色的。这里应该可以。
那里怎么会长囊呢？啊？这是胆囊壁吗？
哎，这个地方应该可以连过去吧？这里从这个洞。
这什么东西啊？
哦，这个人肯定变异也很多的，已经都扭了。
做这个干扰控。
觉得这边应该可以连起来吧？从这左往右。
这个是可能刚才讲的所谓的胆囊血管。这个啊？
这么粗，有可能。
啊？
有可能。
刚讲的是胆囊血管。啊？
这应该可以。
这个怎么会粘在这里呢？
有可能发炎发的。
Professor Joe, this is the last.
时间快到了，你有说什么吗？没有，后面他们还有讲课。
这夹子是哪里的？大家是胆囊管的承担了，胆囊管的地方了。
胆囊管不会绕了个圈吧？对。
So Professor Joe, do you hear me?
Yes.
Yeah, is there marked fibrosis that makes the dissection not easy?
Yeah.
那个前端呢？哦，胆囊管切下来的前端呢？现在的前端呢？这是个什么东西？对。
这右边，5点钟是刚刚那个小豆豆，对的，就是刚刚觉得是前端的那个，
是吧？
嗯。
前端纹的前端。
这是我们刚刚切开的，原来是前端的，是这里。
这里吧？
嗯。
但是看到是管道结构吗？
是，切之前是，但切下来那个洞老小了。
就是大概是给那个意思。
Yes, right. The final cut.
Almost final.
Yeah, I think this was the final.
下来吗？
嗯，左边可能还有一点点。
这里有没有？是不是这里说刚才一个
好像不是。
有个硬的大圈套器。
So is it totally released, Professor Joe?
OK， 大的圈套器，不回的大的圈套器。这个孔大不大？啊？它的石头包的多大
1.1最大的。
多少
？1.1。
1.1啊。
多发最大1.1这么爆的。
这是胆囊吗？
是。
这是胆囊。啊？
是。
هو خلاص دلوقتي يا جماعه السكشن ومدخل سنير هيمسك بيه جول بلادر ويطلعها من الفتحه اللي مفتوحه في الاستومك. ده سنير عادي.
好大呀，满。
واتاكد تماما ان هي بقت ديستكتك وقلبها كده جوه البريتونيال. كده ما عادش لازقه في اي حاجه، لان لو في حته من اي جنب لسه لازقه وشدها يمزعها يحصل بليدنج. همسكها باللس.
不行，左边牵着。
松一点点。
موجود الحته اللي فيها
胆囊床。
是吧？连着哪儿吗？哎，可以。
لا هو خلاص.
可以。
وشدها وطلع بيها من الفتحه ويخرج بيها خلاص دلوقتي.
啊，那个什么呢？转播。导播。能拍一下这个吗？镜头过来拍一下这里。拍这里。
ثلاث سنير على حته صغيره اتقطعت، هيدخل يبص يشوفها فين.
麻醉师把球囊
马律师把球囊松一下。你先拍人吧，待会儿告诉你我过来，你再过来。
压在胃里面。
موجودة في الاستومك.
胃壁不够。
ممكن تكون هي الجول برادر احنا شايفينها كبيرة قوي، فممكن الفتحة بتاعت اللي موجودة جوه الاستومك تبقى ايه مش بتعديها بسهولة. هيمسكها تاني كويس بالسنير ويحاول يعمل الهزهزة اللي هو بيهزها بإيده وهو طالع عشان يحاول يطلعها.
ماشي.
كود جراسب. هو ماسكها ماسكة كويسة دلوقتي. هنشوف هو حتى بايده الشمال مثبت السنير على المنظار بحيث ان هو يبقى زنقها جوه كويس جوه الكاب. بتعاند معاه شويه بيرجع تاني. بنطلع الفورين بادي يعني بنطلعه كده بسهوله شويه. عنده الفتحه الاولانيه اللي الكارديا وبعد كده الابر اوسوفجيال. كل واحده بتاخد شويه مانيبيوليشن كده بسيطه لحد ما يطلعها. طول ما السنير يطول يبقى معنى كده ان هي مشدوده تحت. هيرجع يأثر. طلعت الجول.
Thank you. Congratulations, Professor Zhu, for this work. This is really a very difficult and tough case. Yes.
这个很长的胆囊颈啊。
就给我剖开来，就剖开来看一下。看一下。你拿
个夹子，拿个夹子。
Very tall.
Professor Zhu.
是在规定时间之。
Thank you very much. This is really.
You're welcome.
This is the
stone.
Yeah, the stone remained in the esophagus.
Yeah.
还有全套吧？
全套。
那
هو بيشد الستون وقعت من بيجمنت ستون اهي. محترمه خرجت من الجول بلادر. واعتقد دي كانت حاجات هي اللي مخليه خروجها صعب شويه كمان.
1公分，这不止，这个不止。
stones.
不管它。有什么问题吧？
这个地方分离的时候，这个地方说不
定。
胆囊这个地方。
对。
有什么问题吗？是一个洞吗？
一个洞，这是一个洞，这是胆囊这个地方。
胆囊颈一个，胆囊壶腹一个。
然后我现在给泡。
我要我主要看下面。The stone comes from the gallbladder of the mucous wall injury, the perforation of the gallbladder wall. 胆囊壁的破损的地方出来的，这个过程当中，你讲。
As we can see during the procedure that there was accidental perforation on the gallbladder wall, so that's why the gallstones came out.
Yeah.
Yes, we can.
And now we check the gallbladder bed. 胆囊床是吧？
You are checking the gallbladder.
有什么问题吧？
很好的，
这么
长，颈很长。
对啊，是的。
颈很长，跟那个磁共振里一样。
我操
When we check the specimen, we can also find that the neck of the gallbladder is very long, which is in accordance with what we see during the procedure.
这个夹子应该有问题啊。
对，你夹的是什么？
夹子这样没下来。
就最后一刀是在夹子上面断的，因为最后不是这边断了，上面还有一些吗？那一刀断的时候是在夹子那边。
So for this patient, the gallbladder duct is very, very long.
Yes, yes, we can see this.
Patient.
Yes, we can see this.
很长啊，胆囊管。
هو بيتشيك البيت دلوقتي
他说不能了，亲。
امور كويسه مفيش
I think now you can
هيموستاسيس ولا
remove to another room. The any other procedures?
Sorry, Professor Joe, can you?
We have almost, we have finished the majority part, and after hemostasis, we are going to ligate the cystic duct
这里
stump.
还有一段胆囊管。
There's some parts of the cystic duct remaining here. We are going to remove it, and then we are going to ligate the stump. And after that, we are going to close the perforation of the gastric wall, and then the procedure will be finished. Since we have finished the majority part, I think you can switch to lectures, as I think we have passed through the time limit.
Yes, yes, now we reached your time. Thank you very much for the nice demonstration. It was really an amazing work. We hope to see you next year, Professor Joe, in Cairo University.
Uh, 这是还有一个吊在这里。
对，它肯定是在里面折了。对，我们当时切的那一段，后面后面有一点。对，这还是胆囊管的组织。
是，把这个再去看一下这个胆囊管。
对。
夹的地方是不是一个腔？
扔。
拍一下。3点钟做的是吧？
还行。这个人因为实在是有点，石头，那个颈就在那里折啊折，拐好几个弯。结束了，转播结束了吧？转播结束了吧？他们好像去，应该是可以结束了。周老师，我们是继续还是这边继续还是怎么着？
什么？
我们这边继续录还是怎么着？
怎么录？
这边继续录吗？还是
转播还有吗？
他们好像开始讲课了吧？
听到没有？看一下。
那我不说话的就是。
看一下是一个胆囊管吗？是一个小管吗？他们要看的。对，他们爱看的。直接签。
طبعا الناس اللي هي متابعانا على الزوم اللايف والشانل بتاعت اليوتيوب والشانل بتاع الفيسبوك. احنا ان شاء الله طبعا السكند سيشن هننقلها من هامبورج من عند بروفيسور توماس روش، وحاجات برضه كده شايفينها. احنا دلوقتي هيبقى عندنا 3 محاضرات يعني صغيرين كده. المحاضرة الأولانية على المايكرو ديسكتومي اللي هو التكنيك بتاع المايكرو ديسكتومي، ودي هتبقى بروفيسور يونشي زونج. بعديها في عندنا محاضرة باريتس اوسوفيجاس with hybrid ABC، ودي طبعا تكنيك يعني مهم جدا جدا وفيري انترستنج دلوقتي، اللي هو الباريت اوسوفيجاس مع الهايبريد ABC، ودي هتبقى من بروفيسور دون جوانج. بعديها هيبقى عندنا محاضرة عن الاندو انجل، ودي برضو حاجة من التكنيكس الجديدة وحاجة فيري انترستنج بالنسبة لحضراتكم من عن طريق بروفيسور هونج جانج جي. بعديها هننقل اللايف كيسز تاني من هامبورغ في ألمانيا. فيعني نرجو ان المحاضرات دي تبقى لطيفة مع حضراتكم.
Professor Joe, thank you. Thank you a lot for your nice work. Can you please shift to the lectures? Can we start with Professor endoscopic microdisectomy?
可以了吧？他在介绍您，对。这不稳定吧？没事，你可以，因为他们稳定就行了，就是他们那边接收稳定。可以吧？现在看到我的 PPT 吧？可以。看到了，看到了，我开始了。对，我开始了。您共享了吧？共享就行。我试试看啊。共享。对啊。你直接讲就行。可以吧？OK， 我开始了。好。
Yes, hello. Professor Yonchi Zhang. Hello.
Hello. I think I should say good morning because maybe 11 in the Egypt. So first I will say thanks for Professor Naga very warm welcome invitation for me to give a lecture to this very large conference. I'm Vice Director of Endoscopy Center, Zhongshan Hospital, Zhong Yunshi. So this time my topic was the digestive endoscopic ternary technique used hybrid knife. This is my second time to give lecture in Egypt. Maybe the first time 10 years ago. As I think Cairo is very beautiful. Also, I'm also want to go to Cairo again when the coronavirus 2019 will stop.
You are welcome, Professor John, to Cairo.
Yes.
We hope to see you again.
Yes. So this is the
lecture, please.
This is the picture to show many type of resection work we do in our center, also in the world, including ESC for early cancer, ESE, STIR, or EFTR for submucosal tumor, and also the point, very famous for the esophageal achalasia. And nowadays, today you also see Professor Zhou do the notes to resect gallbladder. What is the DETT ternary resection technique? Go to our new use. So you can see it began in 2004. Cairo to do the first peritoneal biopsy in pig model, and then in 2007 and 2010 we do a lot of things to step by step to do a lot of ternary working. And in 2012 we do the first STIR in Zhongshan Hospital, April conference. There are a lot of endoscopic knife we can use, but especially in the ternary resection work, hybrid knife was the best choice. You can see this is a very typical case we call esophageal achalasia. To deal with this kind of very severe with cachexia or pneumonia case, we can use dilation with balloon or put a stent and also point. For some special or for some difficult case, we can use different type of method to deal with this kind of case, but the very, very useful one was the point. You can see the same case after we have treated 6 months, he became fat and he can eat a lot of things. This is the first time to deal with cachexia. And the next, why we must deal with esophageal achalasia, because it may be caused their earlier esophageal cancer. You can see this case because I have a long time of esophageal achalasia. You can see their mucosal lesion. The first we do point to let the patient can eat, and if he cannot eat, he will not have the main purpose to see our doctor, and then we can resect the earlier esophageal cancer. You can see there are 2 lesions. What the difference between the normal earlier esophageal cancer between in the patient, because a lot of fibrosis in submucosa layers. So we resect very, very difficult. We only can use hyperknife. We cannot elevate it. We only can use the hyperknife to resect just up the muscle layer. This is another case. Achalasia with mucosal lesion in EG junction. What the kind of the mucosal lesion? You can see just like a bridge. This is the entrance. This is just like a bridge in the entrance. Maybe she eat the vegetable. You can see the vegetable. I just ask her, when you eat it? She say, maybe 2 months ago. So all the food will in the bridge, and maybe it's the one kind of the reason she cannot eat. The first, we should resect the mucosal lesion, and then we will do point to let the muscle become release. Then the girl can eat things. And 3 months later, we have the follow-up. She is very good. The 4th case is the patient who received radical extrarenal partial gastrectomy, only 1 month. And then he cannot eat something. What the reasons? The surgeon is very, very worried about it. Maybe the recurrence? No. So you can see the obstruction site was the entrance in the EG junction. It was achalasia just after the gastrectomy. So we do the point for this kind of case. You can see this is EG junction. It's different between the normal case. There are 2 holes, which is the correct one to go to the stomach. We just only can use this hyperknife to injection and a cut, injection and cut to let us to find the correct route to just like do the normal point. So you can see we go to the gastric part and also do the myotomy. After 1 month, the patient can eat. Another case, also the same reason, but he received proximal radical gastrotomy 3 years ago, and then he cannot eat things. It's a recurrence after CT scan, no recurrence, but he also cannot eat. It was pyloric sparse. You can see it was what pylorus, the very, very close. Also, we have the same method to do what? To also do the myotomy, not in the entrance, in the pylorus. The same method to first to create the tunnel, and then in the tunnel, just in the space between the mucosa layer and the muscle layer, we go in and to find what is what. This is the pylorium. And also you can see it's very, very close, very, very clear. Just like a ring. And then use the hyper knife to do the myotomy. The patient can eat things. It's very, very, maybe you can think it as a very simple, but for the patient, it's very, very useful because she did not want to receive another operation and only can receive the endoscopy resection work. Also have a very good result. This is another case, very similar to achalasia, but not achalasia. It was esophageal diverticulum. The patient have the obstruction in the middle part of the esophagus caused by 5 centimeter diverticulum. How to deal with this kind of case? We use STESD also. It is not ejection. It was in the middle part. How can deal with it? Because this was a very, very large diverticulum, and this is the esophageal. So we also use the ternary resection to resect or to cut the one part of the diverticulum. And also after resection, the patient have a normal, we just can say it's a normal route to eat things. So I think the ternary resection work is a method. It can deal with a lot of diseases caused by different reasons. This is another case we called esophageal cyst. After the first, we have do the EUS pre-operation and find it was a very large cyst, and then we do the ternary resection. But after we have created ternary, we cannot find this one because it is outside the esophageal muscle. So we do the EUS in the tunnel to sure we have this kind of cyst. We call the retroesophageal cyst, and also we can cut the muscle to shoe the whole wall of the cyst. And after the cyst, we use APC to deal with the cyst wall, and then we stop the endoscopy resection work. 8 months ago, later, we do the follow-up. The cyst cannot be seen. We also know there's we can use the tender resection work to resect leiomyoma, very large cervical tumor in the esophagus. Maybe 10 years ago, the patient will to see the surgeon to have a very large operation. But nowadays we can resect a very large cervical tumor in the esophagus. But for this kind of very large ones, how we do stir, we can call it open stir because the mucosal layer cannot be untouched. It will also be resected. But after resect, we can put a esophageal stent, help the patient to go to the normal work as early as possible. And the stent will be put out 2 weeks ago. 2 weeks later, the patient very, very, very good. Another method, if the tumor is in one part in the gastric, one part in the esophageal, we can do EFR plus STER. How we do it? Because maybe a lot of doctors have done STER for some very large tumor. When in the end of the operation, we can find it very difficult to pull the tumor out, and also very difficult to see the base of the tumor. So if the tumor in some part in the gastric, we can open the base first. Open the base first, and the tumor have the space to go down. To shoot one, because the tumor also maybe have half part in the esophagus. So when we open the base, we can do the stir to resect the part in esophageal. Now we can resect it. You can see it's a very, very large one. Also, how we deal with this kind of wound, we can use the suture in the gastric and use clip to close the wound in the esophageal. The patient can go outside, go to his home only in 1 week. Also, we can see another kind of SMT. We call it a bomb. What is bomb? I think you will met this kind of one. It's a very small one. You can see this very small one, but I cannot see the base. What is kind of one? It was an aneurysma. So if you do not sure it was an aneurysma or tumor, you can use the ligation method to deal with this kind of case. If you cut it, they will cause a very huge, very, very huge bleeding. And in the esophageal, we also can do the nodes. This is the case we call it SMT. It is a lymph node just beside the esophageal. So we do the EOS in the ternary to make sure the tumor, we just can't the tumor, it was a lymph node is beside. Then we can open the muscle layer to shoot this one. This black one is the lymph node in the just beside the bronchial, and also in the colorectal disease, we also can use this kind of method. It is the endometrial cyst in the rectum. We use the ternary method to have a sure biopsy. And this another case have the rectal operation 3 years ago and have a SMT just in the right rectum. So we use a ternary resection to cut it. Also, it's a cyst just beside the muscle. Turner method to do this, also do the same work as we do in the esophageal. Okay, I use only 50 minutes to introduce our work to deal with some special case in our normal work. I think maybe it will helpful for our dear friends in Cairo, our dear friends in Egypt to do more tertiary resection work. Nowadays, we also in the Happy New Year time in China. So we also say Happy New Year to all the friends in Egypt. Happy New Year to Professor Daga. Happy New Year to all friends in Egypt. Thank you.
Thank you, Professor Chen, for very elegant lecture. And now we will shift to second speaker.
Thank you, Professor John. This is an amazing lecture, and we welcome you next year in Cairo, hopefully. So we proceed to the next lecture, treatment of Barrett's esophagus with hybrid APC, with Professor Dong Wang.
Yeah, hello.
Hello. محاضرة يا شباب. Professor Wang, can you share your presentation?
Okay, thank you.
Hello.
Hello?
Yes,
Can you hear me?
Yes.
Hello?
Yes, we can hear you. Can you please share your presentation?
Okay. Ladies and gentlemen, good evening. I'm Dr. Dong Wang, come from Ruijin Hospital of Shanghai Jiao Tong University Medical School. Today, I will share my study about efficacy and safety of hybrid APC ablation for Barrett's esophagus in 80 cases. Prospective multicenter preliminary study in China. As we know, the Barrett's esophagus is a potential disease. About 5% will development an esophagus carcinoma in 10 years. We have a lot of treatment method to treatment the BE, including the drug treatment, surgery, and endoscopy. As we know, the drug treatment for BE can improvement of reflex symptom, but it cannot preventing the canceration. The esophagus, the surgery can complete a radical cure for BE, but its advantage including lower quality of life and higher mortality rate. For the endoscopy, we have two methods. One is ESD, the other is APC. Relative to ESD, the APC has a lot of advantage, including easy to use, low hemorrhage risk, low perforation risk, and low stenosis risk. But for APC, we cannot use a histological evaluation, and we cannot know it's I0 resection. Here is a typical APC, routine APC. its lecture reports, we can see the remission rate is about from 60% to 90%, but the stenosis rate is about 9%. So for routine APC, how to balance the safety and effective, I think it's difficult. For the routine APC, the advantage is easy to use and effective, but the disadvantage, including security, not reliable. So for the APC, more effective, more harmful. No, we have a new method, hybrid APC. It's a water cushion APC technique together. For hybrid APC, the diameter is 2.3 millimeter, so we can use our endoscope to perform this procedure. And the length is about 1.9 meter. It's designed for buried esophagus, and it can prevent a stricture. Here is the image we can see. Here is a lesion, and this is a water cushion, and this is a hybrid APC. Let's look at this picture. Here is a lesion about 0.3 to 0.4 millimeter, and the APC, the depth of coagulation about 2 to 3 millimeter, but the water cushion is about 10 millimeter. So we can ablation the disease more safety. It's a hybrid APC. Some experts study the APC. Their article reports that to decrease the incidence of stricture, they can use a water cushion. And another doctor reports their research. APC add submucosal injection can reduce the depth of tissue injury. So we have a new solution in those hybrid APC, including the water cushion and APC technique. Here is a hair APC. Hybrid APC is APC and water cushion. It has a lot of advantage, including a single-use instrument, multifunction, including water jet and APC. It's designed for buried esophagus. Note in the procedure we can use one APC and no change of other instruments, and it's very easy to control the APC. It's a procedure. Here at the foot, we use a hybrid APC to elevate the submucosal. Then we use a hybrid APC to ablate the disease, and then we can ablate the disease. Here is after treatment. Here is an article to research the hybrid and standard APC. And here we can see for 50 watt, the histological depths, calculation depths, the hybrid APC is more superficial than standard APC. And here we can look at the damage to wall layer. The hybrid APC is better than standard APC. After 3 months follow-up, the rate of structure formation is about 2%. As we know, the standard APC structure rate is about 9%, and the complete remission about 96%, and the histological complete remission is about 78%. So the result is very good. So our study is designed prospective no control group. It's a multi-center research. Our study aim is to evaluate the efficacy and safety of the hybrid APC in treatment of buried. We have 80 patients in our study. The design defined of buried esophagus is esophagus squamous epithelial line had been replaced by metaplastic columnar epithelium, which is more than 1 centimeter, with or without intestinal metaplasia. Our endpoint is successful complete ablation of buried. The 3, 6, or 12 months after hybrid APC is followed by endoscopy. Here, operation is follow-up. It's our second endpoint. The number of hybrid APC procedure required for treatment of buried, and the operation time, the progression of buried, and the complication.
Can be devitalized by input.
Here is a video for hybrid APC. Here, we can see it's a short cap at the end of the endoscope, but we can see it's not very stable. It's very not stable. In our study, we use a long cap at the end of scope, so it's very stable, and we can destroy the disease very clear and very safe. So it's our experiment. So it's very clear and very stable. It's a result, including 80%. The shape of BE, the tongue shape about 38, the Iceland tip about 28, tongue at Iceland about 8, and cycle is 6. The length of the bee more than 3 centimeter, about 19, less 3 centimeter, about 61. Intestinal metaplasia about 39%, and dysplasia about 24. All operations were successful complete. Among them, about 40% of the operation were performed by attending physician. So it's very easy. So the next is performed by a senior endoscopist. The operation time about 10. So it's very quickly, and no serious complication. So it's very safe. One patient had a middle esophagus fracture after the operation, and one patient had a bleeding, but not use endoscopic treatment. We just use the medicine. One patient accept twice procedure because it's a cycle BE. 1 year follow-up shown that the recurrent rate was only about 3%. So in China, the BE is low damage. Most Chinese buried patients do not need endoscopic resection, but with intestinal metaplasia, B still has a risk of cancer and need treatment. The advantage of the operation is simple operation, low technical difficult and short time, and it in case of water low, good treatment, and low recurrent rate, and it have a multi function. So it's our study team. Thank you. Hello.
Hello, Professor Wang, thank you very much for sharing this very nice experience. This is really an interesting work. Thank you very much.
Thank you.
Now we move to the next lecture, new research of endoangle. Professor Yu. Professor Yu, do you hear us? Professor Yu? Professor Yu, can you share your presentation? Okay, thank you very much. Now it seems that Professor Yu is not with us. We can move on to Germany, back to the normal world.
May I ask Dr. Ayman, Dr. Hassan to come and chair this session, please?
Thomas, dann würden wir erstmal mit der Kamera so reingehen.
Geht's jetzt los?
Yes, hello, Professor.
Hello, good morning, Mr. On.
Thank you very much for your participation in the 16th EHGC, the Endoscopy, Hepatology, and Gastroenterology course of Kasr Al-Ainy, Cairo University. I transmit all the gratitude of Professor Mazen Naga and all the team. This session will be chaired with Professor Ayman Fayad, the head of gastroenterology department in the internal medicine department of Cairo University, and the Professor Hussein Okasha, the professor of internal medicine and gastroenterology with you. So it's all to you to start, please.
Okay, so good morning, everybody. It's, of course, a great pleasure to welcome you to our live transmission from Hamburg University Hospital. We are going to show you two cases. And the first one is a lady with long-standing achalasia. And as you know, the endoscopic procedure of POEM has gained widespread peer acceptance. So we will tell you a little bit more later on. And yes, you also see the endoscopic image. And we start with general anesthesia. So a patient has to be intubated. I think that's obligatory. And worldwide, I think most people do it, or almost everybody does it under general anesthesia. So I'm here with Sandra, who helps me. Left side, you can't see her at the moment, but maybe later on. Here we are, the two of us. And we also have a very nice and efficient team of general anesthesia. In general, I must say we love to work with general anesthesia. So we do a lot of therapeutic procedures in the esophagus, ERCP, long colonoscopies in frail patients under general anesthesia, or at least with anesthetic support. Good. So you see we are in a typical long-standing achalasia esophagus. We have the cap, the transparent cap, which we need for that. And there's no esophageal motility. So this is typical of a achalasia type 1 case. Of course, you have to have manometry or at least radiology to confirm the diagnosis. But here we're going down, and this is the sphincter. And especially, it's a little bit narrow, but not too much. So that depends. Some patients have a very narrow lower esophageal sphincter. This patient who had pre-treatments, I think with balloon, etc., the sphincter is not so narrow, but she has a clear-cut radiology image with the typical appearance of achalasia, and she also has manometric confirmation. So what we do when we start with POEM, we start at the esophageal esophagogastric junction and measure it. It's about at 45 centimeters from the incisors. And then we go back maybe a maximum of 10 centimeters, not too much, because it's not necessary to make a very long cut. And we're going to start here above the sphincter with our injection, needle out, and inject. So here we have the bluish bleb. Say we take saline and inject, maybe 5-6 milliliters. Okay, good. Stop. Then take the knife. So there's not so much distance, maybe 5-6 centimeters. But as I said, it's not necessary to make a very long incision. You just have to cut the sphincter.
Hello,
in type 1, the esophageal body musculature is not existent anyway. So it doesn't make sense to cut a non-functioning muscle.
Do you hear me, sir?
Pardon?
Yeah, you choose anterior approach, I think, right?
We choose the minor curvature approach. This is what we have been doing, knife out. So this is a triangle tip knife. You can use several knives, as you know.
Hello, Professor Ross.
Hi.
Mazen Naga speaking.
Hi.
Hi, Mazen. Hello. Very nice.
Hi.
Hi.
Mazen, very good to hear you.
Thank you.
And the question was, why are we doing this? Because I think we have been doing this from the very beginning. Some people, or a lot of people, following Haru Inu's advice, do it now posteriorly, but I think it doesn't matter. And studies have shown that there is no difference. So this is very typical. There's almost always a bleeding at the very beginning. And if you can't control this, it's bleeding all the time during the procedure. So we stop it with a cap. And I think we have to work this time with a coagulation forceps. So here's the forceps coming out. Two, we close the forceps. And we stop the bleeding, which is always laterally. So this might be long enough, but not yet. Okay. So you have to release the pressure. Not much bleeding, a little bit maybe. You can also, if you want, you can also dissect with the forceps. And we are not deep enough. There's still submucosa. I will show you later how you can dissect with the forceps. That has the advantage that when it's bleeding, you can just switch.
We have a question here, sir.
I beg your pardon?
What is the solution you use to inject in the submucosa?
Saline.
Just saline, Carl?
Yes, just saline.
It was indeed carmine.
Well, it's just normal saline. We inject with a little bit of methylene blue, not too dark. See, I can work, if I want, I can work with a forceps as well, which I often do in the cardia when there are a lot of vessels. Yeah, now we see the musculature underneath, and going back to the knife, because you can also inject with a knife.
Such long case of achalasia with extensive fibrosis, inflammation in the mucosa, do you prefer to add adrenaline to the solution used to inject?
No, I don't think that's... You may need it in resection, but I don't think it's necessary with POEM, because you can re-inject, and maybe you should not over-inject too much. Else. Because you should try to avoid damage to the mucosa. So we have to open the space, and now I'm in. And we very cautiously dissect. So what I do, so maybe you can show my hands with the other camera and focus. You know what I do? I have the knife out a certain distance, so I do not have my hand on the knife. I have the hands on the scope, and I'm working with a scope. So the knife is the prolonged arm of the scope, and I'm moving the scope forward and go alongside the muscular layer very cautiously. Initially, I do not want to damage the muscular layer, to avoid there is leakage of air.
Because you are using TT knife, it's not TTJ, but TT knife. You are dissecting with coagulation or with endocut mode?
Endocut mode.
Endocut mode.
I have the soft coag mode for vessels.
Yeah.
And it's the TT...
The power of the endocut mode?
TTJ knife.
This TTJ knife?
Yes. You will see in a second. So this is the position I like. On the right side, the muscular layer. On the left side, the mucosa. and stay away from the mucosa. So go, in contrast to ESD, go very close to the muscular layer. Now we don't have enough injection, right? So we take the knife and inject. Yes? Inject, inject, stop. Now we have our blue space again. Right side muscular layer, left side. What? Left side submucosa, and stay away from the mucosa. So initially when we were starting this, we had some surgeons visiting us. And one guy who was very helpful was Professor Fuchs from Frankfurt. And he was doing a lot of helamyotomies. He then was also doing POEM. And he said two things are very important. A is protect the mucosa at all costs. So if you have a vessel and if it's bleeding on the left side, be very cautious not to damage the mucosa because that's patient's life insurance. And the second rule is make sure that the closure is good at the end. Because at the beginning we were very afraid of looking into the mediastinum, and then this was all very new to us. So still, very slowly, every vessel has to be killed. Sometimes there are minor bleedings a little bit later. So try to keep it very dry. If this knife is not enough for coagulation, take the forceps. Here again, we have the same image. Right side muscular layer, straight on submucosa, left side mucosa. Stay away from the mucosa. I say it again and again. Again, a slight bleeding.
And would you show us the set of your electrosurgical unit?
Yes. Well, I don't think we can focus so far, but we have an endocut Q and soft coag at 5. Because the knife is not very good for coagulation. So, Rein, if you have a larger vessel, you have to take the forceps. Jetzt spritzen. I think we are at the sphincter already because it's getting narrow. So if this type of bleeding starts, I like to go back to the forceps because if I hit a vessel, I have the forceps right here and can coagulate. Whereas when I hit the vessel with a knife and the coagulation doesn't work, then, I have the exchange time. And as I showed you, you can make very short bursts here with endocut. Again, coagulation. And at the cardia, they are usually vessels. So here's some vasculature. And now I have overview again. So very slowly, it's not a race. Always try to keep a good overview.
So now you are dissecting using the hot biopsy or by coagulation.
The vessels, yes. So I'm cutting with the forceps, with the cutting current, the endocut. And if I have a vessel, I do coagulation. Very slowly, take your time. And always get back. Here we have some bleeding. So I can stop it right away. Mal auf, bisschen. We open it now a little bit and close. Close. Stop. Okay. Auf. So what's also seen that at the cardia, the musculature gets thinner. Spritzen. So we take, an injectate. I'm already at 45. So I think I'm at the level of the cardia. Now, We take the needle and, you know, it's very thin on the right side. See that? So sometimes you even have an air leakage into the abdomen and you have to puncture. So I'm feeling the abdomen of the patient, it's still soft. And another thing I'm looking at is the peak pressure on the anesthesia machine. So it's 13, but when all of a sudden it raises to 18 or 20, then I know it's probably air in the stomach. Another little trick is maybe we can focus here. If I exchange accessories, I make this little marking. Can we focus a little bit more on that image? No, other way? Good. So this little marking helps me when I have to introduce the instrument very quickly. I know when to stop. That I don't poke the tissue with a needle. Injecting is usually with needle in, not to injure vessels. Now inject. Stop. Works nicely again. Sometimes if I want to get deeper, I get the very close nadel raus. And so I very carefully penetrate and inject. Okay, stop. Forceps. You see now we have a nice image, right side musculature. The submucosa is a little bit thicker here and there are probably a lot of vessels. So it's wise to be cautious. Be aware of vessels. Don't be too quick. Don't cut through like in a race. And you have to slow down at the cardia. So I'm reintroducing the forceps. Of course, I cannot inject with the forceps. That's the downside. And I think there are some vessels. So I will do some change between, I will have my marking again. Some change between coagulation and cutting. And this forceps is pretty big. So you have to take it back like this. It's like a stamp doing stamping. Here we have a little hole in the musculature. No vessels, hopefully, but I'm doing stamping. Very cautiously. And if I get a vessel, hit a vessel and it's bleeding, I can immediately coagulate. I'm going to the left side. So now I'm really in the cardia. You see a lot of vessels appear, like here. So I have to be cautious. I have to coagulate them first. And then I can go auf. See that? So that was not enough, but I'm immediately on the spot with the forceps. Drehen, abmachen, drehen. So you can rotate a little bit because it's not in a good position. Auf nochmal. Close. So now it's quiet. I think it was a good example how helpful the forceps can be, because if I cut and it's bleeding, that was quite a moderate bleeding, then I have to take all my time to exchange the instrument. So I'm just on the spot and keeping the vessel in place. Open. Close. Open. Little. Two. So now it looks ugly and we do some re-injection to get a better overview, because it looks like a black mask actually with two eyes. And what I'm going to do is now finish the tunnel. I think we are almost at the end of the tunnel because we are at 47, but we need a better overview. I need to make sure, spritzen. Stop. So we want to have the blue color again, spritzen. Stop. Spritzen. Stop. Okay, so it's coming back, you see? And there's still, now we see the big vessel. Spritzen. And there's a real, die Zange. You know, there's a real defect on the vessel here. You can nicely see it. So it's not yet done. Schnell die Zange. Okay. I keep it by sucking it a little bit into the channel. And now I can quickly process until the marking here. So I'm going slow. Okay, here we are. And you have to totally kill that vessel auf. Bisschen zu. We have the vessel, there's still blood flow. Auf. Good. So, not yet. So this is the dangerous side because it's at the mucosa. Be very cautious. And maybe you make just a little auf, bisschen. So. So we grab it, only a short burst. Okay, open. Maybe one more. Good. So let's have a look inside. And then we present you some data in between. I finish the channel and I come back for the cut. So let's see. How does it look like? On the right side, you see the injection. It's not very blue, but you can see it because the esophagogastric junction has vanished. Here is the injectate, injectate, injectate. So we are beyond the cardia. Yeah, see that? I don't think you need a second scope to figure that out. So what I'm doing is to suck air out of the stomach. The abdomen is still soft. We do not have any emphysema. So everything under control. The anesthesiologic parameters are fine. And we are cleaning the scope a little bit, cleaning the esophagus. And Carsten, if possible, we can switch to our colleague Yuki Werner, who wants to present you some results with regards to POEM and other measures. And I'm coming back in a few minutes. Carsten?
Okay. Hi, Salam alaikum, dear ladies and gentlemen. I will speak about POEM and give you a short overview. So first, as you can see here, this is a classical aspect of upper endoscopy for achalasia, remnants in the dilated esophagus and a patient with long-standing dysphagia, typical findings. And achalasia is confirmed by the high-resolution manometry with the missing relaxation of the lower esophageal sphincter, as you can see here, and with the missing of propulsive waves, peristaltic waves in the esophagus. So just a minute. Fange ich nochmal an oder bin ich im...
Can you please share your presentation?
Can you hear me?
Yes, we hear you clearly. Hello.
Okay. No, they can't.
Can you please share your presentation?
Please. Could you please start our video? I think it's in your technical apartment.
وقف الفيديو وتشغل البرزنتيشن بتاعتها ولا؟
Sorry, here is the technician from Germany. You stopped our video. We share our presentation in the camera picture. But you have to restart our video again, please.
Professor Roche, we will do this soon.
You have to restart our video in the Zoom conference. You stopped our video. Our camera.
Okay.
Yeah.
Yes, we are doing this now. The
Okay.
ultrasound to fix the problem.
Okay, perfect. Thank you very much.
Where's the video finally? Start our video. Yeah. It's the camera. Hello? Yeah, no, we are sending you the video. We are only using the camera. And you see the PowerPoint in the camera you had from Professor Rush a minute ago. But you stopped our video. I cannot restart my video in the Zoom conference because it says I cannot restart the video because the host has stopped us. Yeah, 1 second.
We are trying to fix the problem.
في حد عنده أسئلة يا جماعة؟
Professor Roche, did we fix the problem?
Yes, we can see
yes,
you.
now it is fixed.
So,
Yes, it's okay.
so should we go to Thomas back or?
Ja, dann,
You are now with us.
dann lass uns, wir gehen zurück zu Thomas.
Okay, just a minute. We go back to Thomas now,
We will do the lecture later.
and we will do the lecture later on.
So we finished the channel, but there's something very interesting. So there's a bleeding vessel on the wrong side, mucosal side. And I'm very afraid of the mucosal side because it can be very unforgiving. So what I did, I was injecting on this side. And now we very cautiously open the forceps. Bisschen zu. So I grab the vessel, I pull it, and only a very short burst, because otherwise you would get damage to the mucosa. See that? Okay. So here, I think you can also clearly see here is this with the sphincter level about. So when you go back, here it's getting narrower. That's the sphincter, which you can nicely see. And below the sphincter is the cardia. We still injected the cardia a little bit to have space if we want to go on there. But now we start with a cut. Here you see it. Okay, so how long shall the cut be? Maybe a few centimeters, like starting here, raus. We change the setting. We now have spray coag. And if you want, you can make some markings. So I think that's high enough. Or we start here a little bit. So as I said, it's not necessary to go too far. So we take the spray and hook in and then cautiously push downwards. Then it opens up. Not necessary to do the full cutting in one go. So we push, and here we see still transverse muscle. So here's the sphincter level. And then we can take the same route and open it up a little bit more. Just very gently. It's not the Olympic Games, you have time. Here we see a little hole into the transverse muscle. So we hook in here very cautiously. Then I turn my instrument left and I go downwards. We cut. Always get your orientation, whether you are still in the right plane and you are away from the muscularis. Go back and see where we are. Here is the longitudinal muscle. We can nicely see it. Here is still circular muscle. And we split the fibers. Rein raus. We have some dirt here. So it's always important to have a good overview. And we push gently in.
Professor Roche?
Yeah.
I want to ask you, in such a short tunnel, you don't prefer to do a full thickness myotomy from the...
Finally, yes. But it doesn't have to do with the length of the tunnel.
I mean, we are very close to the cardia.
Yeah, I'm now at the cardia. So you can also cut backwards. Always suck out, keep your overview. It's not yet done, see that?
Yes.
So here it's done. We have, I think, almost full thickness. Here's the cardia. So we go on, cut, cut, cut. Now it's more open. Again, we have full thickness. Here we have some residual fibers. Clean your lens. Here is probably the most distal part. Here we have some slight bleeding. So what we could do to improve visibility, Rein, we inject a little bit more in spritzen. Okay, stop. Now we see it. Huh? That's the wrong side. That's the mucosa. Here is the lower end raus of the musculature. We cut. I'm still in favor of full thickness, actually, and there's no proof that cutting less reduces reflux to some extent. That might be far enough. I'm at 47. Here we have some longitudinal fibers adhering to each other. So let's very cautiously open them. Here again. Here the last ones. So this is the most distal cut to the muscular layer, I think. So we have and that's a thin musculature. That's the distal one. We have a nice view. It's all open. It's all open. Here we have some remaining fibers, but they are mostly longitudinal. We can cut them. It's a little bit burning here, too much maybe, but okay. Slowly, no rush.
Break sir, Professor Roche. This break
biopsy? Oh, sorry, what?
We are asking about the mode you use in the myotomy. Is it spray coagulation?
It's spray, yes. The new spray, as you see, is a little bit more aggressive.
Yes, we
So I
can.
think we are pretty high up.
On which what you adjusted?
The settings of the spray coag, please.
Yes. It's 3, I think, yes, 3.0. Good. So let's check. I think it could be finished. Let's check the lower sphincter. And I think it's nicely open.
Yes, it is.
And what we should do is also suck out the air from the stomach. And then there must be a soft mucosal prolapse. Yes. Huh? I think that's a nice result.
Yes.
Very soft, no resistance at all. So we clean the scope for a second, and what you could do actually is, if there was some bleeding, so you leave the patient for 5 minutes, have your coffee, and after 5 or 10 minutes you come back and see whether there is still no bleeding. So in this situation, there was not much bleeding. There was one moderate bleeding, which we could manage quickly because we just had the forceps in situ. Now we have a better view with alcohol cleaning of the lens. And here we have the entrance. The bleeding comes from above. So let's see whether there is something left, maybe here. Yeah? Messer nochmal? A little bit. So here we are at 42, 43. The sphincter was at 45, 46. So it's a little bit variable, you know, all these indications.
Well, Professor Rush, have you experienced some cases of delayed bleeding from pollen?
Delayed bleeding?
Yes.
Yes, of course. That's not very pleasant because it's we have never opened it again. So one case early on had to be operated on or drained because it bled into the pleura. So here we have, you see, longitudinal fibers. We still can open them to open everything here. Now it's open up here. And maybe last cut here, very gently. And then we suck off the dust. We maybe want to wash the cap like here. So I want to have a good view. And this might be our last entry into the channel. So let's see from here. To here, it's open. No musculature, all very clean. Sphincter level. Diaphragm going down to here, 48. I think that's enough. That should work fine. We take some pictures. So 42 to 48, 46. So that's our 6 centimeters. I think that's okay. And now I will show you closure. Wo ist sie denn? Wir nehmen einen gelben Clip. Yeah, there's a whole variety of clips. Gelb. We often start with Microtech clips, but you could also take other clips. I think it's best that you get used to one type of clip. You know, we have checked the lower sphincter, as I said before. We have checked the integrity of the mucosa. It's still very open and soft. True.
So we are asking about the complications that you may experience during POEM procedure.
Yeah. A bisschen drehen. Just a second. I talk to you in a second. So the first clip should be placed underneath. That's the most important one. Drehen noch. You have to rotate in the right direction, then open. And underneath, you get a fair, a half a centimeter, close, not shoot, and then pull a little bit. Yeah. And you see, okay, it's good, and shoot. Dann einen blauen. So if you are not well trained in clipping after POEM, you will be an expert. So this, then you can pull it a little bit, push it downwards, so that you have a straight line, and that's why the first clip is so important. So the second one can be smaller. It's another Microtech clip. And if we pull, we can then pull both sides a little bit out. Auf. Yeah, zu, drehen. Has to be rotated in the right direction. Auf. Like here. Not too big. Close. Pull a little bit. Yes, and shoot. So jetzt nehmen wir einen Olympus. We can also take the good old Olympus clips with a loading device, which has been reprocessable, but is now coming as a single item as well. So that's, as I said, rule number 2, make sure that the closure is perfect. Take your time again. Some closures with a very thick mucosa can be quite painful and time consuming. But here the mucosa is thick, but it's still soft. So here's the good old traditional clip with the loadable devices. Of course, you cannot reopen it. So if you do that, you have to be very careful. Open. Rotate. It's not a good position. Stop. Then you do the same thing. You go in a good position from both sides. You adapt. You close, noch nicht abschließen, langsam zumachen, slowly, slowly, and before you shoot, you pull a little bit and shoot. Good. I like that. Okay, next one with Olympus. So there's always an easier side and a more difficult side. The easier side is the right one because you have more to grasp, and the more difficult side is the left one. So you have to make sure, like here, that the clips are entirely in place.
So Professor Roche, you are now using the reloadable clips, right?
Yes.
Yes. But sometimes you find it difficult because it closes once and you cannot reopen.
Exactly. So if I'm not sure, I take a clip which I can reopen.
Okay.
Open. I just wanted to show you the variety.
Yes.
So this is already good, I think. So turn around to the right side and close. Noch nicht schießen. And yes, shoot. Okay. So now it's a little bit flatter. I think we should have a Microtech clip in between to be on the safe side.
Yes.
Yeah, it's flatter and it'll be okay with the Olympus, but I show you the varieties. And blauen.
Yes. This is really interesting.
Yeah, it's. I'm happy with that. It's on both sides, and I place them pretty narrowly, that if one falls off, the others will take it, and start below, as I said. So let's have a look at this one. Maybe 5 more minutes to go to tell the general anesthesia that the patient should not be awake too early.
Yes.
Auf. So now I need the left side a little bit more, like this. I rotate and let's try, close it. Ah, it's okay, very good. And shoot. So what shall I take next? I think another one, huh? Another reopenable one, because it's getting flat. Or do you want me to use the Olympus one? Blower. No? No protests? Okay. Again, take your time. And of course, the assistance is crucial. So the slow movement, the coordination with yourself. So I'm very happy Sandra is with me. And she does it even if you wake her up at 3 o'clock in the night. She does it in the same perfection. Open. Yeah. So let's grab it. Not sure, but let's close. Yes, shoot. Okay, that could have been the last one, but I want to have another one up there. Nehmen wir jetzt mal einen gelben. Yes? Good. So that was a good one. So it took the other side very nicely. But I want to avoid that there is a little pocket. I think that's the upper end already. So I place one clip above to take the tension away. Okay. So Sandra, great finale. Mal drehen, rotate. Ah, okay, back a little bit, tiny little bit back. Ah, wonderful. Oh, open. Okay. So not too close because the pocket is then prolonged. About here, close. So we take the whole, very good, and shoot. So this takes the tension away. And if you want, you can place maybe another blue one in here to be super sure. It's not mandatory, but yeah. So we get the final one. This was not the final one. We can, in the meantime, go down again, suck the air off. It's also remarkable when the sphincter is intact, you often get a huge air collection in the stomach. So sometimes patients get a big abdomen and it's not free air. There's too much air in the stomach. So you go down, but when the sphincter is open, there's not so much air collection anymore. Huh? Another thing which is interesting. So let's get out with a hopefully final clip. Good, go back. And yeah, wunderbar, open. So again, more on the upper side here. And close. Good. Yes, shoot. So I think that should be pretty safe. And I'll make a last photograph from the open sphincter for our files. This looks good. And that was it. So we now can go back to Yuki and check whether her lecture is running. This poem is finished.
Thank you, Professor
Roche.
Once again, salam alaikum.
Speaking.
Colleagues, I will speak about.
Could I thank Professor Roche first?
A short overview. Here you can see this. This is a classical aspect in upper endoscopy, of course, for achalasia with food remnants and the dilated esophagus. And achalasia is confirmed by high resolution manometry with the missing relaxation of the lower sphincter, as you can see here, in contrast to the normal finding like this. and with the missing peristaltic waves. So this is typical. And this is a second case, which is a bit different. And this was a 29-year-old patient with retrosternal pain and intermittent dysphagia. And in this case, you can see that the mucosa looks quite normal, and the barium appears, the barium swallow appears also quite normal. And we have, of course, to exclude any underlying histological ground for the reason for dysphagia as eosinophilic esophagitis. And in this case, only the high-resolution manometry can detect or detected the underlying achalasia, even in a special swallow protocol, the so-called multiple rapid swallow test in this case. So this is the typical aspect of type 2 achalasia. And as you are an experienced audience, of course, you know that achalasia is the best studied motility disorder. It is a rare disease, and it is chronic and benign. Male and female rate is 1:1. There's no ethnic preference, and the onset average age is about 50 years. The main symptoms, of course, is dysphagia in over 90% and can be combined with regurgitation, pain, and weight loss. And we use the so-called Eckardt symptom score. It is a combined symptom score of the four aforementioned symptoms, which are graded in 0 to 3 points of each symptom. And we use it as to indicate or to have an indicator for the symptom severity. So 12 points is worse and 0 points is best. And we also use this Eckardt symptom score in studies and trials for the follow-up of patients. Well, the average delay between symptoms and diagnosis is 3 years, and this is very important to know. High-resolution manometry is the diagnostic gold standard in patients with dysphagia. Of course, if you can't evaluate any endoscopic reason for it. And here you can see the catheter with multiple pressure sensors each centimeter, which is inserted in through the nose and swallowed by the patient. And then you can follow and evaluate each swallow on the screen in real time. And this is an example of a normal swallow, of course. As I mentioned, here's the upper esophageal sphincter. This is the lower esophageal sphincter. In the normal swallow, you can see you can really see the relaxation of the lower sphincter and the peristaltic wave. And we can evaluate about 97% of underlying causes in these dysphagia patients. So this is the gold standard. Also for achalasia, the subtyping with HR manometry is important, as it can be prognostic. We differentiate 3 types: type 1 achalasia, type 2 achalasia, and the specific one, the type 3 achalasia. In our presentation, in our presented case, it was a type 1 achalasia like this. Most often you can find the type 2 achalasia, and the type 2 achalasia is the best, oops, the treatment success in type 2 achalasia are best in contrast to type 3 achalasia, which is often difficult to treat, as you can see here. So, and next is now paraoral endoscopic myotomy, the POEM. As you know, it was introduced in 2010 for the treatment of achalasia as an absolutely new and innovative concept and technique. Just in short here, the 5 principal steps, as you have already seen: incision into the submucosal space, creating of the submucosal tunnel, then starting the myotomy along the submucosal tunnel. Myotomy is going through the LES into the cardia, and then the finished step by clipping. And through the years, multiple modifications of the technique are created for treating other diseases such as gastroparesis or Zenker. And since a little more than 1 year, we have the results of the first multi-center randomized trials of POEM and achalasia treatment, which I will shortly present here. So the first trial is POEM in comparison to pneumatic dilation by the Amsterdam group in achalasia patients. They so here there were 64 patients for POEM in comparison to 66 patients with 1 series of pneumatic dilation. The primary endpoint was the success rate after 2 years. And as you can see here, 92% of patients of the POEM group were successfully treated by POEM even after 2 years, in comparison to just a half a patient with pneumatic dilation. So POEM is better than dilation in the treatment of achalasia. And secondary endpoints in this trial are also interesting. So we can see that there were no complications in the POEM group. The esophageal function tests were equal in both treatments, and development of reflux esophagitis. This is a very important point, of course. At the 2-year follow-up, you could see about 40% in the POEM group, whereas only just 7% in the balloon group. So, and the second randomized trial, which we were conducted with 7 other European centers. We compared POEM with the laparoscopic halamyotomy, the gold standard in achalasia. And in this trial, we included patients with a symptomatic achalasia. That means that they had an Eckert score of over three points, and these patients were included and were randomized 1-to-1 in either POEM or laparoscopic halamyotomy with door funduplication. And they and here you can see the follow-up, the great follow-up, about 5 years, in which we evaluated clinical results, endoscopic results, and esophageal function tests as well. The primary endpoint of this study was the success rate after 2 years, where evaluated by the Eckert score and in a non-inferiority design. So here comes the results. The study population included 221 patients we treated 112 patients with POEM in contrast to 109 patients with LHM. And the baseline data, the baseline characteristics in both groups were equal or similar, as you can see here. And 1/3 of patients had a prior treatment, had already a prior treatment that failed for these patients, normally pneumatic dilation or Botox therapy. And here are the results. As you can see here, after 2 years, the treatment success rate were nearly equal, 83% in the POEM group and 81.7% in the LHM group. So in our non-inferiority hypothesis, just prior the trial start, is confirmed by the results, as you can see here, and we can say that both therapies are equal in treatment of achalasia. Well, our secondary endpoints are shown here. We can say that POEM is really safe, as in the aforementioned trial. There were only 3 adverse events in the POEM group. It's about 3% of complication. And on this slide, you can see, well, a follow-up of 1 patient where for the function test by HR manometry. This is a patient with a high pressure relaxation pressure before POEM, and then that drops. After 3 months, there was only a ERP of 5 millimeter, and even this was stable at the 2-year follow-up, and this patient was absolutely fine with it, no symptoms anymore, and it's good. The other 2 things we evaluate, can we say about the function tests by manometry, as you can see here, dropped very, very good, like this. And also the quality of life raised up in a good manner. And this is again the reflux data. This is very important to see in the endoscopic evaluation. You can see here both comments. On the left side is the POEM group, right side is the LHM group, and in the 3 months follow-up, we see much higher rate of reflux esophagitis. It's also just minor grades A and B, LA, A and B, but it is greater in POEM than in LHM. And this is also seen in the 2-year follow-up appointment. But now in the 2-year appointment, we see that it's a little approach. They approach each other. And it will be very interesting how it comes out in the 5-year follow-up. And the other thing is what we see is that the grades for C and D, more severe reflux grades, is quite stable. And this is, well, this here shows you the PPI medication in these patients. And there we can see that at the 2-year appointment, the patients with POEM have a greater intake of PPI than LHM. So what we can say, my summary, the midterm results from the 2 randomized trials establish POEM as gold standard therapy in patients with achalasia. POEM and LHM are equally effective. POEM is more effective than pneumatic dilation, with 1 series, of course. POEM is safe, and gastroesophageal reflux rates differ between study groups at short and midterm. 5 years follow-up data are awaited, and I think it will be this in the end of this or next year. Thank you for your attention, and salam alaikum. So we will give to Thomas, I think.
Thank you very much. Alaikum salam. Yes, Professor Rush, we
Yes.
are back with you.
Okay, I'm now in a different room together with Ramona. So maybe, yeah, the two of us can be shown. That's I like the right picture because it looks like in sunshine. But okay, so this is a elderly lady with who was referred for multiple polyps. And you know, we are in the endoscope in the cecum. My colleague Dominic Rea was kind enough to clean the colon. That's very important. And we'll show you the current tricks for polyps, even for small polyps, how to find them. First thing is maybe yourself. So it's best if it's not the 20th colonoscopy in a day and it's 5 o'clock. Then your chances of a good adenoma rate decrease. Second thing is a good scope, high resolution. And while we were showing the Olympus scopes for the poem, which I've been using from the very beginning and I'm very, very familiar with, this is now a Fujinon scope. And of course, it has imaging functions. So that's the LCI mode, which looks a bit pinkish. You have to get used to it. Laser color imaging. And there's the BLI mode, blue laser imaging, which is sort of very similar to the narrow band imaging mode of Olympus. Okay, let's go back to the normal one. Then we have a cap. So maybe we can focus in the endocuff vision cap, which you can show here. So it's a cap with little side arms. Yeah, and when you go through the colon, so let's see, that's the colon. Then when you are on the sides, you can flatten the folds. And it's not, my finger is too big, sorry for that. But I tried to show it to you. When you go back, these arms, they flatten the colonic folds. So you can look behind folds, which is especially nice in the sigmoid. That's number one, that's mechanical. So I can try to show the arms on the sides. Habt ihr das wirklich drauf? Huh? Yeah. So Ramona swears there because I don't see any arms, but we will see them later on. So this has been reported to increase adenoma, and the other thing everybody, that's a must-have nowadays, is artificial intelligence, because I'm afraid we are not intelligent enough. But anyway, so you can, here in this, you can switch it on, cat eye on and off. Good, so I switch it off. And if you're in the cecum, you should, there are some areas which you should look at. And so have you seen some polyps? Here's the valve. Below the valves. Let's ask the moderators. Have you seen polyps already, or do we need artificial intelligence? Can you hear us?
Yes, we can hear you. We don't eventually see polyp.
No? Okay, so we need the artificial intelligence.
Yes.
Do you prefer to do rate reflection in test if there is any polyp related to ileocecal valve?
Yeah, there it looks polyp. So we had a signal here.
Yes, there is.
Here we have a signal, but it's not persistent. It shows you some folds as well.
There was also a signal above the ileocecal valve.
Yes, here is one.
This one could be.
So it doesn't recognize it from the distance so well. See that? You have to go a little bit closer. And there was another one with the ileocecal. So is that the ileocecal valve? Maybe. Yes, that's the valve.
Yes.
But there is one, huh?
One, yes. This is a one.
Not a big one, but a nice one.
Yes.
We can switch to the other modes, and the system also tells you what it is, hopefully. So here it says it's hyperplastic. Well, what do you think? I think this system is very new, and it's not very well trained or it's not trained at all to differentiate serrated lesions and hyperplastic. And I think in the right colon, it's very often it's serrated lesion. But anyway, you have to take it out. So sometimes, you know, nowadays, the other fashion is cold snaring. So we'll do cold snaring. Actually, we have to look for the first very small polyp again, because it might be below a fold. That's the trouble with small polyps, huh? I rather prefer to resect large polyps than chase the very small ones. But let's go for this one first, and then the other one. So when you are not nicht ganz, when you are not capable to do this on your own, I rotate the scope. I can use the scope again, and slowly, it's moving on zu, on zack. Might have worked or not, so let's see. Yes. So the little one is open. Here. Here is one. But where's the other one, the very small one? The tiny baby. I think it's somewhere in this fold on that side, I think too.
Type of this snare and its size.
It's 7, oder? Das ist eine 7 oder 10? It's 10 millimeters. Sometimes it's too big, so you don't have to open it fully auf.
This 10 millimeter.
It's 10 millimeter, right? So for the very small ones, so the very little one is hiding from ourselves. And at the end, you should ask yourself whether it's really necessary to. What you can do is then rotate the scope. And here we are. So push forward. Is it really true? No. Yeah, doch. And here you are, we are slipping. So that's a micro polyp. Two. Good. Okay. Now you have another one. Okay. Auf. I don't know how you think in Egypt. Sometimes I think we are overdoing it with the mini polyps. And it's not very good at a colonoscopy. Each colonoscopy takes an hour and ends up with a number of very small polyps. So here's the first one. So let's get this one. Suck it into the instrument. Spritzen. Mit der 20er. We have to flush the channel.
Minute forceps with a biopsy forceps? I mean the minute polyps with a
it's not easier. And even for it's not easier.
For the minute ones.
Yeah, even the minute one. They're also sometimes hard to hit. And you are more complete with the snare. It's a little bit more expensive, not so much, but I changed to, here's the valve. I changed to cold snaring because it's quick. You cut everything off. Mostly you cut too much off.
And what about, sir, if you find
Here we have our arms. See them? I'm glad that you didn't forget the cup.
Sir, I have a question, please. If
Yes.
you have a polyp about a little bit more than 1 centimeter, will you remove it by cold?
Sorry, I have to put it louder. So here I am. Sorry. You say it again.
If you have a larger polyp, slightly more than 1 centimeter in the cecum, would you remove it also by cold smearing?
Yeah, if it's a very flat one, a serrated one, yes. If it's bigger and thicker, maybe no. What also people do is retroflexion. Some do it regularly. I'm just afraid to find more very, very tiny polyps and having to spend too much time with them. But there is nothing substantial, I think. So that's the right curvature. Ah, here we have one. So artificial intelligence helps, huh? It sees the very small ones. Ist der Polyp in der Falle? We had a polyp trap schon rausgeholt. What you also should do, if you have one of those small ones, so just remove it right away. If you slip back or if you have to clean, sometimes you won't refine it, especially with colonic motility. So this is, let's ask the system what it is. It is neoplastic. So it says it's an adenoma.
Yes, it looks like tubular adenoma.
Yeah.
Yeah. So AI can help in identifying the pathology of the polyps.
Well, there are no good data as yet open. And the question is, what do? You still send it to histopathology. Moment, ein bisschen zumachen.
Yes, we still.
So let's get it in, suck a little bit, and close, and suck, okay? And then you just insert it, you suck it off. Do we have it? No.
Yes.
Oh. As I say, I rather do a big one than a small one, because especially getting them out can be cumbersome. Or is it another one? Maybe it's another one. We haven't resected yet, huh?
I think that there
maybe it's another one. Give me my... No, I think it's that one we just resected, right? It's sticking. We'll see in a second. So there are some studies about artificial intelligence that you find some more polyps, maybe 10% more maximum out. Und zu. Zack. Not so sure, maybe it was a new one.
No, we think it's done now.
It should be done.
Yeah.
So now we stuck it in. Yes. So we have it. But you still have to expose the entire mucosal surface, right? So for a change, we could switch to LCI. Do you like that?
Yes.
Yes?
Yes.
That's why the company calls it, or not the company, some people call it lady color imaging.
Call it what?
LCI, lady color imaging, because it's pink.
Yes, it is.
Sorry for the joke, but I think you have to get used to it.
No, it's okay.
So there are studies saying that you find polyps more easily with this one. I have to get used to it. Okay. So I think it's a very clean colon, not from the very beginning, but again, thanks to my colleague. So this is now the BLI. Is there something here? Yeah, there is something. So I found it first. Sorry to say.
This looks like a plastic one.
Yeah, let's test. Let's test. What does it say? Yeah.
It looks hyperplastic.
Looks hyperplastic, and it's confirmed by the artificial intelligence. Open. So you have to torque the snare. Bisschen zu. Stop, stop, stop, stop. And then suck it. Suck, suck, suck. Not so happy. Zu. Push in. Not good. Open. You have to suck a little bit more. I'm not happy with that. So let's change the scope position. I think we should grab a little bit more. I push in. Zu. Good. Now we grab a little bit more, but we have it. And the system decided for neoplastic at the end, so we will see. I have to suck it in. You have to speak to your histopathologist because when the resection site is larger than the polyp, so this was maybe 3-4 millimeters, but the resection is 1 centimeter, then our pathology reports come back with a 1 centimeter polyp. And that's not true. Jetzt kommt noch was. So we also have to make sure that we retrieve the polyp. So now it's here. So we have a polyp trap, and looking into the trap. But it's an almost normal colon. So help me looking for the polyp. Help me beat the artificial intelligence system. Tell me when you see something. Oh, it's quite big, huh?
So you're checking the bed after the large bite?
Yeah. But I'm not so concerned because there are many data that the bleeding risk is low.
Yes, sure.
Let's flush this one away. Yes. There are false positives. I'm not sure whether this was a real false positive because usually if you see something elevated, you look at it. So the system alerts you what you should look at. This one.
Another one.
Another one. I don't think we have to use the artificial intelligence. This looks as hyperplastic as anything, huh? So now I rotate, open. When you have trouble to get oriented, don't be shy, don't feel ashamed, use a third hand. Ask a colleague to direct the scope. Oops, oops, oops, oops. The snares are sometimes a bit stiff. Und zu. Good, we got it. From the other side. So as I say, you find many of those polyps. And if you do 10 colonoscopies with only small polyps, you probably dream of them during your nightmares.
Yes, definitely.
You see colons all over with tiny polyps chasing you and you chasing them.
Yes, it's enough to have one colonoscopy per day.
Yes. So again, and of course we still can miss them because they can hide behind folds, etc. But this patient will come back anyway for surveillance. So it's not the dangerous ones for missing are the normal colons, between quotes. So here we have the nice arm. So I'm a distinctive fan of endocuff because it's so simple.
Yes.
And especially in the curves on the left side, I love them. I also find a few more polyps. So I switch back to you, to the pink image, okay? Ah, another one. We have also seen it quite quickly and on the left side as well. Huh? The left side one was not so readily picked up. Hey, guy, here's the polyp.
Yes.
Ah, now we have it. Hmm. Oops. What does it say? Hyperplastic, huh?
Looks like serrated.
Oh, then it says hyperplastic, so it's too close for an assessment. No, it doesn't. It doesn't like the polyp. So the
Okay.
polyp is rejected by artificial intelligence.
Mhm. And can you see the one on the right side?
Yeah, I have to. That's the issue. What I said. If you see something and if you don't focus into here it is. Focus on it right away. You sometimes have a hard time to refine it. So I'm not a fan of the underwater group. Ah.
Yes.
But this is kind of involuntary underwater exercise now.
Yes.
So I rotate the scope. Yes?
Can we get close to it to see it?
Yes. But I'm so happy to have it in close. It's a little bit dirty water, but it's a kind of an underwater thing. And it's always nice to rotate the scope to the 6 o'clock, that you have the polyp at the 6 o'clock position.
Yes.
It's in? Okay. So it's in the trap. Somebody has to keep track of all these polyps, because otherwise in the report they just write multiple polyps everywhere. But the likelihood that there is something malignant or so is almost zero. So where's our hyperplastic friend staying?
So you routinely use the endocuff during your routine colonoscopy?
Yes, yes, yes.
Yes, you do it.
Look here, I love it. Here's our little friend, rejected by the AI. We still kill him. So how is it in Egypt? Do you also mostly find these small polyps?
Yes, I personally use the endocuff.
You also like endocuff?
Yes, but I find it sometimes hard to get when I want to go to the ileum.
Yes, that's right. That's right.
When I want to do like a retroflexion in the rectum, it could be cumbersome somehow.
Yeah, but it's mostly the ileum. So if you have to intubate the ileum, you should consider not to use it, because if it's acute angle or something,
yes,
it doesn't let you in. That's an important message.
Yes.
So for ileal inspection,
Yeah.
our friend has gone again. Here. No? That was the other one. A small cut up here.
One and right.
6 o'clock. Auf. I might need a third hand, so let's see. Yes. I rotate the scope. It's somewhere here. Yeah. Moment. I try. Ich brauche da jemand, der mir das hält. So. Gedreht, ja. Now I need the famous third hand. So gedreht. So I can work with the scope and the snare. Where are we? Is it the right one or not? Drives me crazy. Yeah. Halten. So, Moment, wer ist jetzt zurück? Moment.
Yes.
So, good. So this would not have been possible without a third hand.
Yes.
I would have slipped back, okay? So sorry to bore you with all these tiny little polyps, but I think it nicely shows what we can do and what also the limits may be. Because you have a longer examination time, you know, with all these tiny little things.
Yes.
Longer propofol sedation. A tiny little risk of bleeding, more bleedings.
So with the Endoscopy and artificial intelligence, the ADR will be 100%.
Yes. This is what I'm afraid of. I'm afraid of. So, okay, no, I think when something looks really very hyperplastic, we now leave it in because we are in the left colon. And we don't drive us crazy with chasing all these, you know, it took me 5 minutes to get this little hyperplastic thing. And artificial intelligence didn't even show it. So I think the next ones we leave alone. So, but this is, the sigmoid is a perfect area for the endocuff.
Yes.
You don't slip back. You can nicely flatten out the curves.
This is very nice.
And there are enough studies showing that either the ADR is increased or the number of polyps. There are hardly any negative studies on endocuff. There's not a huge benefit. But here you see how nicely the sigmoid is spread up.
Yes.
Okay, I can reassure only 20 centimeters left. So probably everybody is slightly sleepy and hungry now.
No, we are awake.
Can I ask a question?
Yes.
Would this be in the future, artificial intelligence removing the polyps and makes our life easy?
I don't know whether it makes the life easy. As you can see, my life now is almost more difficult, but when we get that far to throw them away, maybe yes. So we just leave them. We don't, we remove them and leave them in the colon, and artificial intelligence makes the diagnosis. Maybe yes. I think it will come sooner or later.
Yes.
Of course, it has to be improved, you know, especially when you interfere with histopathology. So, and you make the diagnosis instead of the histopathologist. There are sort of quite a few legal implications. But when we solve that, I think, you know, when I see this small polyp, and it's probably hyperplastic, even without auf, bisschen, nicht so weit. Ja, auf. Zu, good. So I just leave it. Huh? I don't worry to suck it and note where it exactly is and send it to the pathologist and so on and so on. So 15 centimeters left. Hey, there's a real one. Now it gets more interesting, huh? That's an adenoma. Shall we test the system?
Yes, but can we have a closer view to the? Yes, it looks like there is a vellus pattern in it. It could be tubular vellus.
Yes.
Some vellus changes.
Now finally we are at relevant business. Ist noch nicht da? Ich glaube, der ist weg.
Closer here.
So I also do that cold. It's small. It has a, maybe it's a little bit pedunculated even.
So what the AI said?
AI said neoplastic.
Sorry?
Neoplastic.
Neoplastic.
No. Ah, guy. Yes, thank you. So you wait as long as the right answer comes back, which you like. So rotate again and close. So we get it nicely with the entire stalk out. And you see how important rotation is. Not sure whether it was all, no.
You can clean.
I can continue, so I flush it through the channel again. Die Schlinge. So I can show you some tricks what you do with the resection site if you are not sure whether that was all. Macht mal die Spülung hoch. First of all, you can flush heavily,
yes,
and it will blow up. Krieg ich mal die Nadel? But it seems to be complete.
Yes, it is.
You have this little fibrous thing in the middle, die Nadel, und mit blauer Flüssigkeit.
This is the pseudo.
If the resection site is larger, we have a lot of motility, so you could consider Buscopan, but we are almost finished. If the resection site would be larger than that, I show you the other trick. Durchspritzen mit Blau. Leave the needle inside, like with foam, and push it on and spritzen. This is push it on the resection site. So you could blow some bluish fluid into the resection site. Yes. No needle out, huh? See? Now we have a very nice view. Okay?
Yes.
And we are pretty confident that the polyp is resected fully. Whereas at first sight, I wasn't so sure. So there is his brother, his hyperplastic brother, I guess. Come on.
Sorry, again?
That's the hyperplastic little brother.
Yes, it could be.
I guess, but the system refuses to.
Some more close to.
Okay. Yeah, schnell.
Looks hyperplastic.
Looks hyperplastic. So we agree again. But it's important that the two of us agree, or the three of us, whoever, not so much with the system, huh, as yet. Oh, auf bisschen. Maybe not the full extent. Press it down. Close it. Zack. Okay.
Yes, perfect.
So maybe let's see whether that's a bigger hyperplastic one.
Yes.
Sure. Not so sure, huh? What do you think? I think it looks very hyperplastic. So let's ask the oracle again. Ah.
A closer view.
Yeah, you have to repeat it as so often until the desired answer comes back. But it's again neoplastic. Open, neoplastic. So again, it's nicely at 6 o'clock and close. So finally, it's hyperplastic. Again, this is the typical resection site with the little thing, the fibrous thing in the middle. So that's no residual adenoma. Let's flush it and blue it up a little bit in the middle. So we see more of the submucosa. Oh no. Oh no.
Oh my
God. I think we could leave these, right? Yeah, that's the desired answer. I think we are now in the hyperplastic rectal area. Again, very nicely with the endocuff, huh?
Yes.
What we could do, we could, maybe there's a triple polyp. That's a family. So we take the family as representative of all the others once more.
Yes.
To be sure that this is all hyperplastic. Let's say what our system tells us. Hyperplastic. So again, open.
Polyposis syndrome بيبقى كله polyposis syndrome بيبقى.
So let's get the entire family, 3 little polyps. Wait, 2. One fist.
So you remove the family together.
Yeah, the entire family. So it's too hard for a snare. So don't watch me now, because I'm just pulling through. It's not allowed actually, but there are also double snares where you could, when you can't tear it off, you can then go to. Das Luft geht nicht. Then you go to the hot resection. So I think we should look at the resection side.
Yes.
Warte, was ist denn mit der Luft? Ist wieder drin? Oh, big one. No, not so bad.
Yes. And flush also.
Yes. Blow it up a little bit like that. Zip. For the underwater fans. Yeah, see, now it's nicely blown up.
Yes.
Okay, so the other ones, the remote family members, we leave them. Here is one, just that we don't miss a relevant one. I think this looks very much like the rectum. So inversion, you are right. This rectum is a little bit narrow. So it might be difficult.
Yes.
And here's our most relevant candidate. So, okay. Wir spritzen jetzt mal hoch. If you want, I show you something for the lovers of hot polypectomy. I show you a hot one at the beginning, at the end. Okay?
Okay.
Yes.
Yeah, okay.
This is adenoma.
Yeah.
Yes. Even the system agrees. But we don't have to do ESD. Is it okay? Raus. So inject underneath. It's
so it's small, please.
Yes, right. So I was too far in. I withdraw. And I think it has a small stalk.
Yes.
Yeah. Yes. And there's a hyperplastic aside. So I pull back now. Okay. Zehnerschlinge. So this is the one and the other one why we did the colonoscopy.
Yes.
Ist eingestellt? Ja. And sometimes in the vicinity of the polyp, you have these lymphatic vessels.
Mm-hmm.
I don't think they mean anything, but I can try to resect this a little bit deeper, like this, 1, 2. Thomas? Okay.
Yes.
So we have a safety distance, and we have the normal standard setting, and here we are.
Oh.
If this is an outpatient, I think we would place a clip.
Yeah.
But it's a little bit deep.
If
It
it's
needs
true
to.
that they,
I think it needs to. Yeah.
so if it's true that there is some bleeding, again, you can blow it up. No, microtech. Okay. We see the submucosal network. And if it's true that hot bleeds more, I think it's a good idea to close it with any clip you have at hand. It's a microtech clip. I think we need two, maybe.
Yes.
Yeah.
Dreh noch ein bisschen. So rotate the scope. I'm working with the scope. Zumachen und schießen. Ja, klar. So it doesn't have to be watertight. It's just to keep the margins together to prevent bleeding. It's not evidence-based. The studies show that you should do this in the right colon. But anyway. Dann nehmen wir die Schlinge nochmal und holen den Kerl raus. But you know, it's also typical. The most relevant comes in the rectum when you are entirely exhausted from the many small polyps. Drehen. If you are too quick, and then you would have missed a really relevant one. Und andersrum drehen. Gut, stopp, zurück. Ja, wunderbar. Again, working with the scope only. Und zu. Und Schuss. Gut, jetzt kriege ich noch mal die Schlinge. Now we remove this guy, and then that's what I say to my nurses. Even the nicest colonoscopy finally gets to an end. Fortunately. Sorry for keeping you awake for so long.
No, it's okay.
Another one. Das ist jetzt aber die heiße Schlinge, oder? Okay,
another one.
But that's hyperplastic, right?
Could you try the normal?
There is one message. If there is something which you don't know what it could be in the rectum, it's reddish, it's a little bit flat. Think of the fact that it could be a rectal carcinoid and resect it more deeply. I don't think that this qualifies. It looks like a slightly damaged hyperplastic polyp, but if you have something not entirely typical, think of a carcinoid, inject, and resect it more deeply.
I think carcinoid is more delineated than this. Usually the borders are very thin.
Yeah. But if you do a too superficial resection, rotate again. Here's another one. So let's take a little bit more with this one. No. You suck und zu. Gut. Nee, das ist, müssen wir den anderen noch rausholen. Now we lost. Wie, der Große ist schon da? Was? No. The assistant wanted to convince me that I sucked this through the channel, which I found hard to believe. That's too small. I don't think that's going to work. Gib mir mal die große Schlinge. So I sucked the little one. So this stays in. And also, you know, with retroversion, another advantage of the endocuff is that you have a very nice view on the proctum.
Yeah. Sure.
So maybe if you are afraid because it's too narrow, you don't have to make retroflexion.
Yes.
Professor Roche, in view of this large number of polyps, do you consider attenuated fab, please?
As what? Whether it's
do you think this patient with of attenuated fab with this large number of polyps?
Let's see what histology is. Wie alt ist sie nochmal genau? Okay. And she's 74. So let's see if it's all adenomas and so on. We might go to some testing. Of course, you could take the family history and all that kind of stuff. But I think we have only two real bigger adenomas, not bigger, but one was 5 millimeters and the other one a centimeter or so. But I agree, that's always something you should keep in mind, especially in younger people. Okay. So I think that was it.
Yes. Thank you very much. And Dr. Naga wants to thank you by himself.
Professor Roche, this is very nice to connect again Hamburg and Cairo. I finished my job actually, and I hope my colleagues will continue with Professor Roche, connecting the school with much Dr. Roche.
Yes, no, I'm very grateful that we had the opportunity to link up with you. I think we had a very nice conversation. I enjoyed it. And I hope we can strengthen our cooperation in UMass. I know you have such a long-standing history with this Hamburg University Hospital, even with Nipse Hender, my predecessor, whom we all greatly, greatly value and honor. So thank you very much.
Professor Roche,
thank you very much. Thank you very much.
And especially thanks the hospital, OKA, Universität Krankenhaus Eppendorf, as a site where I trained for endoscopic ultrasound 23 years ago in 1997 with Ken Spinmoiler, Zabin. So I'd like to thank you very much and thank you.
The whole unit belongs to Hamburg.
Memorial.
The whole unit belongs to Hamburg.
And always producing education. Thank you very much.
Okay.
We hope to see you in Cairo after the corona.
Yes, yes.
Soon.
I'm looking forward to some travel at least. Huh?
Bye-bye.
Bye-bye. Ciao.
Yeah. Bye-bye. Bye-bye.
After a few minutes, we will shift to Istanbul with Prof. Hakan. خمس دقايق يا جماعه وهننقل من اسطنبول على طول ان شاء الله. الدكتور كان محضر لنا حالات قويه جدا.
يا جماعه اللي عايز ياخد الكافي بريك بتاعه او البريك بتاعه يعني يتفضل يستلمه وكده، وحتى يعني يبقى يخش تاني مفيش مشكله. احنا لسه قدامنا بتاع 5 دقايق على ما نخش.
عبير ازيك يا عبير؟ والله باخد بالي. اهلا وسهلا.
هو على فكره هو اللي
yapmışlar. Biz başlayabiliriz yani. Bize engelleyen bir şey yok.
Ama benim onları duymam gerekiyor.
Oraya bilgisayar açıp bir tane de orada açacağız.
Tamam, açalım hemen.
Okuyacak mıyız?
Okuyacağız.
Vardı hocam. Burada olabilir ama burada değildir şu an. Odasında olabilir.
Ben bari kesin ama yayına gönderiyorsun değil mi? Her yere yok. Tamam. Ona gönderiyorsan şuna zoom açsan bana. Ben hocanın oraya götüreyim onu. Onlar şöyle bir şey yapmışlar. Bizim gönderdiğimiz yayın görselini almışlar. Şeyin içerisine koymuşlar. Zoom'un içerisine
tamam.
Koymuşlar.
Yayını direkt oraya vermişler.
Yayını oraya vermişler. Tamam.
Bizim yapacağımızı kendileri yapmışlar. Biz sadece soruları sesli alacağız.
Tamam.
Onlara.
Burası salonu görüyoruz öyle mi?
Evet. Salondaki oturacakları şeyler.
Daha kimse yok orada da. Yani.
Dosyayı kaydettim ha. Şey isteyecek. Kullanıcının adıyla girelim ki anlasınlar, sesimizi açsınlar.
Evet.
Bizim. Ha? Uygulamayı açtı.
Hello. Can you hear me?
Ya bak.
Ben size şeyden de
Hello,
Hello.
can you hear me?
Yes.
Ses aç.
Bak bunu kapatacağız ki ses şeyler.
Tamam.
Mikrofon kapalı da. Hocamda mikrofon var.
Şimdi benim mikrofon açık mı?
Açık hocam.
Tamam, şu yankıyı kapatsak. Yankı.
İçeriye bir gidelim hocam, orada kapatacağım.
Tamam. Hadi o zaman gidelim.
Sizin telefonunuzdan Zoom açtınız mı siz?
Açmadım.
Kapalı değil mi?
Kapalı.
Hello, can you hear me?
Şimdi kontrol edelim. Yok, şöyle konuşsanız alır zaten.
Peki bu mikrofon çalışıyor.
O da çalışıyor. Sonra bundan göndereceğiz. Biz şimdi onu ayarlayacağız. Yani şu anda o da çalışıyor. Onda arkadan da o gelecek. O ses gelecek. Ben onu ayarlayacağım.
Hello.
Hello, can you hear us?
Hello, can you hear me?
Hello, yes, we can hear you.
Will you use the Zoom screen or your website?
Sorry, I don't understand.
Please mirror your screen.
It's mirrored.
Mirror your screen.
Yes. Hocam siz o tarafa geçin, bizim Mert oradan sesi gönder. Buradan yani Wirecast'e bas sadece sesi. Tamam mı? Sadece yani Zoom'un sesini açacağım da bunun mikrofonu.
Başlıyor mu? Ya sürekli bir yankı var yani. Ben konuşamıyorum ki. Ses müthiş bir yankılanıyor.
İki farklı yerden ses alıyor. Yani oradan duyduğumuz buradan geliyor. Sonuçta buradan evet. Zoom diğer taraftan bağlı olduğu için. Hocam şöyle bunu kısacağım. Soru sordukları zaman açacağım sadece.
Ama benim bağlantıda olmam lazım.
Ama siz hep bağlı olacaksınız zaten. Siz hep konuşabileceksiniz.
Ama benim sürekli onların konuştuğunu... Böyle olmaz.
Ama
duyuluyor.
Burayı duyacak yani. Burayı duymak istiyor hocam.
Ama şu an şey yaşıyoruz yani canlı yayına bağlanıp televizyon açmış.
Evet evet. Zaten o yani o şeyi yok aslında.
Hiçbir şey anlamadım.
Benim buradan kendi bilgisayarımı buraya vermem lazım. Ha? Yani teknikten Zoom'dan olması lazım.
Evet, evet. Değişim. Yalnız geç kalıyoruz yani. Keşke bunu daha önce düşünseydiniz yani. Yani bağlantı olmadan nasıl canlı yayın olur? Siz hiç Zoom yapmadınız mı şu ana kadar?
Bu hep tek yönlüydü hocam. Onlarla konuşurken
Ama tek yönlü olmaz ki. Bütün toplantılarda mutlaka karşılıklı
şu anda
konuşuyorlar.
yaptıklarımızın hepsi, yurt şeyinden hepsi, uzaktan olduğu için hepsi, herkes elinden bağlandığı için hiç böyle bir, yani bize bu organizasyondan diye de bahsetmişler. Bir yerde toplayacağız diye de bahsetmişler. Zaten chat panelini falan test ettirdik onu.
Peki ne yapıyoruz şimdi?
Tek Zoom'a düşürelim ki ses etmesini istiyoruz aslında.
Yalnız bu bilgisayarın sesi yok ki.
Ha? Ekrandan, monitörden getireceğiz ama HDMI'ye gidiyor. Yok, öyle de bunu...
Ya ben kendi bilgisayarımın Zoom'undan bağlanayım daha iyi ya.
Bütün o görüntüler hepsi orada bilgisayarda hocam.
Ona ben bağlanayım ne fark? Ya bilmiyorum şimdi zaman geçtikçe geçiyor ya. Biraz tecrübesiz tabii ondan.
Orayı konuşabilirsiniz.
Tamam. 1-2. Ben nereden duyacağım peki?
Buradan, televizyondan gelecek normalde.
Buranın sesi var mı ki? Buranın sesi yok ki. Hoparlörü yok, hiçbir şey yok buranın.
Profaka?
You hear me?
Yes. With you, Ahmed Murad. How are you?
Fine, and you?
I know that you prepare a lot of interesting things for us today.
Yes, we have.
Here we are waiting for you.
Okay, we are having very interesting cases for you.
Now we see you.
You hear me?
Yes, Professor Hakan, I'd like to welcome again and again and again. This is Dr. Roxanne Okasha with you. It is a pleasure and honor to be with you.
It is
face to face and even on air.
It is okay. It is pleasure to be with you. I wish I had been in Cairo, but anyway, we are together, even if in virtual terms. The first case is a lady with gallbladder stone. She is a fairly old lady actually with comorbid conditions. And
yes. There is a small technical problem that we see you inverted mirror image. All right, left. So if you can correct it from your side, this will be a very good thing.
Okay, they are going to fix it.
Okay.
How is it going in Cairo?
Yes, we are hearing you well. We are hearing you very well.
Very good, very good. So you hear me. This is the first case, an old lady with gallbladder stone. She was considered unfit for surgery. My surgical team is also with me here. Dr. Cumhur is with me. Yes, you would come. Actually, we evaluated this patient together with him, and Dr. Cumhur is from our surgery department, and the patient was unfit for surgery, and we planned endoscopic laser lithotripsy 4 weeks ago. We performed an cholecystogastrostomy by a fully covered stent. Now we are going to perform stone disintegration with spyglass system and laser lithotripsy. Is it okay?
Okay.
We start
Through the natural orifice or like the previous one in the...
Şunu biraz şu tarafa doğru. Biraz şu tarafa. Şu ekranı görmem gerekiyor. Ha, şöyle biraz daha arkadan canım benim. Ha, şöyle. Okay, this is a therapeutic gastroscope with a large channel from Olympus. I insert the scope. Endoskopik resmi alalım ekrana. Benim görünümüm ve endoskopik resim. Okay. Yes, the stent is here in antrum. For cholecystogastrostomy, I generally prefer antrum. Some people prefer duodenum, but duodenum is more difficult, I guess. So I performed the procedure through antrum. Now I get the spyglass. Yes, spyglass, please. Işık. I am inserting the spyglass scope. Spyglass is from Boston Scientific, and it can be inserted through the therapeutic gastroscope. Yes. Now we are spyglass görüntüsünü de alalım bir tarafa.
Excuse me, this metal stent is fully covered, partially covered, or
Fully covered stent. I think it is from Microtech company. Now I am preparing to find the stone. Evet, takalım. I fix the cholangioscope to the gastroscope.
Keseceğim. Kestim. Verdim. Onlar biz yayını izliyorlarmış. Şimdi ben zoom'a girdim.
Now we are in gallbladder, you see.
Yok mu ki ben ya? Şunu oldu.
Evet, görüntü.
Tam geliyorum.
Picture is okay, right left is okay.
Spyglass görüntüsü arkadaşlar. 2 numara. 2 numara ve endoskop. İkisi beraber. Spyglass ve endoskop. Ve 2 ile 5 birlikte. Ekranda niye görmüyorum arkadaşlar? Su veriyor mu çocuklar? Ama otojetin verdiğini görmüyorum. Veriyor mu? Evet. Yes. Çocuklar sanki suda bir sorun var gibi ya.
Dr. Akan?
Yes. Now you see
the CBD or intrahepatic stone.
This is not intrahepatic stone. This is stone in gallbladder.
Yeah.
So previously we performed an cholecystogastrostomy.
Yes.
And then we inserted the spyglass through stomach into the gallbladder.
Yeah.
You understand?
Yes. Yes. Yes. Then this is cholecystogastrostomy.
Cholecystogastrostomy, yes.
Ostomy with anti-radiation. Okay. Very nice.
Now I am trying to find the stone. You see the gallbladder. Gallbladder is a bit inflamed. I am trying to find the stone in gallbladder.
The question is, why we are using the spyglass? Why not?
Yes, the stone is here, you see. Just here, just in the neck of the gallbladder. The stone is here. In gallbladder, it is not easy to find the stone sometimes. A very large space.
The primary reason
stone is here.
To gastrostomy, Dr. Akan. What is the primary reason for that? Just for the procedure or the patient?
No. This is just for the treatment of cholecystitis.
Yes.
Because the patient is unfit for surgery, no way the stone will be removed with gallbladder. So we performed cholecystogastrostomy. Otherwise, the patient is suffering from ongoing cholangitis.
Professor Hakim, this is Naguib with you, Muhammad Naguib. How do you do?
Yes, please.
The patient did cholecystogastrostomy
remove hair cholecystitis. Is that right?
Yes, cholecystitis, and we plan a later disintegration of the stone.
Yeah. So this is done by a lumen opposing stent, isn't it?
No, no, this is fully covered stent.
Fully covered stent.
You see the stone now. I get the cable. Kablo. Hadi çocuklar. Ne bekliyorsunuz kablo?
My question is here that should we do it with a lumen opposing stent so that its diameter or its caliber can accommodate the passage of a regular upper endoscope, and maybe you can extract the stones easier from inside the gallbladder?
Hiç çıkmıyor. Çıkmıyor. Ha, şimdi. Yes, now we administer the cable. Nerede uçuyor? Ucu çıkmıyor yalnız. Now I administer laser to the stone. Nereye gider? Niye çıkamadınız tam ucundan? Ha? Nerede ucu? Ha, bırak. Başka bir tane bir cable alsam tam ucundan çıkmamış. Görüyor musun? Ucunda takılmış kalmış. Yes. You see the stone now. Sürekli videoya kaydetmeyin. Çocuklar bu laser cable'ı çok kötü. Bu ucundan çıkmıyor tam olarak. Başka bir tane almamız lazım. Ha, şimdi çıktı. Tamam, şimdi. Şeyi hazırlasanız da şu Kamil Bağdatlıoğlu'nu onu yapalım. Now, in the gallbladder, it is difficult to point the stone. I am trying to do this. Cable rahat hareket etmediği için şey yapamıyorum. Görüyor musun? Cable'ı itemiyorum. Şurada sıkıştı kaldı. Ucu kırıldı bunun. Gördünüz mü? Bakın. Yeni bir tane cable ver. Al şunu. Var değil mi ya cable'ın? Ha? Ver. And now we are experiencing some problems with the cable. We are going to fix it.
Professor Hakan.
Yes.
Of course, you have to point the laser on the stone. in the setting of being inside the gallbladder, the stone is mobile. When you hit it, it will move, and it will not be in focus like if it is lodged inside a CBD or something.
Yes. Because the stone is in gallbladder, actually it is difficult to see the stone clearly as it is in common bile duct. It is more difficult to align the cable. Tamam mı? Evet. Bunu baştan koysaydınız çok iyi olacaktı uçuna kadar. Şunu çıkartıp bir daha sokayım. Pardon. Getir uçuna kadar şimdi. Hadi. Tamam. Bir dakika. Görünüyor. I changed the cable. Ucuna kadar getirip tekrar now I am going to aspirate first and then I am going to insert it again. Hadi ucuna. Nereden? Anladım. Şimdi mi çıkmıştım? Şöyle tutalım. Hani tam ucundan mı? Geriden tutun. Geriden tutun. Tamam şöyle. Ucunda değil. Tekrar. Tamam biraz geri. Geri. Geri biraz şuraya kadar getir hadi. Tamam böyle kalsın. I insert the spyglass again. أنا ما عنديش تليجرام. وطلعها.
Professor Hakan.
Yes. Actually, now what I am trying to do is I am trying to find a stone with laser cable in, because if the laser cable is not inside, it is very difficult to manipulate it. Now we see the stone.
And simultaneous use of fluoroscopic screen can help you in...
No, fluoroscopy does not help it. The stone is just in a very difficult position. The problem is that.
Okay.
Bıraksana bir elini.
اللي كانت موجودة.
I am trying to manipulate both the scope and the spyglass. You see there are some sludge and the sludge is obscuring the view. That is the problem. So the stone is here, but I cannot get access to the stone. Yes. You see, gold plate is a capacious space, so it is not as easy as it is in bile ducts. Now we are trying to find the stone in a good place. Çocuklar su vermiyor galiba. Şu suyu bir kontrol edebilir misin? Su bitmiş. Suyu kontrol edin. Hadi. Yeah. Actually, I think the position of the stone is not very suitable, actually. That is the problem. Because I cannot have a good view of the stone. That's the problem. No, okay. Çocuk spyglass dokundunuz bakın. Diğer hasta geldi mi? Kamil Bey. Tamam. Yes, the position of the stone is not suitable for disintegration, I think. Now we are in the gallbladder, but I cannot see the stone. Su veriyor mu şu an? So you see that stone disintegration by spyglass in gallbladder is not as easy as it is in bile ducts. Because gallbladder is a large space. And the maneuverability of spyglass is not perfect. So we cannot see the stone in a good position.
Maybe the stone is infected at the neck or at the beginning of the cystic duct. So
sorry?
Maybe the stone is impacted in the neck or the system.
Yes, the stone is in the neck, sure. The stone is in the neck. Because of this, I cannot reach the neck, you see.
Yes.
I am trying to do it again. This is sludge is here. In order to exert radio laser, I should have a very clear view of the stone. Otherwise, damage and perforation could happen. Yes, the stone is here, just beneath the laser cable, you see. But the problem is that I cannot have a good view. Yes, the stone is here. Işığı yanmıyor yani. You see the stone?
Yes. It's
just in the neck.
Yes, at the bottom of the screen, it is a part of the stone at the bottom of the screen. Yes.
Yes, but the problem is that I cannot have a position to touch the stone.
Yes.
I am trying.
Professor Hakan.
Yes.
I'm asking that would it be better if from the start we introduced alumina posing stent with wide
No, it doesn't change anything.
and enter inside the gallbladder with a regular scope and maybe retrieve the stone with a basket or crush it by electrohydraulic lithotripter or mechanical lithotripter.
It doesn't make any sense.
Okay, thank you.
Yes, we are unlucky this time because we cannot have a good position. And unfortunately, I cannot fix it to the position I want. Hastayı ben biraz yan çevirelim. Biraz yan ne diyorum? Yan çevirelim biraz. I am going to change the position of the patient slightly.
Yeah.
Hadi. I am going to change the position of the patient. Maybe it will help.
Yes, the patient was on the left lateral. It would be
left lateral, yeah.
Then to supine.
Left lateral, yes. Bir dakika. Geriye çekince yerinden kaydı ya. Apart from the position, the sludge is also obscuring the view. Now the stone is in a better position.
Yeah, we can see.
No, it doesn't touch still.
Professor Hakan, just a suggestion which may work. If your assistant can push the epigastric, push on the epigastric or the right hypochondrial region.
Evet, bir bastırsana bir. Şöyle yukarı doğru. Yok, öbür türlü bak, öbür türlü. taşı görüyorsunuz ya, oraya doğru. Hastayı biraz daha şu tarafa doğru alabilir miyim? Biraz daha. Yani tutmayla. Hala evet, bu tarafa doğru. Evet. Tamam. Yes, now it is much better. Ya bir dakika bozmayın. Bak pozisyon yine bozuldu. Demin ki bak şunu bir elinle şuraya doğru ayarlayabilir. Çok güzel, öyle dur. Çok güzel öyle, tamam. You see the sludge is still obscuring the view. Çok yerinden oynatmayın diyorum ya o. Yes. Oynamayın. Böyle. You see, it is just in the vicinity of the stone, but it is damaging the wall. So I must take a better position.
Yes, much better position now.
No, it is now. It is very good. You see,
Yeah.
it is in a very good position now.
Yes. This is laser or hydraulic lithotripsy?
This is
laser or hydraulic?
Laser.
Laser, yes.
In this system, the main problem is that you should control everything by yourself. The gastroscope, spyglass, cable, everything together. Su yine mi bitti? He partly disintegrated the stone, but this is not suffice, of course. Hayır. Bir bırak bakayım. Tekrar bastır. I am trying to find the stone again. No. Yes, I have found it again. Şunu biraz daha bana uygun hale getirebilir misiniz taşın konumunu çocuklar? Bakın. O öyle değil ya. O yavaş hareket. Yavaş tamam. İyi öyle iyi. Öyle iyi. Tamam öyle tamam. Evet. Tekrar bir şunu bana doğru getirebilirsen çok başarılı olur. Çok güzel öyle kal. Biraz daha aynı şeye devam et. Çok güzel. Ha. Now I am trying to disintegrate the stone all the way. You see, it is very successful. You see, Hussein?
Yes, yes, very nice. And position now is very good. And I think this stone is rather hard. It contains a lot of calcium, so it is not disintegrated easily.
This is a 3 centimeter stone. Çok güzel Ayşe. Biraz artırsak.
Yes.
I am increasing the power of the laser.
Yes.
When the frequency decreases, the power is increasing. Tamam çok iyi. Pozisyonu hiç bozma. Değiştirme. Yes, it is partly disintegrated.
Yes.
Canı rahat mı? Çok güzel. So this is the system of gallbladder stone dissolution in patients who are unfit for surgery. We first perform an cholecystogastrostomy from antrum. Then we wait for 4 weeks. Then we insert an spyglass into the gallbladder. Then we perform a stone dissolution like this. for the sake of time, I think I must finish it here. We will need another session for this lady, but because there is a very large diameter fully covered stent, I think we are going to remove the remaining stone parts with an basket later because of the time limitation. Now I finish the procedure here, and we are going to have another session. So this is the system of gallbladder stone disintegration with spyglass through the US guided cholecystogastroscopy. Any question?
Yes, Justin, I have a question. Do you prefer lens, whether Axios or Hanaro, better than the covered stent, or no difference? Any stent available, you can.
As far as I am concerned, I do not think there is a difference. But you see that why we use these stents, these are significantly cheaper. That is the
yes.
price of this stent, the cost of this stent is 1/4 of an lumen opposing stent. Mostly we use this because of the cost, but you see it is very effective. So this is the system. Now we switch to the next patient.
Yes, okay. Thank you. Very nice job. And very excellent maneuver for those poor surgical risk and complaining of cholecystitis. Thank you very much.
Thank you. The next case, şunu onu elinde bırakın. Bırakın şöyle koyun. Onu oynamayın onlarla. Biraz geriye çek. Ne yapayım? Ne soruyorsun anlamadım. Tamam, geriye çekelim biraz. Çabuk hareketler, hadi bekle be. Çocuklar aradaki hareketler çabuk ki Deniz. Okay. The next patient will be a patient with liver cirrhosis and bleeding fundal and esophageal varices. We are going to perform fundal varix embolization, coil embolization.
Yes, excellent. Esophageal or gastric?
For fundal varices, we are going to perform coil embolization. Then we are going to go ahead with band ligation of esophageal varices.
Yes, okay, excellent.
Actually, we are going to have another case for cholangioscopic stone disintegration in common bile duct. Common bile duct stone disintegration by laser is fairly easy, but for gallbladder, we always experience this problem, especially if the stone is in the neck.
Yes.
So if you are you aim to do this technique, you should be very patient. It requires a challenge to find the stone in gallbladder in the right position and to put the cable into the right place, just into the stone. It is a bit difficult. And if you administer too much laser into the wall of gallbladder, that would result with perforation. You see, when we touch the gallbladder mucosa, there is a whitening of the tissue. If you go on with shooting, that would result with perforation. So you should care for these whitish chains. If there are some whitish chains, it means that it is damaging the mucosa. And in this patient, we used a very powerful setting because the stone was very large, 3 centimeters. In these stones, the complete disintegration will take at least 30 to 40 minutes. So in order not to take too much time in the workshop, I deferred the remaining to the next session. Otherwise, we generally spend 30 to 40 minutes for complete disintegration. In this patient, you see the stent in gallbladder is a fairly large one. So even if the stones are not completely disintegrated, the remaining parts would be spontaneously discharged from gallbladder. Any question for this technique?
Last question. In case of gallbladder lithotripsy, gallbladder stones lithotripsy, do you prefer the less penetrating hydraulic lithotripsy or the laser is better?
Sorry, could you please repeat the question?
Which is better in cases of gallbladder stones and fibromucosa, as you said? Which is better, hydraulic, the less penetrating hydraulic lithotripsy, or the laser lithotripsy, in your opinion?
Actually, the problem is that I do not have any experience with hydraulic lithotripsy, but as far as I have heard, disintegration with hydraulic lithotripsy is more difficult than laser because laser is more powerful. So with electrohydraulic, it would take too much time in comparison to laser lithotripsy. But frankly, o zaman alalım yavaş yavaş. Hadi. Actually, we are having general anesthesia because of this. You see, we should wait for some time to make the patient stable and to admit the other patient. Diğer hastayı alalım yavaş yavaş. Hayır, devam ediyoruz.
Nazmiye Hanım.
Okay, and thank you.
Now we are going to admit the next patient. Öbür hastayı alabilirsiniz. Skopya gerek yok. Var.
Any question from the floor? If anyone wants to ask any question, just you can pick up the microphone and ask your question.
I want to tell something about US-guided cholecystogastrophy. As I said, we use this technique for the patients with gallbladder stones who are not unfit for surgery. And if they are having ongoing symptoms, we perform this procedure. In some other cases, we perform this as a rescue procedure. For example, 3 or 4 days ago, we performed choledochoduodenostomy. Actually, we aim to perform a choledochoduodenostomy. I am going to show the video tomorrow session, but choledochoduodenostomy failed. That is something very catastrophic. So in this case, I should have a drainage in any case, but the bile ducts in yavaş yavaş alabilir miyiz acaba? Çok zamanımızı gezdiniz. Bile ducts in liver were not enough dilated, so I could not perform hepaticogastrostomy. Then I performed cholecystogastrophy as a rescue procedure. This is another indication. And the third indication, and the most common indication, is the treatment of acute cholecystitis. In acute cholecystitis, in general, the surgeons are preferring external drainage, but increasingly in our hospital, endoscopic drainage is gaining momentum. Professor Cumhur, would you come? Cumhur is my best friend in hepatobiliary surgery. I think we would have his opinion about this endosonography guided gallbladder procedures. Do you think that this is helping to some patients who are unfit for surgery?
Of course. Firstly, getting from
Sorry.
Turkey, we work together with.
Sweet actor, sorry.
Could you
Sorry.
raise a little bit, please? You can just.
We work with Professor Shanter together, and I also think that this endoscopic procedures are more useful and and also successful treatments because the external drainage are always have some more complications, and the physiological way is the best in my opinion, and Professor Shantok is so good in this job, so we make some decisions together. It's always and then we follow these patients together.
Actually, in order to perform all these procedures, you should have a very good collaboration with surgical team, because these are risky procedures with significant morbidity and mortality. In this gastrointestinal biliary access, there is at least 10 to 15% complication rate and up to 5% mortality rate. So you should take into account, you should explain this procedure to the relatives of the patients, and you should have a very good collaboration with surgical team. And you see that most of these patients are frail elderly, and most of the patients are having a malignant condition in its late stage, so they are not very good candidates for surgery. And because of this, Dr. Jumhur is pushing us to find some ways other than surgery, because he thinks that surgery is detrimental in these patients.
Yes, of course, I totally agree with this. And the these complications may of course occur, and in such cases we follow up these patients together. If any emergent surgical decision is ordered, we give this decision together.
Okay, now I am going to give you some explanation for coil embolization. May I have the coils to show our colleagues? Coilleri getirsenize. Yes. For coil, sorry, yes, Hussein.
Yes, you show us now the applicator and how it is the coils are plugged inside the applicator.
Sorry?
Show us now the applicator and how the coils are introduced inside the 19G needle. We are very curious to see how the coils are introduced into the 19G needle. Very interesting.
Okay. For fundic varix ligation, we first insert this 19-gauge needle. This is a hook needle, actually, into the fundal varix through esophagus. We always use transesophageal approach. And this is guarding against bleeding in the procedure, because if you access from stomach, there is, sorry. Ne oldu?
Yes, this is
okay. Okay. 19-gauge needle, we use it through the esophagus, because if we insert it through the esophagus, we take the esophageal recess, esophageocardial recess, as a guard against bleeding. These are the coils. You see there are several sizes. There are two different diameters in the coils. One is the width and one is the length. As to length, it is from 2 centimeter to 13 centimeter, and in width it is from 2 millimeters to 12 millimeters. So there are very, very different types of coils, but in general, these are the diameters we take into account in the procedure. We choose the longer ones and wider ones for large varices, and the small ones for small varices. On average, in the literature, tomorrow I am going to talk about this, they use from 3 to 5 coils, but in my personal experience, at least 7 to 8 coils are necessary. So in most of the cases, I use from 5 to 10 coils. Now our patient is becoming ready. In these procedures, we always have a general anesthesia because there is a risk of intraprocedural bleeding. And in case of bleeding, in order not to deal with aspiration, we should have an endotracheal cuff in its place to better manage if bleeding happens. Any question in reference to this coil procedure?
No, we are very curious to see the maneuver. Yes.
In 5 minutes, we are going to start. Siz de gelir misiniz? We are going to use an Hitachi device, a new one. What is the type? What is the brand of this machine?
Arietta 850.
Sorry?
Arietta 850.
Arietta 850 device. This is the newest one from Hitachi. We have had it just months before. Very nice device. And actually, I am not very familiar with the console. So, what's your name?
Basri.
Basri from Hitachi is going to help me in managing the buttons because this is a very complex machine. And I am going to use the Pentax therapeutic linear endoscope, the newest one.
J10? The J10 Pentax needle?
Sorry?
The therapeutic J10 Pentax echo endoscope?
What was the type of the scope? Actually, I don't know completely.
Okay.
Hazır oluyor muyuz?
Professor Hakan. Professor Hakan,
yes.
Do you hear me?
Yes, yes, I hear you.
We are very interested to see how the coils are introduced inside the 19G needle. Would you
Yes,
ask
we
the,
are going to show it in detail.
yes, would you please ask the cameraman to concentrate on this step because it is very important to all of us.
Yes, you are going to see it very clearly.
Okay, thank you.
Şu tarafa doğru geçin.
Wishing you the best of luck.
Gerek olursa ben sizi çağıracağım. Bu taraftan geçin.
Burada bekleyebiliriz.
Now we inserted the US scope. There is a considerable ascites in this patient. Now we are at 40 to 50 centimeter.
40 centimeter?
45.
45 centimeter.
45 centimeter.
Okay.
Aorta.
Yes.
Konsolda şimdi şu damarları en iyi göreceğim şekilde ayarlar mısınız Basri Bey? Basri Bey nerede? Bu taraftan gel canım. Gel bu taraftan. Bu mudur emri bunu? Okay. Arrow alır mısınız? Oka. Ok. These are the fundic varices.
Yes.
We are at 45. Not fairly large.
Yes.
Doppler flow. You see the Doppler flow?
Yes. Very.
Yes, okay. Şöyle sıkı tutalım. Now we insert the needle. Buraya 5 santim 5 milimetre. 5'e 5 varsa veya en yakına. Okay. Şimdi şu ekran bizi göstermesi lazım. Oğlum gel buraya. Şeyi getir. Kamerayı getir. Hadi bırak telefonu. Gel buraya. Şurayı göstereceksin. Şu yaklaş. Tamam. Sen yerini bozma.
Ben de
Hazır mı? Biraz çabuk hareket. Ha? Aç göster orayı. Yavrucuğum bak onu takip et. Ha? Ha? The nurse is preparing the... Şöyle göster, elini göster bak. Ha? Tamam. Evet. Yaklaştır kamerayı iyice.
Can the cameraman a little bit zoom on the...
Yavaş. You see the coil now? It is here. The coil is in this metal part. Now the nurse is going to attach this to the needle, US needle. we are going to withdraw the stylet. Then we are going to push the stylet through it to release the coil into the needle. Then we are going to withdraw this and we are going to push the coil with the stylet. Okay, you are ready?
Yes, yes.
To remove the stylet, then you introduce.
Yes. Now we are in the vessel. Bir yavaş stylet'ı bir göstermek için yapıyoruz bunu ya. Now the nurses remove yavaş hareketler. Remove the stylet. You see, remove.
Yes. So now we remove the stylet. Yes.
And we attach this to the needle.
Yes.
Bir dakika, görülmesi gerekiyor. Görülmezse hiçbir işe yaramıyor. Bu tarafa geç.
So we the metal part containing the coil inside it.
Yes. Now we attach it. You see?
Yeah, we can see. Yes,
Very
we
clear.
can see.
Very clear. Yes.
Yes, our other nurse is pushing it.
When you introduce the stylet from inside this metal part, it will push the coil.
Yes, exactly. That is what is happening. Now it is in the needle.
Yeah.
Then you pull the stylet again and pull everything and reintroduce the stylet again.
Now you also follow the EUS image and you are going to, now another very important point. Show the scope. Geri git, şöyle git. Git. Now the scope is a bit angulated. This is not good. The scope should be straight. So I am going back. And I am becoming completely straight with the scope. Şuradan göstersene.
Yeah.
Olmadı öbür taraftan. Öbür taraftan. Geç öbür tarafa. Şöyle biraz çabuk. You see the scope is completely straight. This is very important.
Yeah.
Now she is pushing. Completely straight.
Yes, so pushing the coil.
Now also watch the US screen. Geldi mi? Now it is going to be expand. Yes. You see the coil.
Yeah, very nice.
That is the technique. Did you understand it?
Deployed into the inside of the varix.
This is in the fundus.
Yeah.
Even one coil was very effective, you see.
الكويل الأول.
The size of the varix is notably decreased in size.
You see it, now we cannot see anymore.
Will you inject cyanoacrylate inside the
No,
only the coil.
Only the coil, yes.
But I think there is a small active part with Doppler slide to the right of the screen. Will you apply another coil in that area or only one coil?
Now we choose another site to attain a complete eradication of the varix.
If the varix is large, will you apply 2 or 3 coils at the same site with the same needle punch?
Yes, of course. You can do this.
You can do it, okay.
Now we administer another coil here. Yes, please. Again, straight. Evet, 5 mm 5 santim. Actually, for the sake of time, I preferred a patient with not too large varices. Otherwise, it would have taken too much time. But anyway, you see the technique.
Yes.
Göster. Evet, gel buraya. Gel. Yes. Now you see there is something here. We are removing this part, this one. Ekrana doğru yap. Evet. Çıkar. Evet. Evet. Tamam. Attach et. Evet. Go on. Bundan sonra şu şey hastası. Mehtap hemşirenin annesi. Evet. Straight position. Scope'u göster. Scope. Geri git. Küçül. Şurayı bak şu şeye. Now geldi mi? Şurayı diyorum. Bak şu bölgeyi tümünü diyorum evladım. Ha? Geri git biraz.
You are totally against the injection of histoacryl small amount.
Yes. Now watch the US screen, please. Yes, devam et. Evet. Yes. Go on. Yes. This was the second one. Histoacryl is not necessary. Tomorrow I am going to show you one of our study comparing histoacryl, comparing a coil with or without histoacryl. Actually, there is no difference.
I speak about the cost benefit because the coil is so expensive and
Yes, of course. You should take into account this.
Yes.
And there is another one here. This will be the last one. Küçük, 3. Yes, this will be the last one. Evet. Tamam, evet. Tekrar gösterin. Bakın hemşire hanımı öbür tarafı öğrendin artık ha? Evet. Getir hadi. Evet, devam et. You see the position of the scope completely straight. And I release the buttons. They are in neutral position. Otherwise, you are going to be stuck to the, your coil will be stuck to the lumen of the needle. Go on. Now we are pushing it. Go on. Yes.
Yes, now it is coming. Yes.
it's not necessary to suck blood at the beginning. It's not necessary.
No. And you see that in this patient now near complete eradication of fundal varices.
Yes.
No more flow. Maybe small flow here. Yes, there are still some remnant varices here. And another point is that you should not confuse the collaterals. You see these are collaterals. Ok nerede? Oku getir göster. Basri. Ok.
These vessels are outside the muscularis.
Yes, these are collaterals. Of course, you should not put coil into these ones. You put coil only varices. But beginners may confuse them. That's the problem. You should take into account. You should not put into the tansiyonumuz stabil mi? Şöyle tutalım. Near complete eradication.
Yes.
And you have seen the system. Now we are going to check with gastroscope. Tamam. Çok iyi. Çok yararlı olur. Karbondioksit. Karbondioksit. Bir de water jet. Karbondioksit diyor. Karbondioksit gitmiyor. Gitmiyor. No bleeding at the moment. No bleeding either from fundus and esophagus. You see, there are fairly large varices. So we go through these varices with 19-gauge needle, but no bleeding. Now, my friends are going to, or I am going to do it here. I must do a band ligation as well here, quickly. Band, please.
You prefer in the same session?
Yes, in the same session. Because the patient is intubated, I do not want to let the patient have another session. Hadi bant çabuk çıkarma, çıkarma bant. Çok çabuk. Any question for this procedure?
Yes, very good job, excellent. Just a question. I noticed that the coil is pre-made. It is already located inside its applicator. Is there another kind of coils which can be introduced by the nurse, or the coil is pre-made inside its applicator?
Sorry?
As we see, the coil is already loaded.
Yes, in the applicator, yes.
It's pre-made. It is pre-made, and this is very easy to apply.
Yes, yes, of course.
Yeah.
If somebody do it for 2 or 3 times, it is easy. But don't forget, your scope should be completely straight. You go away from patient, and then you put it completely straight position. At this time, the gentleman or lady who is holding the scope is very important. Here there is my assistant Burhan. He is very experienced man. So he grasps the scope and he keeps the same position. Otherwise, if you lose the position, the needle will damage the mucosa.
Yeah, yeah.
Sometimes some doctor prefer forward scope US from Olympus. In forward scope EUS. in coil application. It seemed to be easier than side view, or
I do not have any experience with forward viewing, but I think that forward viewing is not better than linear, because in esophagus, if you have a linear, then you would negotiate with the wall better. So I think that forward viewing is not better than side viewing, if not worse. Tamam mı? Ucuna kadar geldi şu. Tamam. Endoskopik görüntü. We never perform band ligation for fundal varices. It is very risky.
Yes, very risky.
And one of my patients actually bled to death because of this. After that time, I didn't use band for yes, that is the end of the procedure. Now we are going to go on with another interesting patient, an obstruction of bile duct at the level of hilum. This is either Mirizi syndrome or Klatskin tumor. We are going to perform EUS. Then probably, if this is Klatskin tumor, we are going to administer radiofrequency. Hastayı direkt olarak yoğun bakıma göndermemiz iyi oldu. Çok. Sandostatin devam etsin. In order to be on the safe side, for these patients, you would start somatostatin or octreotide 1 day before. And if you have, you would administer 2 milligrams of gliperesin 2 hours before procedures. These are not standard ways, but if you do this, the risk of bleeding will be less. This is my personal advice.
Even if the patient was not bleeding at the admission?
Sorry? No, even if not bleeding. For example, you admit the patient for an elective coil embolization without bleeding, prior bleeding, or very risky varices. In these cases, my advice is that you start somatostatin or octreotide 1 day before, and then 1 shot of gliperesin 2 hours before procedure. It will decrease the risk of bleeding. This is not an evidence-based data, but I sometimes do this, not always.
Yes.
About the next case, Dr. Akan, you inform us that Klatskin tumor and?
The next case is an case with painless jaundice, appeared a few days before, and CT examination. CT, could you please open the PowerPoint? Orada PowerPoint. Orada PowerPoint'i görmek ya da kameraya PowerPoint yansıtılabiliyor mu? Anyway, kalsın. Çok önemli değil. Yok oynama. Şunu bozulur bir daha. Boş ver. Kalsın. Okay. The patient presented with painless jaundice and computed tomography showed there is an obstruction at the level of bifurcation. But because the patient kalabilir o, sorun yok. Because the patient has gallbladder stones as well, the radiologists say it may either be a Mirizzi syndrome due to gallbladder stones or Klatskin tumor. However, I believe that this is the possibility is that this is a Klatskin tumor. I do not know. Now we are admitting the patient.
Yeah.
Alıyor muyuz?
ERCP, yeah.
The coil price in Turkey is at the moment how much euro one coil? We have a very good gentleman, Kadir. Come, Kadir. Kadir is a very able company representative. He is providing this coils to us to a very good price, $100 per coil.
Yes.
100 coil per $100 per coil. But now the other companies are providing it with which price?
19.
Kaç liraydı Türk lirası olarak? 3500 lira demiştim.
Ha 3500 lira evet.
Yani ne kadar yapıyor? Kaç dolar?
Kaç dolar yapar hocam?
They
500 dolar geçir.
in Egypt,
There are some coins from other companies up to $500 per coin.
Only one.
Cook company is very generous.
they have a branch here in Egypt, Dr. Hakan.
Sorry?
They have a branch, this company, in Egypt or only in Turkey?
No, Cook company. Cook company is producing this. Boston Scientific is also producing, but the prices from Boston Scientific is too much in comparison to Cook.
Only $100 for each coin. Only $100.
$100 from Cook company per coil. $100. Boston Scientific $250 per coil. Terumo, Japan, $350 per coil. So it is a costly procedure anyway. If you put, say, 3 coils, it would be $300 only for coil.
It's very cheap. But in Egypt, much more costly than that.
Sure. But it is very effective, you see.
The comment. Mazen with you. Hello?
Hello? Yes.
You hear me?
Yes, we hear you.
Mazen with you. Mazen with you. You hear me?
I hear you, yes.
Yes. Did you use the coil without histoacryl?
Hussein, would you please tell the question to me? I cannot hear it very good.
He asked about the same question which asked about before. If you add histoacryl, it is better or only coil?
Actually, histoacryl, coil plus histoacryl is not superior to coil alone. But histoacryl without coil is not as effective as coil only or coil plus histoacryl. So the best method is only coil without histoacryl.
There is a study which proves this is very effective, like histoacryl, because it blocks the gastrorenal, the splenorenal shunt.
Yes, of course. There are too many studies proving the efficacy of histoacryl. But you see that there is another problem with histoacryl, which is that it is a sticky substance and it may damage the endoscopes. That is another concern.
Never to damage the scopes.
Yeah, if you are very experienced, it may not happen to you, but it may happen to others.
Yeah.
Anyway, for an endoscopist, I think the best treatment method is the method that the endoscopist is familiar. So if you are very familiar with histoacryl, and if you are having good results, then it is better to go on with histoacryl. But because I am more experienced with coil, I prefer coil. Tomorrow, in the lecture about vascular EUS, I am going to present the data about this, and we are going to discuss. But of course, do not take this as an evidence that coil is better than histoacryl. You may be right. Coil may be as histoacryl may be as effective as coil. But this is a new emerging technique. I think in the future we are going to have better results.
Okay.
And anyway, another important point is that in the future, probably we are going to use coil as an EUS specialist for other areas. So if you are already experienced with coil, you will indulge in this area. But if you do not have experience with coil, you cannot catch these developments, because probably a few years later, we are going to perform most of the procedures the interventional radiologists are already performing. So if you are enough experienced, that will help.
You know, I am from the old school. I'm from
Our
the old
patient
school.
is becoming ready.
Professor Hakan,
yes.
There's a question from the floor here about the EOS vascular intervention, the last case. They are asking about if there is a recurrence of bleeding from varices after coil insertion.
Actually, as I said, I am going to reveal this data tomorrow. In 2 out of 25 patients, I think, we have had ongoing bleeding due to coil. One of these patients presented with acute bleeding. The coil did not stop the bleeding. We performed tips, but it did not effective as well. And the patient died because
You will not reveal all information until your lecture tomorrow.
Sorry?
Say that it could happen, but we will not reveal all the data until your lecture tomorrow, so that people can.
Yeah, I am going to reveal it tomorrow. But in general, we repeat coil after 6 months. So it does not mean that coil would eradicate the varices infinitely.
Okay.
After 6 months, we perform another EUS, and when we find remaining or recurrent varices, we also administer coils. This is something like variceal ligation.
Okay.
If you do it, you would not say that it's okay, there is no more procedure.
So follow up after 6 months, then re-evaluate if the patient.
And if necessary, put some other coils.
Thank you.
Yes, please. Evet.
Dr. Hakan.
Yes.
You start, or you can ask another questions, or?
Yes, please. We have time.
As regard coil, it's used only in variceal, in varices, or sometimes in other region like blood supply the tumor to obliterate it in EUS.
Yes. Tomorrow in the lecture, I am going to talk about this. You can put coil.
But at the same time, with any type of bleeding, you can put coils. For example, the feeding cancer of gastrointestinal squamous tumor. So any area that interventional radiologists are performing embolization, in most of the time we can perform it.
Sorry, the voice is not good quality.
Yes, I think because of my mask. Now is it better? What about the quality of voice now?
No, no.
Mikrofonu yukarı alsın.
The problem, I think.
Okay, I am going to fix it. Don't worry.
That's okay now.
Yukarı.
Put it.
Yes, I am going to do it.
Superficial to the mask.
Yukarı. Ha.
The field.
Şunun üstüne. Yes, is my voice okay now?
Yes.
Very nice.
Very nice.
Good. Okay. We start with US first for this patient. EUS ekranını alın çocuklar. 1 numara. Actually, I put off my mask because I have had 2 shots and 2 weeks elapsed after the second shot, a Chinese vaccine. So I believe that I am immune against COVID, but I am not sure. Evet, kafasını bana gönderelim. Hadi. Evet. Çocuklar yalnız şurada biraz şimdi onu bırakın da şu şeye yardımcı olun. There is a problem with the patient's spine, so it is a bit difficult. Dönmüyor. Çocukları biraz döndürmemiz lazım. Şöyle. Jel versene. Jel ver dedim.
Azıcık çevireceğiz çünkü boynu dönmüyor.
Evet, boyunu döndürün bu tarafa doğru. Biraz daha. Çocuklar hadi. Ha. Tamamdır, oldu. Tamam, şimdilik tamam. Şimdi yüzüstü alabilirsiniz, sonra endoskopu sokarken de aynısını yapın. Sorun değil. Şimdi büyük ekrana şeyi alsınlar. Çocuklar 1 numaralı görüntüyü ortaya alın. Büyük. Diğer endoskopu kapatın. Yalnızca 1 numaralı görüntü ve yukarıda da ben. Hadi. Now ses çok az olsun. Ses çok az. You see intrahepatic biliary tree is highly dilated. Actually, this is a very good case for hepaticogastrostomy anyway. There is significant dilation. We are at the level of 50 centimeter. We do 130 degree clockwise rotation. We see the pancreas. Pancreatic duct is not dilated. Now we inserted the scope into the second part of the duodenum. We are in the second part of the duodenum, aorta, and we are slowly withdrawing.
Professor Hakan, you are working in the left, right, and right, left?
Yes. Şu çocuklar şuraya al. Bak kamera. Nerede kamera? Geç şöyle. Şuraya çabuk. Biraz geri çek sen de. Heh. Evet, tam şu hareketi göstereceksin. Now we are at the head of the pancreas. We see the pancreatic duct and papilla vateri. Ok. Hadi Basri geç şöyle. Papillayı göster. Pancreatic duct is not significantly dilated, so it means that the obstruction is not due to pancreatic carcinoma or papillovatary carcinoma. And you see, I cannot see a dilated common bile duct. Actually, the common bile duct is very narrow. Ok nerede? This is common bile duct, and you see there is a collapse of common bile duct.
So it is hilar obstruction.
Yes, it is. Now we are quite sure. This is common bile duct here.
Yes.
Oh. Common bile duct is completely collapsed. So in this case, we may experience some difficulty in cannulation because the common bile duct is not enough dilated. So if we are not able to perform it, then probably we should go with US guided procedure.
But in ordinary or on the everyday life, you'd like to try first trial of ERCP, and if failed, then US guided, or you shift to AUS guided from the start?
No. Of course, we are going to first perform ERCP in any case. We are going to check for common hepatic, but as I see, even common hepatic is not dilated. So this is a hilar stricture. Now we withdraw the US scope and we go on with a pentax duodenoscope.
Yes.
And after we perform contrast injection, we are going to take the view of Cumhur. Cumhur, could you please come here? What is your experience with such kind of Klatskin tumors, which are high? I mean, not type 1. Okay, you go.
These kind of tumors, of course, are so aggressive, and in such cases, we are commonly the patient's presence with unresectable stage.
What is the criteria of unresectability?
There are many criteria for this kind of tumors, but for example, we classify these tumors with bismuth class 1, 2, 3, 4, for example. Bismuth tip type 4 class B tumors, for example, are we decide these tumors are unresectable, inoperable. There are many factors about these Klatskin tumors. For example, the liver's position,
age of the patient,
age of the comorbidities, the liver status, is there any cirrhosis, or the structure, vascular invasiveness.
So at the end of the day, only a fraction of these patients are suitable for surgery.
Yeah.
Okay, so we start. Endoskopi ekranını karşıya alın arkadaşlar. Endoskopi ekranı büyük, biz küçük. Şimdi sırt üstü alabilirsiniz. Çocuklar. Evet, alayım endoskopu. Şimdi ekranı 2'ye bölün. Sola 3'ü koyun. Buz kopan yapalım. Hadi. Ekran. We are using a microtech sphincterotom. Geldim. Küçük değil, ikisi de büyük. İkisi de büyük. Tamam, okey. Buz kopan yaptık mı? Tamam. Sen bıraktığın yerde tut tatlım. Ne oldu? Çocuklar 3'ü sol. ya. Azalt biraz. Ha. Şimdi devam et. Geri. Evet, devam et. Gel biraz daha. Gel.
If I can.
Yes.
Sometimes make a decision of from the start, try for some time. As regard knife pre-cut, as regard the looking of the papilla.
I generally do not prefer pre-cut in not non-dilated common bile duct actually. Yes, geri al. Bak attırıyorsun. Beni de bir çağırın çocuklar. Hadi.
We think this papilla may need that from the start, or what's your opinion about the looking of papilla?
You see, the common bile duct is totally collapsed. So in this case, you cannot expect an easy cannulation. Şimdi sevgili arkadaşlar, bu hastayı koruma alabilir miyiz? Yüzüstü koruma. Ama boynu dönmüyor, öyle değil mi? Sizin için zor olur yani. Evet, boynu dönmüyor. Pozisyon çok kötü. Efendim?
Ben biraz böyle pozisyonda alttan
Olur, olabilir belki. Yes, for this patient, we are going to opt for hepaticogastrostomy. Ona yazsanız hepaticogastrostomy. Tamam. Hepaticogastrostomy ona. Hadi. Hazırlayın. Evet. You agree for hepaticogastrostomy for this patient? Yes. Because the patient is high jaundice. Anyway, jaundice should be managed. Kaç yaşındasın? Okay.
Önce git ona yaz.
74 yaşında.
Tamam, tabii. Evet, scope. Evet. Yas hastayı biraz şu tarafa çekin. Bakın o taraftan scope'un şeyine yaklaşıyor. Ha? Şu tarafa doğru. Tamam. Biraz daha. Biraz daha bu tarafa. Tamam. Şimdi biraz yan döndürelim. Hastayı da biraz şu tarafa doğru itelim. Konsolu kullanmam gerekiyor. Şurayı açalım. Şunu da açayım. Kilitli mi bu?
Bir saniye.
Şu kilitli mi? Şu.
Onu açayım bir saniye hocam. Şu hastayı iteyim biraz.
Tamam, böyle iyi. Dur. Karbondioksit değil mi ya?
Evet.
Tamam.
Hastayı
Evet.
hafif şuradan
Jel.
yanına geçsek yeterli. Böyle yeterli mi?
Çok güzel. Ses olmasın. Hasta kolesistektomisi mi? Tamam. Scope. Aletin ucu. Deniz. Şu şeyi ayarla. Doppler'i Basri.
Basri Bey buyurun.
Doppler'i ayarla.
We have the ultrasound image.
Ultrasound imajını koysanıza ya. Ne yapıyorsunuz? Hadi. Aşağıya. Biri sola alın. Biri sola alın. Niye ayarlamıyor? Ha? Ya çok düşürmüş. Satmışsın bunu. Tabii ki ayarlamıyor. Ne bu? Tamam, şimdi oldu. Ayşe git karşıya aleti tut. Tamam, sen bir bırak Burhan şimdi. Gel. Dikkatli. Şöyle. Ver 19 iğneyi. Şöyle. Onayı aldınız mı? Atilla nerede?
Professor Hakan, this is segment 3?
Segment 3, yes.
Yes.
Şöyle.
You are now about 42 to 45 centimeter from the dental arch.
45, yes.
45, okay.
Emin misin? Evet. Yalnız tam yazılı olarak alın da. Yazılı olarak alın, öyle haber verin. Çabuk biraz. Sık o. Kalp pili mi var bunda? Ha, tamam. Tamam mı Atilla? I am waiting for the consent of the patient's relatives. İmza tamam olunca söyleyin. Şöyle. Ha. Tamam mı? Sizinle ne yapıyor ya? Evet. Evet. Yes, now we are in. We first aspirate bile. Ayşe çok dikkatli. Bak şöyle görünecek şu tatlım, bak şu ucu görünecek. Ha. Evet. Bile is coming, you see. Ekran, kamera şuraya geçsene. Hadi. Şunu göster.
Yes.
Yes, the bile is present. Al onu.
It's very clear.
Yes, contrast.
The screen is not there.
Sorry?
The screen is not there. We want the screen.
Screen, yes. Scopy screen'i. Sola Scopy'yi alın. 3'ü alın. Bizi yukarı alın.
Yes, yes, very nice. Screen is there now.
Buyurun. Bir dakika şunu da geliyorum. Peki, hadi bakalım. Yani bir dakika bak, şimdi orada nereyi göreceğiz? Aşağıyı görmemiz lazım. Ayarlasana Aysel. Hadi yukarıya. Evet, devam et. Kayda devam et.
What is the type of the wire? 0.035 wire or
0.35.
0.35. Okay.
Sure. Evet. Now it is turning in the dikkatli ol. Biraz geri al. Tamam, devam et. Geri dönüyor. Ne oldu? Aynı alanda dönüyor. Dönsün peki. Orada iyi yerde. Yok, hiç da değil aslında. Biraz geri alayım. Tamam. Şimdi geri al biraz. Devam et. Ucu mu kaldı orada? Ne oldu? Evet. Peki başka bir guide koy o zaman. Şu an bekliyorum. Başka bir guide koy diyorum ya. Evet, al. Hadi. Biraz daha kontrast ver. Ver. Doldur, doldur, doldur, doldur, doldur, doldur, doldur, doldur, doldur. Devam et. Şimdi guide'e devam et. Hadi dikkatli ol. Geri çekme. Evet, devam et. Ya anladık. Görüyoruz herhalde. Devam et. Tamam. Bir dakika bak. Attırırsarsın şimdi. Geri gittim. Bekle biraz. Şimdi geri al, geri al. İçini çek. Çek, çek. Ha. Bekle. Şimdi devam et. Devam et. Tamam, çok güzel bir şimdi. Devam et. Geniş olan yani.
Evet, orada
Tamam.
loop yaptık.
Tamam. Çekiyor.
Tamam.
Evet. Dikkat et, tutturma. Şuradan o gayeti görelim çocuklar. Bak gayeti göster. Bak gördün mü gayeti? Ayşe. Ha? Dikkat et gayeti. Devam et. Devam et. Devam et. Yok yaptırmadan. Now we are removing the needle. Scope'a bas. Bak gayeti göreceğiz diyorum ya. Oynatma yerinden. Şu gayet bak sol sağ üstte. Devam et. Keyboard koyacağız. Devam. Devam. Devam. Now we are going to dilate the track with 6 Francis open.
The wire went to the CBD or to the right side. I didn't see it well.
Left side. It is still in the left side, I guess. Maybe right. Yeah, you are right.
Not yet went to the CBD.
Yes, CPT is not present because you see, CPT is totally collapsed.
Stricture, yes.
Evet. Şöyle. Şu en iyi pozisyon. Ha? Evet.
This is a 6 branch cystotome?
6 branch cystotome.
Yes.
Yavaş. Skopa bas. Skop. Hiç çekme. Deniz sakın loop yapma. Extreme fail. Ayşe çok güzel. Sen gözünü oradan ayırma. Senin gözün orada olacak. Geri al. Geri. Yes. 6 branch cystotome here. Hazır. Skop. Yes. We are in. Öyle değil mi? İçerideyiz. Tamam. Çekiyorum. Artık kontrast vermeye gerek yok. Evet. Gözünü oradan ayırın. Evet. Ona 8. Geoportallardan emin miyiz? Şöyle tatlım. Şu görünüyorsa ters sağ yukarıda sorun yok. Hadi. Evet. Sık ol. Topa sürekli bas. Sen o yeri kaybetme. Geri, deniz. Geri. İyice kıvrıl orada geri.
لازم المنظار يبقى لازق في الميكوزا.
Geri.
مش
سكوبا بقى.
هتشوفوا اخر مرحله خالص لما يعمل ديبلويمنت للبروكسيمال ستنت ويبتدي يعمل ديبلويمنت.
Yes, now the stent is in. We open it slightly.
ده طرف السيستوتوم اهو.
Şimdi EUS görüntüsünü kaldırın. Sağ endoskop görüntüsünü alın. Şurayı. Kaç numarası görelim. Aç.
ده طرف السيستوتوم.
Bir kısmı içeride değil mi?
على الايدج اوف ذا ليفر دلوقتي.
Tamam.
باين في
İçerideki kısmı
يعني تزق جوه شويه.
Yeter. Bir kısmı içeride değil mi? Şu orta mı gördüğün?
Şurası orta. Bir şurada hocam.
Emin miyiz?
Evet.
Tamam peki. Tamam. Peki. Peki. Bir dakika.
كده اتعدلت
Evet. Şöyle. Aç. Bekle. Yok çok güzeldi.
ده دكتور فهمي بقى اللي هو الديستال.
Aç. Bekle. Aç. Bekle. Şöyle. Aç.
Bekle. Aç. Aç. Aç. Aç. Aç. Yes.
Yes.
You see it is training.
Yes, yes, very, very excellent, very nice. I see this is a fully covered stent,
No, partially.
partially covered stent,
Yes, partially covered.
or one half and a half, or two-thirds and
No,
one
no, no. Partially covered.
partially covered stent.
So the 8 centimeter, 6 centimeter is covered, and proximal and actually 4 centimeter is covered. 2 proximal and 2 distal is open.
Yes, here you leave a longer part inside the stomach, at least 3 to 4 centimeter inside the stomach.
That's böyle bir görelim.
Professor Hakan.
Yes.
I'd like to ask question. When you use partially covered stent, then you should leave at least 3 to 4 centimeter inside in the stomach.
Sure.
Stomach.
3 centimeter.
At
But
least.
I think not 2 centimeter, but 1 centimeter is open, I think. 6 centimeter is covered. 1 proximal, 1 distal is open, not 2 centimeter.
At least 2 centimeter inside the stomach.
Actually, in stomach, at least 2 centimeter should be left.
And,
better 3 centimeter.
and this 10 centimeter or 8 centimeter length? Partially covered 8 centimeter or 10 centimeter?
Partially covered 8 centimeter.
8 centimeter.
Yes.
Hmm.
Görüntü alalım. Sık olsun. Yes, you see it is, şu görüntüyü alsanıza çocuklar. Endoscopy. Ben orası aldım yani. Endoscopy'yi bir göster. Endoscopy. Tamam, yerinde öyle değil mi? Ha? Ya tamam, şimdi böyle. Okay, now we completed the procedure. Do we have a time for next patient, Hussein? Do we have time for one more patient? Hussein?
Yes, yes, I'm with you. Very nice job, perfect.
Do you want another patient?
As you like. It's still half an hour. As you like. You did a lot of cases, very interesting cases.
This case is the most interesting one. Okay, then take this patient. But I think it would be for 1 hour. Is it okay?
Okay.
Good. This is a pancreas case.
Yes.
4. sıradaki. Hakkı Yaman. Any question? So in this patient, that was a very high level stricture. Jumhur, would you please come?
Yes, but I am a little bit surprised that you are using partially covered stent, because Japanese are always using totally covered stent, and some European countries are using G4 or half and half. So it is partially covered stent. It is very nice and cheaper.
Yes, yes, it is cheaper and it is halfway. The problem with the fully covered is that when we administer fully covered, because the
distal part, the part in bile duct, may be stuck to the wall of the lumen and it may not drain. That is the problem. Chumur, you have seen that when we injected contrast to the left, so we couldn't demonstrate common bile duct, and even a part of right, probably. I couldn't be sure. So it is a very high stricture at the age of 75.
Yes.
So I think this is not a good candidate for surgery.
Yes, of course, because as we know, the surgeries, the classic tumor surgeries are so morbid, high morbidity and high mortality, huge liver resections and more complicated resections. So it must be a fit patient. Unfit patients are not good candidates. So these procedures are more suitable, I think, as you.
Okay, so the next patient, we are going to have the view of Dr. Chumur as well for the last patient. The last patient is a patient with pancreatitis. This is a bit unfortunate patient. He presented with pancreatitis and there was cholecystitis as well. Percutaneous cholecystostomy was performed. But while the patient was waiting for surgery, the patient has had another attack. Am I right? Okay, another attack. And that was a severe pancreatitis, extrapancreatic necrotizing pancreatitis. Some collections developed, and now the patient CRP level is very high. There are some large collections. We are going to check whether these collections are suitable for drainage.
Yeah, okay.
Multilocular collection or multiple collections, peripancreatic.
The radiology says that all these collections are connected. Just 4 weeks have elapsed between the pancreatitis attack and collections. So this is just the right time, if not early, for drainage. But I am going to show you this is not an easy case, very, very difficult case. So we are going to do something other than simple drainage, because you are going to see it as something very complicated, and it is at the head of the pancreas.
No. There is a probability that you will introduce multiple cystogastrostomies.
We are going to see. We are going to see. Yeah.
Yeah.
When do you think we are going to have face-to-face meetings in Cairo again?
It's just an airplane away. Come now, you will meet us. In fact, there is a good number of attendants here, and they are all watching the live demonstration from Turkey, and before that from Hamburg, and then before that from China. And they are very interested and they are asking a lot of questions. And I think it's very nice. And let's hope that this would be live and face-to-face soon, inshallah.
But these cases are very variable. The previous transmissions from China and are all poem and endoscopic cholecystectomy. So there are all third space maneuvers. In Germany, it was poem and polypectomies. So these cases are.
So we completed.
Very good. Yes.
Yeah.
And also including US, and this will be very interesting to me at least.
But I congratulate Mohammed Nagib and Ahmed Murat for their invaluable work. They worked very hard for this meeting, I guess.
Yes.
Thank you, sir. Maybe the next the meeting, the face-to-face, would be in Istanbul.
Yes, of course. But I think we should schedule it for at least at the end of the year. Otherwise, you see, the cases are undulating. Today they say it is decreasing, tomorrow they say it is increasing. So I think biraz çabuk olalım arkadaşlar. Sercan, hadi hastayı alın. Nerede hasta? Çabuk. Hadi gidin siz getirin, çabuk olun. Actually, I am not sure when we are going to be able to travel. What do you think, Cumhur?
when we are going to go. Actually, the interesting point is that the last time I have a flight in just these days, in the last year, I traveled to Cairo for this meeting.
Oh, yes.
So that was my last meeting and last air flight.
I think this will will go on at least 1 year more.
1 year, yeah.
1 year for me, yes.
So until the end of the year, so it is not possible
Because
to
the
have.
mutations do not stop, so we vaccine, but the mutations are going on, so it won't last for 1 year exactly.
طيب على بال ما الدكتور حكام طبعا يعني حابب طبعا ان انا ابلغ حضراتكم ان هو الناس اللي معانا في القاعه او الناس اللي معانا على اللايف سواء على الصفحه على الفيسبوك او على اليوتيوب او على لينك الزوم ان احنا ان شاء الله باذن الله هنبتدي بكره المؤتمر الساعه 9 الصبح. هيبقى عندنا 3 كورسز بوست جراديويت كورسز هيبقوا شغالين ان باراليل الصبحيه. كورس بتاع ترانسبلانتيشن ده غالبا هيبقى هنا في القاعه الرئيسيه، وهيبقى عندنا كورس بتاع الترا ساوند. الحقيقه الدكتوره منى امين عامله كورس بتاع الترا ساوند يعني متكامل وفيري انترستنج وجميل جدا جدا، وده ان شاء الله هيبقى في قاعه كيلوباترا اللي هي الناحيه الثانيه. وهيبقى عندنا كورس ثالث بتاع تولز اند ايكويبمنت عاملينه انا والدكتور محمد البرعي، ومعانا كل الاساتذه بتوع الاندوسكوبيز اللي انتوا يعني تعرفوهم. وده هيبقى في قاعه عايده اللي هي برضو الناحيه الثانيه. بعد كده ان شاء الله بعد الكورسز دي اللي هي هتخلص الساعه 10:30 هيبقى عندنا الجلسات طبعا بتاعتنا. هيبقى عندنا جلسه دوز اند دونتس بتاعه الجي اي تي بليدنج، وطبعا دي هيبقى فيها الدكتور مازن والدكتور مجدي دهشان والدكتوره حنان نوح والدكتور علي فرج. بعد كده هيبقى عندنا جلسه فروم هيريتج تو ليجاسي في الهيباتولوجي، والجلسه دي هيديرها طبعا دكتور وائل عارف، وهيبقى فيها كلام طبعا عن الهيباتولوجي عموما وعن الاتش سي في واز ات ذا اند اوف ذا ستوري والهيباتيتس بي والاند ستيج ليفر ديزيز واتس بيوند الترانسبلانتيشن. برضه هيبقى عندنا جلسات ليها دعوه بالانفلاماتري باول ديزيز وكيسز هتبقى متقدمه. هيبقى عندنا ريفراكتوري جيرد، هيبقى عندنا ابديت في التريتمنت بتاع الارثريتيك كولايتس، هيبقى عندنا دوز اند دونتس في الهيباتيتس. الجلسه دي فيري انترستنج فيها حاجات متنوعه كتيره جدا جدا عن الهيباتيتس. هل لسه المفروض ناخد ليفر بايوبسي؟ اخبار البورتال فين ثرومبوزيس ايه؟ ازاي نقدر نتعامل مع الحالات المزد بتاعت الاوتو اميون هيباتيتس؟ الناس اللي عندهم اسيمتوماتيك اليفيشن بتاعت الترانس امينيزز، الناس اللي بيجي لهم كولي ستاتيك برورايتس، الحالات دي بيبقوا الناس دول بيبقوا صعبين جدا. كلها حاجات كلها ابلايد وبراكتيكال. هيبقى عندنا يعني جلسه برضو فروم هيريتج تو ليجاسي في الاندوسكوبي، والجلسه دي هيبقى فيها حاجات
Burada birisinin lecture'ı mı var? Şey kapalı mı siz?
زي الديسبوزبل اندوسكوبس زي الاندوسايتو مايكروسكوبي. هيبقى عندنا برضو يعني كلام عن جلسه كامله عن السينما. كيسز هتبقى يعني معروضه لحضراتكم. وهيبقى بعد كده عندنا جلسه كونتيننتال فيليج هيبقى فيها بقى دكتور حكان، وهيبقى فيها دكتور جوفانيني، وهيبقى فيها الدكتوره وفاء الخنوسي، وهيبقى معانا الدكتور محمد عثمان من امريكا، وهيبقى معانا كذلك الدكتور ميكائيل هافنر من النمسا. بعديها ان شاء الله من الساعه 8 للساعه 10 هنرجع تاني للجلسات الباراليل. هيبقوا في 2 سيشنز باراليل في كل قاعه من ال3 قاعات. الناس اللي انترستد في الهيباتولوجي هتلاقي جلستين هيباتولوجي ورا بعض. الناس اللي انترستد في الجاسترونترولوجي هتلاقي جلستين جاسترونترولوجي ورا بعض. الناس اللي انترستد في الاندوسكوبي هتلاقي جلستين اندوسكوبي ورا بعض. فهيبقى عندنا مثلا في الحته بتاعه الاندوسكوبي هيبقى عندنا يعني جلسه بتاعه الثيرد سبيس اندوسكوبي مع التيم بتاع البويم والاي اس دي والاي ام ار وكل بقى الحاجات دي كلها. بعديها هيبقى الدكتور حسين يعني عامل جلسه فيري انترستنج عن ال اي او اس هوت توبكس مسج ان فيديو. يعني الفيديو هو اللي بيقول لنا الرساله اللي احنا عايزين ان احنا نتعلمها، ودي هتبقى في القاعه الرئيسيه. في قاعه 2 اللي هي قاعه عايده هيبقى في عندنا نيوتريشن في الجي اي تي، وهيبقى عندنا مالتي ديسيبلينري سيشن بتاعه الجي اي تي مالجنسيز. وفي قاعه 3 اللي هي كيلوباترا، دي هيبقى اللي هي بتاعه الهيباتولوجي. هيبقى عندنا ابروتش تو هيباتيك فوكال ليجنز، وهيبقى عندنا acute on top of chronic liver cell failure. يعني اتمنى ان البروجرام بتاع بكره يعني اكيد يعني يلقى يعني متابعتكم واعجابكم. اللينكات بتاعه الثلاث قاعات للناس اللي هي حابه ان هي تحضر معانا برضو فيرتشوال هيتحطوا النهارده على الصفحه بتاعتنا على الفيسبوك وعلى الجروب بتاع التليجرام، وبرضه هنحاول نحطه على الواتساب على الجروبات بتاعه الواتساب. وطبعا بالنسبه لحضراتكم طبعا اللي حابب انه يجي يشرفنا هنا في الفندق طبعا في اتندنس، ولكن طبعا مع مراعاه التباعد الاجتماعي وطبعا التعقيم والماسكات، كل الحاجات طبعا اللي حضراتكم طبعا عارفينها كويس جدا. نتمنى ان شاء الله يعني ان المؤتمر يكون ناجح بيكم زي كل سنه، ونشوفكم ان شاء الله على خير.
Patient is ready, is almost ready. We are also administering general anesthesia. As I said, this is a complicated patient. The problem is that you are going to see in US, the collections are not perfectly amenable for cystogastrostomy. So there is considerable amount of necrosis, and we are going to see what we are going to do. Probably the significant part of collection is just in the head of the pancreas, isn't it, surgeon? The significant part is in the head of the pancreas.
Actual CT scan also and collection at the end of the pancreas between the
Okay. So there is a collection between spleen and pancreatic tail as well. Yes. Okay. Orada da var yani.
What's your plan, Professor Hakan, for this case?
We are going to devise the plan together.
So you will demonstrate it, and during the demonstration, we will see what's going to happen.
We are going to decide.
Okay.
Gözlük neredeyse. Hazır mıyız? Aysel. Aysel nerede? Gel. I am going to introduce you two of my nurses. Come here. Aysel and Ayşe, they are very valuable part of our team. They are very experienced. Aysel and Ayşe, a very familiar name for you. They are fully experienced in any area. Without them, actually, I cannot do anything. And I thank to them.
together. And Deniz, where is Deniz? The chief nurse.
I heard about them too much from Dr. Ahmed Murad.
Sorry?
I heard about your top nurses.
Yeah, okay.
What?
I think Ahmed Murad explained to you with his literary ability, so I think he will make a story out of this. He's a literary man.
We should thank them
Ahmed Nagib.
for their efforts.
Tamam. Yes, başlayalım. Hazır mıyız? Scope'u da çekelim. Evet. Evet, kafayı bana doğru döndürelim çocuklar. Ekranı 1 numaraya alın. Now we are at the level of 45 centimeters, and there is a collection here. But you see, the collection is not well defined. So I am not sure this collection is amenable for drainage because it is not demarcated. What is your opinion, Hussein? You see the collection?
Yes.
But not defined, not demarcated. There are small bubble loops here.
Yes, and mainly necrotic. There is no much fluid.
Yeah. Çocuklar, Basri Bey, şu ok ayarlasana tatlım.
What about the
There are
imaging?
intestinal loops.
What about the CT and MRI, Professor?
Sorry?
The CT and MRI, what's the finding?
In CT, they say that there are several collections, but in CT, the collections are also not homogeneous. But if you only look at CT, you would consider that you perform a drainage. But in case you perform EUS, you see the picture is very different.
And for how long? For how long the patient?
4 weeks. 4 weeks.
4 weeks.
4 weeks from the second attack. Now we are in the second part of the duodenum. And on the right side, you see there is again a collection, a very large collection here. And there is air in it. So this is probably an infected necrosis.
But still, mainly necrosis. There is no much fluid to insert a stent. What do you think?
Actually, in this case, in this picture, I do not perform cystogastrostomy
Yes, exactly.
because it is not a good option. Now we are going to check with duodenoscope. Better we can do something with pancreatic cannulation. Probably pancreatic duct is distracted.
Yes. Professor Hakan,
yes,
you prefer pancreatic duct stenting if
yes.
the duct is dilated, or
if there is bulging in duodenum, probably I am going to perform a drainage without EUS, maybe. the old technique.
Oh,
If
but
there is bulging.
drainage cystogasttrostomy you mean, or through the pancreatic duct?
First, I am going to try through the pancreatic duct, but I don't think it will be easy to cannulate.
Yeah.
Papilla will be in a very bad condition, I guess. Evet. Şimdi çocuklar endoskopiyi alın karşıya. Yani 4 ve 3 numara. Yukarıya da bizi alın.
Is the surgeon still around? Your surgeon is still around?
Sorry. Biraz şöyle çekelim. Getirin. Tamam. Çok iyi. Şimdi şeyi de alalım. Şunu Deniz için bir uygun bir yere koyalım.
Professor Hassan.
Yes, please.
We still have our surgical colleague.
Sorry?
Our surgical colleague, your surgical colleague, still there?
I couldn't get, sorry.
The surgeon you have.
Third?
Your surgeon. What he thinks about it?
I am sorry, the quality of sound is very bad. I am really sorry. I cannot understand you. Ne diyor? Yes, okay. Cumhur, they are asking for your opinion for this patient. Could you please come?
This is a pancreatic necrosis collection. In this case, there is no need to make a surgical drainage. So if there is a...
Mikrofon var mı çocuklar? Evet.
If there,
Geliyor mu? Yes.
we now we perform this drainage process set up.
Excuse me, the voice now is, there's no voice. We don't...
Yes, can you hear me?
Yes, nice.
Yes, you hear.
Okay.
Yes, you hear now, okay? In
Mikrofon demiştim çocuklar, hadi.
We in the pancreatic necrosis and the peripancreatic collection, we don't perform surgical drainage at least in 1 month. If there is a need to drainage this collection, we first perform the step-up procedure. As well as if there is indication for the surgical procedure, then we do it. But this is very, very not common and uncommon in these days.
Now, on the right side of the endoscopic picture, you see the minor papilla. And in deep, you see the major papilla. And you see pus is coming out of the major papilla. You see the pus?
Yeah.
Yes, probably there is a fistula here. We are going to try to find the fistula.
Yes. And this explains why there is not much fluid inside the collections now.
Yes.
I think this may be a form of spontaneous cure. What do you think?
Sorry?
I think this fistula may be a form of spontaneous cure.
Spontaneous discharge. Yes, yes, spontaneous discharge. You are right. So it seems that before us, the organism's defense mechanism did something. There is significant edema. Bir
Yes.
toplama yapabilir miyiz arkadaşlar?
Yes. As if it is some form of groove pancreatitis.
Sure, exactly. There is significant edema. This is something like groove pancreatitis.
This will make ERCP rather difficult.
I am trying to find the level of fistula, but still I am not able to do so. The fistula must be here, very near.
Yes.
Bir şey alalım, therapeutic gastros, Olympus, yes, Olympus. We are going to take a therapeutic gastroscope. Olympus'u bağlayabiliyorsunuz değil mi?
Then Professor Hakan, Professor Ali Farag is sitting behind me and he's greeting you so much. Professor.
Yes.
Welcome, Professor.
Hello, Ali Farag. How are you doing?
He is now suggesting that if you found the fistula, would you like to dilate it or the enlarge?
Yes, dilate and put a very large stent, if I am able to find.
Okay.
But if I am not, I think I am not going to do something. Because I will do some harm rather than good for the patient. If I am not able to find. Şöyle hitemik pozisyon alabilir miyim? Şöyle. Pardon. Yaklaştırmadım. Tamam, şöyle çok güzel. Tamam. Bağlıyor muyuz şeyi çocuklar? Hemen. Bunu şimdi ortaya alın, bizi de yana. Bravo ya, saniyede hazırladınız. Tamam. Çocuklar endoskopiyi alalım karşıya. Now I am checking with an therapeutic Olympus gastroscope. But still, it is very difficult to keep the position in bulb. I am not able to find an opening here. Öyle mi? Evet. Buralarda olanı tabii gördüm. Endoscopy'da daha iyi görüyoruz. Olabilir. Evet, şuradan. Şöyle tutabilir miyim? Şunu. Şöyle. Burhan canım. Şöyle. Ver sıkıntı. Skopu karşıya alın çocuklar. Evet. Aşağı gitmediysen. Hadi. Görelim. Yok, aşağı gidiyor yani. Sezon. Biraz gelsin. Yok. No. Yok. Burası papilla. Şurası. Gelsene. Gel. No. With an forward viewing, it is highly difficult. Şurası olabilir biraz da. Şurası.
Professor Hakan.
Sorry. I am going to reply you in a moment. Gelsene. Geçti mi? Bassana. Kaydı bir devam et. Evet. Zaten şeyi kaçırıyor nereden ya? Öyle mi? Evet galiba. Evet. Öyle. Yok. Sırada mı değil. Yes, we are probably still in the lumen.
It's between the first and second parts.
Yes, this is the second part, yes. So we didn't went into the... We are going to try duodenoscopy again for the last time. Tekrar duodenoscopa geçelim arkadaşlar. Evet. Aspiratör. Burada aspiratör var zaten galiba. Bir eldiven alayım. Bir tane. Şöyle alalım. Biraz yukarı. Tamam, şimdi şu ekranı karşıya alalım arkadaşlar. 4 numarayı. Karbondioksiti açalım. Şunu çekelim geriye. Şunu silsem. Ekran çocuklar 3-4 numarayı karşıya alın. Karşıya. Yok. Burayı bir görmeliyiz. Spinkteraton versene. Aleti tuttu. Burhan aleti tut dedim. Ha? Evet. Yes, we are in now. This is the site of fistula, you see. Şöyle. Ha. Devam et, gayet içeride kalıyorsun. 12-15 balon dilatatör, devam et. Hüseyin, you see? You hear me?
Yes, yes.
Yes, now we cannulated these...
Fistula.
Tamam. Nerede gösteriyor? Aşağıda. Niye o kadar loop yaptı Deniz? Tam karşıda olması lazım. Dur bakayım. Çok loop yaptı. Bassana bir. Bas. Neyse tamam. Tamam. Bir dakika. Evet, şimdi tamamdır. Devam et. Loop mu yaptı aşağıya doğru yani? Şurası yok yapmamış. Bir dakika. Evet, devam et. Şurası. Devam. Çok güzel. Bu konumda tut. Devam et. We are going to dilate with 15 millimeter CRE balloon.
You will dilate the fistula's opening.
Yes.
How many millimeters you said?
15 millimeter.
Yeah.
Can we go through this and do necrosectomy afterwards?
If the situation does not improve, yes. Sure. Diğeri. Hastanın karnını da arasıyla kontrol edin. Diğeri denizsin. Diğeri. Geçti galiba. Geçirelim. Geçir. Önce 12'ye. Hadi. Evet. Devam. Bekle, bekle, bekle. Biraz geri çekmem lazım. Bas. Gayet iyi. Gayet iyi. Evet, gayet iyi. Evet, gayet iyi. Tamam, şimdi şişir. Evet. Devam, devam, devam. ...12 oldu mu? 15. You see the fistula now. It is very bad seen. Yeah.
Yes, yes, as usual, the tissues is very friable, so
Yeah.
dilatation.
Yeter, yeter, yeter. İndir. Devam et. Devam. Devam. İyice indir. Kaydı sakın kaybetme. You see there is a copious discharge.
Yes.
Devam.
Will you leave
Tamam.
that tail or just leave it like this?
Yavaş. Çokluk yaptım ben. Tamamdır. Devam et. Yes, because of the discharge, I cannot see the picture. Biraz bolus sıvı verelim. You see, because of the discharge, all the view was lost. Devam. Şimdi buraya 8'e 6 yarı kaplıyı koyacağız. Evet, yarı kaplı hizla. We check the abdomen of the patient, no distension. This is a Hizra stent. Today, it was the day of Hizra from Korea. Yes, this one. Show it. Hizra from South Korea, perfect stent. Artık para istemez değil mi? Very good price, cost effective. Deniz cimruk yaptırmadan Scopy'yi takip edeceğiz. Buradan çok fazla göremiyorum şu anda.
This is a metal stent, Professor Hakan?
Metal, yes. Partially covered.
Partially covered, yes. From Taiwan, South Korea?
No, from Hizra. is a South Korea stand. Bak Denizciğim çok aşağı gitti güzelim. Tamam yavaş. Yok. Tamam, devam. Ha, biraz devam et. Tamam, fark ettik. Orası iyi. Aç şimdi. Aç. İyi yaptın. Aç. Aç. Aç. Aç. Aç. Aç. Devam. We are opening the metallic stand. Bekle. Evet. You see the pus is coming through the stand?
Yes. Yes. Good work. Very good work. Excellent.
Yes, we completed this procedure as well. Thank you for your patience.
We are the one going to thank you. Very interesting cases, great cases. Very good work. Our congratulations to you and your team.
It was a pleasure to be with you. Actually, I consider Egypt as my first country, Turkey second country. I love Egypt and I am upset that I couldn't see Egypt for such a long time. You see, in a year, I used to visit Egypt for 10 times. I would like to introduce you our anesthesia team, Ismail and Mustafa. Would you please come? Ismail is anesthesia specialist and Mustafa is actually resident in anesthesia. He is a graduate of Bezmi Alem University. Today they did a great job. They helped me too much. Attila and Serjan, would you please come? These are the people behind the screen. Attila is my chief resident and Serjan is our fellow. They worked too hard. Deniz, the last but not the least, he is my chief nurse. Without Deniz, nothing is possible. And finally, I would like to, my special thanks go to Cumhur. Actually,
thank you very much.
In case Cumhur had not been here, I wouldn't be so courageous.
Thank you.
Because in any case, he is tolerating everything and he's trying to do his best.
No, thank you very much, sir.
And thank you very much for all the people who contributed and listened to this workshop. I am expecting to be with you soon. And again, thanks very much for this invitation. Tomorrow in the lectures, we are going to be together again.
Yes, lastly, and I'd like to thank you very much on behalf of the Congress, on behalf of Professor Mazen Naga, Professor Ali Farag, Professor Ahmed Murad, Professor Mohammed Naguib. Thank you very much for the nice 3 hours and 3 hours, 15-minute transmission. Thank you very much for the nice cases, very variable, very impressive. We benefited of it so much as usual. So I'd like to transmit our great greetings from us for your unlimited cooperation. And I'm always saying it is a pleasure and honor to see you anytime, any place, face to face or online. Thank you.
Thank you very much. Thank you. See you tomorrow. Çok teşekkürler. Neyse çok iyi geçti. Gerçekten problemsiz sayenizde. Benimle birlikte olman çok teşekkür ederim.
المؤتمر الورك شوب وان شاء الله
çok sağ olun. Eline sağlık. Görüşmek üzere. Çok sağ ol.
في اكتيفيتي عظيمه جدا، وشكرا جدا ان انتم
tam program
لغايه دلوقتي، يعني كرم منكم قوي اللي احنا نقعد لغايه الساعه 5:30 من 9 صباحا. شاكرين جدا ليكم. نعم. لو تحبوا ناخد صوره جماعيه ده يبقى كرم منكم، يعني شكرا جزيلا.